அது இப்போதைக்கு போடு, அதுக்கப்புறம் பார்த்து. சிங்கிள் சேர் டபுள் the flower was like this. Good morning, ladies and gentlemen. So, may I have welcome all delegates to the proceedings of the Cardiometabolic Congress. To chair the first session, may I now invite Dr. Pradeep Nair, eminent cardiologist, Chennai, Dr. Ilamaran, Professor of Cardiology from Stanley Medical College, to chair the first session.
Next week போய் கேட்கணும் அதுதான் சொல்றேன். அடுத்த வாரம் அவருக்கு போய் எக்ஸ்பீரியன்ஸ் பார்த்துட்டு பார்த்துட்டு எக்ஸசைஸ்லாம் ஜிம்ல ஜாயின் பண்ணலாமா அவருக்கு கேட்கணும். இதுதான் சொல்றேன். நெக்ஸ்ட் வீக் அவருக்கு அப்பாயின்மெண்ட் ஒரு வருஷம் ஆயிடுச்சுல்ல. ரைட் பா, இருந்தாலும் ஒரு நாளைக்கு முன்னாடி நான் என்கிட்ட கேட்காம ஏன் பண்ணேன்னு கேட்பாரு.
Morning everybody, and session today we are having three eminent speakers. The first is Dr. Vinod Kumar from SRMC. He will be speaking on the role of Dapagliflozin in patients with heart failure.
அவர் சொன்னாலும் சொல்லலாம் ஜாயின் பண்ணுப்பா. ஜாயின் பண்றதுக்கு இது சொல்றது.
Very good morning. Now welcome to the second day session. It's always a privilege to be on the stage. I thank Dr. Chandrasekhar sir for this wonderful opportunity. Today we are going to discuss on a wonderful drug molecule. It's traveled over 1 decade now. It's almost a decade now, full drug. But every day we are getting new indications for this particular molecule. And it has revolutionized the treatment strategy of both diabetic patients as well as cardiac patients. Though this molecule entered the field as a diabetic molecule, now predominantly used by most of the cardiologists, and it finds place in every cardiology prescription. So it is going to be inroading into other fields everywhere. Knowing this molecule is very, very essential, even for non-diabetic, non-cardiologists or any other, because one day you are going to get this drug in your prescription pill. We all know heart failure is a major burden. The number of heart failure patients is very high all over the globe, including India. So we are going to lose 50% of the population at the end of 5 years once they are diagnosed as heart failure. Very, very under recognized field. Because a lot of times we see we concentrate on myocardial infarction, stroke, IHT, we see a lot of decrease in the proportion of patients dying because of this disease over a period of time. But in last 10 years, people who have succumbed to heart failure is more, and for arrhythmia is also more. Similarly, what is the problem with the heart failure? Why there is a scope for new medication? What is really happening? It's not the patients on medications. It's a lifelong therapy, but we don't titrate it. In US and UK, the data shows clearly only 20 to 30% of the patients are get optimized treatment. That is, for example, if you have a AC inhibitor, ARB or ARNI, you want to go up to the fullest dose to get the best benefit, because most of the RCTs do with their fullest dose. But a lot of times what happens is we don't get to the fullest dose. So I want to start, so I will start, but I will not up titrate my doses. That is the biggest problems in treatment of heart failure. Then now we are going into this particular molecule. SGLT2 inhibitors are running chaos into the market. Today we will take one particular molecule, that is Dapagliflozin, and see how this molecule works and how effective it is. So I'm going to the heart failure per se. So I'm going to talk about the trial which it has been done with Dapagliflozin in heart failure with reduced ejection fraction. So it is Dapagliflozin was compared with placebo in the patients with heart failure with reduced ejection fraction. Whenever we say heart failure with reduced ejection fraction, the ejection fraction should be less than 40%. That is what we mean. And if you see this population, it's very high risk population. The age is around 66. LVEF is about 30%. NT-proBNP, which indicates heart failure, it's highly, really high. It's more than 1,400. And if you see, most of the 50% of the population is diabetic. And nearly 38 to 40% of the patient is having atrial fibrillation. And 50% of the population is already being hospitalized for heart failure. That means this is genuinely a very high risk subset of population where the therapy is going to make a much difference. So what they have observed in the studies, when Dapagliflozin significantly reduced the risk of CV death or worsening heart failure, when it happens as early as 28 days. This is a very big thing. So if you start a molecule, we know only beta blockers can give us that much amount of effect within 30 days, reducing mortality. That's why we want to introduce beta blocker during hospitalization to get the benefit at the 30-day interval. So similarly, this molecule shows benefit at 28 days. And you see what is happening to the curve starts widening. That means the benefit you achieve at 28 days, it's getting improving. So continuing this molecule over a period of years is going to benefit the patient. If you see this curve, it's exponentially, it's widening. That means even over a period of 1 year, the benefits are going to be higher. So it's not a short-term benefit. Then if you see, what about CV death? What about worsening heart failure even? It reduces it by 30 to 18%. That means it prevents heart failure hospitalization, or it even prevents first-time heart failure hospitalization. And if you see mortality because of heart failure, that is what we are aiming at. We want to reduce the mortality because of heart failure. When compared with DAPA with the placebo, it has scored in every format, like CV death, death due to heart failure, or death from any cause. This particular molecule, when reduced ejection fraction, has shown benefit. And what about now we are saying this molecule is good and it saves people from heart failure death or a CV death or death from any cause. Whether it is suitable for all group of population, whether all subset of population is studied, yes, of course. For example, in type 2 diabetes, this population is this study is very peculiar. That is the first time this study involved both diabetic and non-diabetic population. It's an eye opener because previously we have been using this molecule for heart failure reduction in diabetic population. This study came out with the idea of enrolling 50% of the population who are non-diabetic and showed benefit in heart failure reduction. And the beauty of this study is none of these patients went into severe hypoglycemic event. So now it is very clear after the study has come that both in diabetic and non-diabetic population, this particular molecule, that is Dapagliflozin, can be utilized. Then it across all the subgroups, like patients with independent of the sex or the geographic region, or what is the etiology of heart failure, whether the patient is obese or lean, irrespective of any other factor, this molecule is working for everybody. Then, okay, then as I discussed this point, like independent of diabetes, it is working and there is no major side effect related to it. What about heart failure admissions? This particular molecule, we all know, once we prolong the life of a heart failure patients, as years goes by, they get admitted again and again for heart failure. the frequency of admission over a period of years is going to increase with the living patient who has uncontrolled heart failure symptoms. So this particular drug not only has an impact on mortality, but has an impact on morbidity. So with dapagliflozin, it has prevention of heart failure admission, even in the first episode, as well as it has an impact on cardiovascular. Then, you see, I say it is good. It has mortality, morbidity, everything is okay. As a patient, what is the benefit I can feel? Because I will not know where it is getting extended, right? So when they implemented the questionnaire, questionnaire score for cardiomyopathy, they found the patients are feeling better with the introduction of this particular molecule. The quality of life and the patients are better. Patients are feeling much better with the introduction of this particular molecule. That is also very, very important from the patient's perspective. If you how to assess this score, whenever it is scored for 100, whenever the score is higher, it is better. The patients are feeling much better. So with dapagliflozin introduction and compared to the placebo, these patients felt very much better. Their 6 minutes walk test improved. They are feeling very comfortable. They are not symptomatic. They are able to perform their day-to-day activities. From a patient's perspective, this is more important than what we talk about morbidity, mortality, which they will not understand much. So this drug not only helps to prevent morbidity and mortality, but also gives a big symptom relief for the patients. Right? So what does this say? The score says there is only fewer deterioration if you increase dapagliflozin as your molecule for treatment. Then renal components. See, this drug is not only helpful in heart failure, but also prevents progression of renal disease. The numbers enrolled were not significant, but they showed a trend that dapagliflozin showed to improve renal function. That is, it prevents the deterioration of renal function or a patient moving into one more thing which was observed is if the patient is put on dapagliflozin before they are being diabetic, non-diabetic substance, it prevents the progression of the patient from being non-diabetic to diabetic. So it postpones the progression of diabetic status in a patient who is non-diabetic. So safety tests, as I said, there are no major safety concerns which are eliminated in this study. But one thing they have noticed is whenever you are using MRA as your part of therapy for heart failure, this is one of the pillars for heart failure therapy. When you add dapagliflozin to it, there is a significant chance that it can increase your potassium. So hyperkalemia is a possibility, and it is better to monitor potassium if the patients are on both MRA and dapagliflozin. And it's very well tolerated both in diabetic and non-diabetic patients. And as I said earlier, it is consistent in all groups. The independent of the BP, independent of the diuretic therapy, independent whether the patient is on ARNI or not, independent of the renal function or baseline NT-proBNP, it works for every patient whenever you introduce this patient for the benefit of heart failure reduction. So summary is 26% relative risk reduction with CV death and worsening heart failure, 18% individually for CV death, 30% for worsening heart failure, and 17% for all cause death. So wonderful study which eliminated a change in the guideline, bringing dapagliflozin to the class 1 indication for heart failure management. And cardiovascular benefits. This is one drug. This Declare is the first trial which came in, which enrolled patients who are not having a major cardiac problem. This for prevention of cardiac disease. That was a primary trial which was done, and that it worked effectively. Similarly, now we have two trial arms. That is, one is Dapagliflozin, which we now study. It showed in heart failure patients it is very, very effective. This heart failure patients should reduce ejection fraction. The other arm is Dapagliflozin. This is the only trial where they studied chronic kidney disease patients, and they found doubling of creatinine time comes down, and the patients requiring for ESRD for dialysis also comes down with this particular molecule. So this molecule doesn't not only have diabetic benefit, it also has prevention of heart failure, and also it's very helpful in bringing down the or stabilizing the renal parameters of the patient. So kidney beneficial, cardiac beneficial, as well as diabetic beneficial. So dapagliflozin delivers is one trial where they studied about dapa with the placebo about 4,700 patients. This is for patient's perspective. and they found that it is very effective in terms of patient relief. What are the ongoing trials? As I said, Dapagliflozin is done. Determine is a trial where they see about the perspective of the patient, that is through questionnaire. And we have acute heart failure trial, where in acute heart failure we are introducing SGLT2 inhibitors as a part of therapy. And there is another ongoing trial which is called as Dapagliflozin, where they are introducing this patient during an acute MI phase. That results are awaited. How to introduce? Now we know where we stand in terms of guidelines. So from 2022 AHA ACC guidelines says DAPA SGLT2 inhibitors have become a class 1 indication as a foundation therapy for heart failure, along with RNA, beta blockers, and MRAs. And similarly, SGLT2 inhibitors reduces mortality in all subsets of population. So if a patient is with heart failure, irrespective of his background, SGLT2 inhibitors has to be introduced as a part of therapy. Then, as we all know, ESC also endorses the same as a part of first line of therapy for heart failure. And they say it has to be introduced as early as possible. Now we know Dapagliflozin has to be introduced. What was the conventional thinking is previously what we are thinking, we have to introduce beta blocker, then AC inhibitor, then MRA, and then finally we have to move into SGLT2. This is what the conventional teaching. But now what is happening is there is a rapid initiation proposed by McNeil. Now it is being discussed in multiple forums. Whenever you go and sit for any SGLT meeting, they talk about this McNeil's new rapid initiation therapy formulation. What is different from what they were thinking before is initially it took 6 months for optimization of the therapy for heart failure. Now what they are saying is the new proposal is go initially with beta blockers and SGLT2 inhibitors. Within 1 month, introduce all. Within 4 weeks, introduce RNA and MRA. How do we arrange this? Because they say this is metabolically neutral, and we know introduction of beta blocker has a mortality benefit as early as within 30 days. Similarly, SGLT2 inhibitors also has a mortality benefit with 28 days. The curve starts widening at 28 days. So, and the advantage of SGLT2 inhibitor is being that you can introduce in any subset. It is not going to affect your BP. It is not going to significantly affect your other parameters. So even before discharge, this molecule can be introduced and it can be optimized after discharge. So you need not wait for the heart failure molecules to be introduced, finally introduce SGLT2 inhibitors. And we know the cost of the SGLT2 inhibitors has come down drastically. And that is one advantage for introducing this molecule as early as possible for every kind of patient. Initially, the major restriction was the cost. Now your original molecule itself is costless. So you can introduce this molecule very effectively on the initial stage of the therapy. So instead of going for a traditional approach of AC, ARB, beta blocker, MRA, RNA, we can even rapidly introduce this molecule within a month's period. So you have to choose the right patient, and dose selection is appropriate. If you want, you can introduce in a non-diabetic patient 5 mg and upgrade it to 10 mg. But the absolute dose required is only 10 mg. You have to, if the patient is on MRA, please monitor his potassium. And it's better, it has shown a benefit throughout the range and throughout the years. So it's better to continue this molecule for a longer period. Thank you. Thank you for the question.
Thank you, Dr. for the elucidation of Dapagliflozin. One of my what was heart failure to preserve injection?
So, sir, now we have a trial. Where IMPA has shown, they are enrolling the patients. The results are not at all. But what we are seeing is what RNA could not achieve in terms of in preserved ejection fraction. But now IMPA could achieve. But the problem is SGLT2 inhibitors in that even in that preserved heart failure trial, what we have done is they have shown benefit for the patients between 45 to 55. But when the eve of clock is 55, they are not that subset of patients. We are not able to achieve the heart failure reduction. Though probably I will say the trial is well planned trial, where they try to bring in even stabilized patients into the category, which RNA did not do when they did the trial.
May I ask one question? Have you got any age limit to start this drug? Another thing, that the different types of cardiac failure, maybe diabetic, hypertensive, resistive. In any case, all this can be initiated to what will be purchased.
So currently, dapagliflozin can be introduced irrespective of etiology of heart failures. But only one case is preserved ejection fraction. That is where the problem is. We don't have a strong data to support. Otherwise, irrespective of heart failure etiology, this molecule seems to work.
Including in postpartum cardiomyopathy.
There is no major studies currently available. We don't have that.
Okay. But in pediatric age.
No, sir. No, not in pediatric, not in postpartum. Only heart failure with reduced ejection fraction is a common major trials are currently available. But whether there is any off-label trials or any other consultants are using in the structure, I'm not sure. And in our center, we have never used both the substances.
Thank you.
Thank you, Dr. Prabhu from Mandurar. We'll be talking on the changing paradigm of nuclear medicine and cardiology.
Thank you, Chairperson, for the introduction. And most respected, my mentor, Dr. Shanmugan sir, to the chairman, APHNA chapter, my colleague, Dr. Chandrasekhar, who gave me this amazing opportunity, and my teacher, Dr. Gauri Shankar, and all my dear friends. It gives me a great pleasure to stand in front of you after a long time, after a series of virtual meetings, and thank Dr. Chandru for getting us together in an in-person meeting. There's nothing like meeting person to person and shaking hands and chatting. With these few words, we'll discuss something about the changing paradigms in nuclear medicine, the impact of nuclear medicine in cardiology. Actually, when we see this on the left, we see the heart. We take a small chunk out of it. You can see the endocardium, the myocardium, the epicardium. To divide it still further enzymatically, we'll be able to see the whole area of cells. But what we have to appreciate is the endothelial cells, the vascular smooth muscle cells, and the lymphatic cells. They constitute a major numbers. They are more in number than the cardiac myocytes. Whereas the cardiac myocytes are they make up the volume because the size is bigger. That is why we are discussing more about the cardiac myocytes. And what is important is, if at all, if you are able to appreciate how the cells intercommunicate among themselves, and how they deactivate themselves by communication, de-differentiate, etc. So many things are dynamic changes are happening in the heart muscle. We have an answer for a heart disease, and we can proceed how to manage them. This is exactly what we do in nuclear medicine. In nuclear medicine, what we do is we introduce a tiny amount of tracer, which takes part in the body metabolism. And as and when the metabolic process is happening, it is going to continuously emit gamma rays, which are highly penetrating, by using specialized equipment. And this is the image you get. Raw images, which is unprocessed, that's all we get. This is nuclear medicine. And these are the common indications. What are the conventionally? We have the ischemic, you can visualize the ischemic myocardium. You can see the regional variability in the ventricular contraction. You can also see the global ejection fraction, regional ejection fraction. You can, in a beating heart, whether LV is eccentric. You can also see the LV dysynchrony. And if you are planning for a device therapy, you want to know where exactly to put the device so that it will be maximum use to the patient. And for this, you draw tracers. The ideal tracer is oxygen level water, oxygen 15. It is a positron emission, chronography. If you use this, because it emits positive charge electrons. The moment you come in contact with electrons, it annihilates and develops with the photons, so light particles. Then the nearest, this is not available because we need an in-house medical cyclotron and a quick camera, which is an expensive proposition. So we are trying hard to get it to Tamil Nadu government. The next best is the fluorine 18 by gas, which is still an experimental molecule. And we were familiar with thallium. It has a weapon molecule for decades. It mimics potassium ions. We all know intracellularly a lot of potassium is there, extracellularly a lot of sodium is there. Since thallium, if you are injected, it mimics potassium ions. We'll be able to see the distribution of thallium. And day-to-day practice, we are using tetraphosphamine as sustainability. This particular tracer goes into the mitochondria. Normal myocardium is rich in mitochondria, is ischemic myocardium has less mitochondria, and infarct doesn't have mitochondria. So depending upon the extent of mitochondrial uptake at the time of injection, we are able to evaluate how the heart is functioning. And if you take up the image as such, what happens will be something you can X-ray, you don't see the contracting moment. So what we do is we give instruction to the system, computers, telling that start taking images as and when the RWA appears in the ECG. So it takes about 24 or 16 rapid images and assembles one over the other so that you can get a medically appreciable image. This is the equipment we have at the multi-super specialty hospital. It's the same equipment. We will be able to visualize the structure of the heart, anatomy, and cellular functioning of the body. And these are the traces that are conventionally having for SPECT imaging. With these traces like sustainability tetraphosphamine, we will be able to visualize the myocardium, myocardial perfusion. Then by using MDP, we will be able to visualize cardiac amyloidosis. There is inflammation, infection imaging, myocardial sympathetic innervation imaging, fatty acid imaging, myocardial apoptosis is erection spike, and alpha V beta 3 integrate that gives us the information about various diseases. These are the imaging procedures which we are capable of doing, and we are almost doing 60% of it in a day-to-day practice. These are the PET imaging traces which are conventionally having, and here you can see the myocardial perfusion. You can quantify the absolute myocardial perfusion. You can also see the microcalcification that is happening in the myocardium. You can see the extracardiac amyloidosis, oxidative metabolism, fatty acid deficiency, myocardial substrate metabolism, sympathetic innervation of the heart, neurohormonal receptors, and inflammatory pathways, and targets for extracellular matrix formation and angiogenesis. This much molecular events that is happening in the myocardium, we can objectively see, and we will be able to quantify it. It helps us understand the disease process that is happening as and when it is evolving. These are some of the studies which we did during the last 2 days in our department. This is to the left, we see the normal myocardium, where we can see a really like well-perfused heart, and there is a uniform tracer uptake. EF is about 79% and 80% of stress images. In our day-to-day practice in our department, we use adenosine at 140 microgram per kg body weight, which is introduced slowly over 6 minutes. On the left, we see ischemic myocardium. What we see is that between the 9 o'clock position and the 6 o'clock position, there is a perfusion defect. That is the inferior valve area, where it corresponds to RCA, and it's a dilated ventricle. You can see just by looking at the images, you can see appreciate the dilated ventricle, and images speak for themselves. The EF will be about 32% and 29%. That is the estimated EF in this particular study. Just to compare. And this is one patient, a similar situation where you can see the perfusion defect in the right corner of the LCS especially. What we see is a hugely dilated heart and a significant perfusion defect. On the right extreme, you can see that there is some amount of activity that is happening. These are the patients who will be benefited by doing a revascularization. If we do an angiogram and form a roadmap, it is up to the surgeon to revascularize and salvage the ischemic myocardium. And this patient came with severe breathlessness and fetal edema, and you can see the hugely dilated ventricle, and the ejection fraction is less. So we'll be able to, what my previous speaker was alluding about the heart failure, you can actually see the heart failure, and we treat with a particular drug and monitor the progress non-invasively. When we are assessing the patient, we give adenosine. The patient doesn't express any difficulty whatsoever. At the most, about 2 to 3 weeks per minute, heart rate is increased, and it's a very comfortable stress for the study for doing day-to-day follow-up. And this is what we see when we study LV desynchrony. You can see a perfusion defect, huge perfusion defect, both in stress and rest images.
लेकिन अब वो नहीं हुआ ना, ये whole one
with a dilated LV aneurysm, all the things can be seen non-invasively. And in a systolic dysfunction, and there are some conditions where increases over stress, which gives us an idea that this particular area is a vital myocardium, and we use whatever may be the method we are at. We do come across patients. The thing is very thin, about 1 to 2 millimeter thickness, and it is not to be associated by the fixation. As you can see, it is bigger than the left ventricle, and the patient is going for RV.
बोल नहीं आ रहा है वो 10
We
बजे
have to
स्टार्ट है
properly
10:30 के लिए
you know that the prognosis for hypertension failure is surrendered. And this is a heart failure for the excessive discharge, preserved ejection fraction, where you can see the systolic thickening of the ventricle during stress. This much is what we are doing in a conventional day-to-day practice in nuclear cardiology. And we do get additional information. Like for example, we will be able to estimate to what extent is myocardium. In this particular study, a couple of days ago, we did it. It says that the circumflex artery is only normal, almost normal, 3% the ischemia, whereas the RC has a maximum 64% ischemia and LCS is having 42% ischemia. On the center, we can see the contraction that is happening in the ventricle and the degree of reversibility that is happening. The reversible perfusion during stress and areas that we are able to see. And also we can overlay the summary of the picture on the ischemic myocardium just to understand what the distribution of the blood flow that is happening. And we can take a CT also to study how is the heart, what is the relationship with the heart with the surrounding structures. So much amount of information in a single image, which is costing for, which takes about 5 to 6 minutes for acquisition, we'll be able to study. And what is more important is we do have to look for the phase histogram on the left extreme. The pyramid is what we see. In a normal myocardial perfusion, you get a very sharp pyramid, you get a very sharp peak. Whenever there is a contraction, dysynchrony is there. It is why the base is widened out. The peak gets short. Whenever there is a desynchronous contraction, suppose we are planning for a device implementation, we want to choose the right candidate. When the EF is more than about 32%, these are the patients who will be able to maximally benefit with the optimum medical therapy. On the other hand, we very little viable myocardium if we are able to appreciate. This is where we will be able to implant the device, and it helps us to find out which are the patients who will be maximally benefited by device therapy. And we can also map out objectively area which is having ischemia, reversibility, all these things. We can give a score to it, and these are the various methods. Just to sum up, you can quantify the myocardial perfusion, you can quantify the ischemia burden, you can estimate the size and viability, you can predict the risk of the patient, and everything can be objectively evaluated. Then what happens? In a ischemic myocardium number decreases, the deformity in mitochondria is also there. As a consequence, moment the system is injected, there is a rapid washout. We can estimate the degree of washout by comparing the heart to mediastinum ratio, and we can estimate which of the patients will be having poor prognosis. This is the algorithm which you can see. Whenever the patient is referred for a myocardial perfusion study, whether it is appropriate, if it is appropriate, then the test is without using deviation. Like for example, echocardiogram is available. We always give preference to a non-deviation anything diagnostic modality. And if it is not available, or if it is not contributory, we always prefer for a PET-CT. And of course, most of the Indian PET centers, more work is being done in oncology. So we will be concentrating on SPECT-CT, the SPECT-CT like the equivalent what we have in our department, and identify the patients who will be maximally benefited by the study. If the patients have ischemic myocardium and stress only, we will give a minimum amount of radiation to the patient, and just for a single study, we will be able to estimate what kind of patients, what sort of therapy can be done. And for evaluating women in heart failure, the symptoms is atypical because of for the natural inherent physiology as such, and they have what we call reduced physical activity in day-to-day living. And these are the algorithms which we use. We use pharmacological stress, and by non-invasively we will understand what is the degree of myocardial perfusion that is happening in women, and we will be able to understand what whether sensitivity, specificity at all. What is the paradigm shift that is happening? What the Chandrasekhar gave me a task. One is the instrumentation. We have specifically cardiac specific instrumentation. One such instrumentation is available in another hospital in Delhi, where when the patient is in heart failure, when he has a severe orthopnea, platypnea, and all, he has to recline on a recliner, and the cardiac image can be obtained like this in a non-invasive manner. And we have high-speed electronics with solid-state detectors, which gives a sharper image than the conventional imaging methods. And there are a lot of what we call hybrid imaging that is going to happen because of a lot of changes that are happening in the electronic development. And we have hybrid PET-CTs and PET-CTs. Now these are extensively available in the country. And we can understand the kinetics, the dynamics of the metabolism that is happening inside. From the diagnostic aspect, we are now thinking of the therapy aspects. What will be able to personalize the treatment? These are the patients who will be maximally benefited with this amount of particular drug, which some other kind of patients may not be able to be benefited, or there are certain resistance patients in inflammation, infection imaging and all, where the patients will not be of much benefit. We have to divide these certain particle limiting areas like the alpha or beta emitters, which will knock out the specific genetic codes. And we will be able to prevent disease forms like heart failure getting clinically expressed long before the patient becomes symptomatic. And this is how we see infection imaging. Infection imaging, as I told you already, were PO. And they were able to find out all other investigations were coming as normal. When the technician level, WHO level, WBCs was done, they found that there is an infective focus on the aortic processes. And that's what we will be able to see here. There is a lot of hypoxia is what happens. A lot of new agents are coming up to find out hypoxia in the ischemic myocardium, which are the cells that are prone for hypoxic damage, and how we are able to the expression of reactive oxygen species. So many other molecules that automatically gets expressed, we'll be able to quantify and we'll be able to take appropriate actions. In the diabetic heart, the metabolic milieu is overloaded with glucose and fatty acids. And as a consequence, the diabetic myocardium, even though it uses the fatty acids for metabolism, there are a lot of inflammatory changes that are happening. A lot of trials have shown that in such patients, the non-invasive optimum medical therapy is more helpful than invasive therapy with a stent or a CAT. Infection, inflammation, and now we have the infiltrative heart disease. This is what we can do in our existing setup. What happens? Over a period of time in the failing heart, we see the amyloid protein infiltration. And this is what we can see in the normal heart, we don't see the amyloid uptake. Whereas with the minimum mild cardiac uptake, we see the amount of pressure when compared to the reach, it is relatively less. In the B here, the reads are almost equal in the option C there, and option D happens very intense uptake that is the heart is taking more amount of pressure than compared to reads. These are the patients who we are having poor prognosis. And there are a lot of established guidelines how to go about it, ATTR protein, amyloid protein estimation and all, how we can non-invasively diagnose. And evidence-based studies have come up, compared with the cardiac MR, PET-CT, and SPECT-CT. With a simple available PET-CT in our SPECT-CT in our day-to-day practice, we'll be able to objectively quantify. These are the patients who are getting for heart failure, and these are the patients who are going to have poor response. Then we have the autonomic innervation. There is a balance between sympathetic and parasympathetic innervation. And this is discussed and for patients for recurring repeated arrhythmias. And these are the patients who will be able to objectively measure by doing meta-iodine study. And for this, we are using iodine-123. But iodine-123 is a cyclotron product. Only Sanjay Gandhi Postgraduate Institute, Lucknow, has this facility. So on the other hand, we in our practice in Mandura, we started using iodine-131 NADG. And even though the image quality may be less, but the information obtained was so much good, and we are using it regularly in our practice. What happens is, this is how the receptors are downregulated. As a consequence, the MHGG, even though it may be localized initially, over the delayed imaging, there will be rapid washout from this target area to show which tests to identify. These are the patients who will be maximally benefited. These are the patients who are going to have poor prognosis. And there are certain challenges, especially in delineating the target border. Like in this particular study, where the MHGG uptake was a bit less in the early images, delayed images showed a good uptake, and it was regained for a prolonged time. So these are the patients who will be maximally benefited. This is ADME research study. In the ADME research study, including early images, just 3 more slides. And what you can see is that in the early images, we will be able to see a myocardium. These are patients who have good prognosis. And some of the patients in the patient number 3, option C, we don't see the migrated uptake at all. These are the patients who were in forward, they approved a lot of arrhythmias, and they have poor prognosis. And this is a targeted therapy we are going to have, and it provides us the guidance. Not only that, not only as we discussed earlier, it helps us to narrow the targeted issue. And what happens, what we have to remember, the heart not only functions by itself, it has a very dynamic communication with the brain, with the kidneys and the lungs, and the immunological system also. And this particular tracer helps us, if at all we are able to identify the communication, we will be able to block the unpleasant communication and prevent and for intending heart failure by using targeted therapy. And then there are a lot of research is happening. What are the methods? Which is more appropriate? Which are the patients will be doing each appropriate study and all. A lot of research is happening, and then research is happening regarding the affordability, bringing down the cost, and the accessibility to the facility, and also to make it uniform globally. Whatever better practices, the same thing is practiced in USA or across other countries. So the uniform standard of practice and the quality is also being monitored. These are the various guidelines issued by the professional bodies time to time, and we follow that. And what happens is in cardiac imaging, we get huge volume of data. We get from echocardiography, we get from CT, so many huge volume of data. We use artificial intelligence to analyze and prognosticate and identify a subclinical heart failure long before it gets clinically expressed. Just to sum up, is currently evolving from assessing the physiology of the perfusion of the heart to identify and coordinate the integrated biological pathways. The 3 areas we have to concentrate. This is infection, inflammation, and infiltration imaging, that is main clinical acceptance. There is a symbiotic first between the nuclear imaging and the nuclear therapy procedures. The image-based therapy is going to cater the future. Newer innovations will be able to identify the molecular crosstalk that happens in the bleeding heart. And literally, we are at our aim. In the sense, we will be able to identify what the areas of the cancers and identify the disease problem before it becomes clinically expressed. Thank you.
Thank you, Dr.
But please ask easy questions.
Really, I mean, congratulations for the wonderful presentation. There, yes, even at molecular level, what's happened to myocardium? Generally, we cannot read this in normal textbook. It's only a myocardial perfusion and molecular level. You have told a lot of insights into the molecular perfusion imaging. I really congratulate for the nice presentation. But I have one small doubt. When I was presenting yesterday the 7 cardiac death, there are fibrosis occurring around the perivascular region. So that causes disturbance in the conduction of dramatic cardiac death. So is it because you are able to identify the separate regeneration, hyperventilation, corruption generation by the myocardial imaging? Is it possible to identify such fibrosis and it is causing triggering sudden cardiac death? Is it possible in the advanced technology?
Thank you, sir. Actually, there is something called a fatty stat, fibrosis activating factor imaging. And this is being used extensively in oncology. It is extensively used in North Indian centers, Bombay, Delhi, Calcutta people are using. Unfortunately, in the down south, we don't have access to much of PET CTs, and whatever PET CT is available in India is more the commercial aspect. We look for the FCT scan for doing myocardial oncology applications. So when you use fatty imaging, we'll be able to quantify the amount of fibrosis that is happening. And that's it. We also keep in mind, which is probably less suspected, the cardiac amyloidosis, which we are coming out. Only recently we are seeing a lot of amyloidosis in patients. We have restlessness with almost a non-resistant infection now. And my friend Dr. Manohar sir, who is a professor of cardiology in Madras Medical College, he was able to send some patients. He did with pyrophosphate imaging, and then when the pyrophosphate imaging showed a positive uptake in the heart, he did took a biopsy and confirmed it, and we found out that a lot of cardiac amyloidosis is prevalent in our population. And these are the possible causes which we have to take up in a day-to-day practice.
Thank you, sir. Thank you very much for nice enlightenment.
Thank you, sir. In fact, like we learn cardiology at the macro level. So today we have learned the cardiology at the micro level. I think it's a good talk deliberation you have given. Thank you for being with us. Thank you. Thank you.
It was a state of art lecture.
I invite Dr. Apandral to speak on dyslipidemia and analysis.
Good morning, everyone. Thanks, organizers, for giving me the opportunity, especially Dr. Chandrasekhar sir and Shanmugam sir. So, dyslipidemia management and insight. So, what? What we are going to see is what is the current management, what we are going to do for dyslipidemia, and what are the newer aspects that comes in there. See the first few slides, which are very well known to us. The cardiovascular disease is one of the most important and leading cause of mortality, and we have the number of people who died because of ischemic heart disease and stroke accounts for almost 16% for the global burden, and stroke accounts for another 11%. And global burden of this disease has shown it has improved from 4th to rank 2 over the period of last 20 years. And similarly, the same amount of burden is there in India also. Though we are a developing country, the burden is increasing. The number of people who have been affected with coronary vascular disease, the number per million population is more in India. The cardiovascular disease is the leading cause of mortality in India, and ischemic heart disease and stroke accounts for almost 80% of the death because of the cardiovascular disease. And we have, and the rank also improved from rank 6 to rank 1 during the period of last 30 years. So, what are the treatment aspects we have? We have dyslipidemic drugs like statins, we have fibrates, we have intestinal cholesterol absorption inhibitors like ezetimibe, and we have PCSK9 inhibitors like alirocumab and evolocumab. And what are the things the statins which are currently being used? And we have a lot of trials over atorvastatin and rosuvastatin, and we have many studies for other statins also. And everyone will be knowing about the mechanism of action of statins. It acts by reducing the COA reductase inhibitors. It inhibits the cholesterol synthesis. Cholesterol levels decreases in the liver. Because of that, there will be an increase in the LDL receptor. Increase. Because of this, more will be uptake into the liver. So there will be a clearance of LDL in the blood. So that is how it is working, and we all know the pleiotropic effects of statin have been proved beyond doubt by lots of studies. And statins are found to reduce both primary and secondary prevention of cardiovascular events for patients who are under risk for the first cardiovascular event, as well as those who are already had cardiovascular event. The secondary effect of secondary event will be prevented. And there are lots of studies, and we have landmark trials like ASCOT-LNA and Jupiter trial, which have proven beyond doubt primary prevention by statins have proved to save lots of life. And we have studies for secondary prevention also, and this also has shown there is a prevent the occurrence of recurrent CV events and mortality when they are used at the appropriate dose. And most of the randomized controlled studies have used the maximum doses, but still there is a residual risk in spite of optimal statin therapy. So, whether it is feasible for increase the statin dose in all patients? Definitely it's not. There are a lot of studies to show that also. The one problem is statin associated muscle symptoms. Most of our patients will be having that problem, and physicians are having inertia in starting that and titrating the dose to the maximum level because of this. And when it comes for the tolerability of statins, there are a lot of discontinuations. There are a lot of myalgia and increase in the transaminase elevations and CK elevations. And whenever we use the higher doses, it is still more. So high intensity statin therapy has been recommended by many of the cardiac bodies, and it has proven beyond doubt it has to be started whenever there is LDL level greater than 190 and in diabetic patients greater than 70, and those who are having atherosclerotic cardiovascular disease at a high risk, it has to be started at any point. And pure primary prevention also LDL 70 to 189. And there is suboptimal response to the statins. This can be physician related or patient related. So we usually start low doses just to prevent the side effects. That is the one thing. And most of the patients will be not adhering to the treatment. They will be stopping after some time. But when you see, in order to achieve that, there is need for the combination therapy. Combination therapy has the highest chances of attaining the target LDL, which has been shown in the trials. So we have the guidelines to use combination therapy. So they always say whenever you go to the maximum dose of statin, still not under control, go for acetylate. Then we go for PCSK9 inhibitor. Whether tolerability of acetylate and PCSK9 because it is an injection, PCSK9 inhibitor is an injection. So whether if you have a drug which has less side effects and if it is oral, definitely it will be helpful for us. And statin, as almost 22% of the people have SANS, and 15% of the people have side effects to discontinue the therapy, and 16% have not achieved, and 29% discontinued the therapy within the first year. So the current treatment and the unmet needs. Statin has been used, but there is discontinuation. We are not going to the maximum dose. Acetylate, there is abdominal pain and diarrhea, and it's an injection drug. And so what we have next? So peptide acid. So it has been introduced in 2019 in world, and recently our drug controller has approved that. So indicated in adults is primary hypertension or adjuvant to the statin or monotherapy or with acetylate. So the mechanism of action is similar to the statin, but it acts one step clear. It inhibits the ATP citrate lyase enzyme. The advantage of it is it acts in a similar way. It increases the LDL receptors and thereby increases its clearance. So thereby it reduces the blood LDL. And one thing which stands from statin to be converted into a active metabolic inside. So for that there is need for a long-chain acid protease synthesis enzyme. So this is expressed not in the skeletal. So we are not going to have much of the side effects when it is used as a monotherapy. And it is an adenosine triphosphate citrate lyase inhibitor. It is present as a tablet. It is a oral and 180 milligram once daily without food, and temperature has to be stored at 30 degrees. So needs trials. Okay, whether we have trials enough to use this when we like. We have clear trials. It is the largest clinical trial and it involves almost 17,000 people, and it is done in 4 methods. Serenity trial and tranquility trial and clear outcome trial. This is yet to come. It may take another 1 or 2 years to complete. And what is the scientific evidence of clear harmonic trial for diabetic acid? It's a 52-week, almost 1 year, randomized double-blind placebo controlled parallel group study. And the incidence of overall and serious adverse
hospital
almost the side effects of the placebo, not much. Added to the maximally tolerated statin did not lead to and but also LDL. For every time we double the dose, there is only so we call it as a rule of 6. But here, by means of adding this bempedoic acid, we can achieve more than 6% reduction. And clear wisdom trial. Yes, it also shows 20% reduction in the LDL, but as a secondary endpoint, you can see there is increase in the other non-HDL total cholesterol, CRP, so which are having a very good effect on the cardiovascular outcomes. And we have a Serenity trial, and this has been a 24-week phase 3 randomized double-blinded placebo-controlled parallel group study at 67 sites, clinical sites, and there is significant reduction in the LDL cholesterol, secondary lipid and biomarker are observed. So the conclusion is it offers a safe and effective oral therapeutic option for lipid lowering drugs who cannot tolerate the statin. Scientific trial, and this is actually phase 3 randomized double-blinded placebo-controlled parallel group, and it has been done with 90 sites, and significant reduction in the LDL-C has been seen as in the before. And both LDL as well as other secondary lipid biomarkers have been reduced. So this is clear outcome trial. It is going on. So once the results are out, it will determine whether the bempedoic acid daily reduces the incidence of adverse cardiovascular events in higher vascular patients with documented statin intolerance and elevated CDL. So there are a lot of meta-analysis and pooled data of shows the bempedoic acid monotherapy and combining either with statin or escitalopram significantly reduces LDL-C. When combined with statin and escitalopram alone, the combination together resulted in additional reductions of the LDL. It comes with adverse events. Anemia is somewhat more common, almost 2.6%. And gout it can cause the gout of hypertension, 3.4%, and there will be increase in amino acids, and pain in extremities are common. There is slight increase in the blood creatinine, blood urea, GFR, but they are uncommon, and it is recommended for using mild to moderate renal failure. So it has been contraindicated in pregnancy, breastfeeding, and concomitant use with the statin greater than 40 because of increase in the statin levels in the blood. So special warning and precautions. There is a potential risk of myopathy when it is used concomitantly with the statin, especially with the pravastatin and simvastatin. Monitoring of patients is needed to be there. And contraindicated during pregnancy. So breastfeeding also it is not recommended till now. So no data on humans per baby, but animal data has shown there is no much effect. No dose adjustment is necessary for the elderly patients. The safety and efficacy of bempedoic acid in children aged less than 18 years are not been proven. So it is a unique and novel mechanism of action that makes it to be used as an alternative to injectable lipid lowering drugs, and it can be used as a monotherapy and in patients who are not tolerating the statins. Thank you.
Thank you, Dr. Any questions to the audience?
Hi, Dr. Dapagliflozin. A couple of things. The way you projected statins, I thought statins are very bad. They're actually not.
No, actually, it's not very bad.
I'm just joking. The point is the amount of statin indulgence is just 7%. Right? It should be 27%. And it should be
maximum tolerated dose of statin must be given. It can be given. I have about 20,000 patients data of only 2 developed cardiomyocytes. And if you have statin intolerance, you can change the statin, reduce the dose of statin, still give statin because statins are still number one. Second thing is ezetimibe is good. Benzodiac acid comes only after ezetimibe. It's not before ezetimibe. That is very true. And benzodiac acid and uric acid is really not that much actual increase in about 0.1, 0.2 only. So it is not going to be that much of a problem. But statin associated muscle side effect, 1 point. Remember, it has to be within the first 3 months, bilateral, symmetrical, involving proximal muscles. Then only you suspect statin associated muscle side effect, which we don't. Normally, anybody's got any pain anywhere 6 months after it, 1 year after it, he's taking statin because of statin. After patient says joint pain is because of statin. All kinds of things they are seeing all around. The actual statin muscle side effects is very, very less. And if you look at bilateral, symmetrical, proximal, it's more than the lower limit, even in the upper. Within the first 12 weeks, within the first 3 months, it's statin. Otherwise, it is not really statin. That will be all kinds of diarrhea. So you should not attribute that. So be a little cautious about it. Benzodiac acid, I have about 25 patients in benzodiac acid is very good results already.
Only I started.
Maybe CPK may give some answer for myalgia or something. Do the CPK level very high, need suspect. I leave for some time, then restart.
Sir, since you have said that you have 25 patients, what about the myalgia? Whether it increases with muscle pain?
Nearly 20 of them are already on maximum tolerated dose of statin and ezetimibe and not achieve target. My target is not 70. For coronary artery disease, I do a live guideline 50. So I try to achieve 50 milligrams LDL in all atherosclerotic cardiovascular disease patients. So most of the patients, nearly 20 are related to this. And the muscle side effects don't happen. I don't know whether he highlighted that. Muscle side effects don't happen because the ACL citrate lyase inhibitor, it starts happening. Benzodiac acid is not a drug, it's a prodrug. It is activated only in the liver. It doesn't happen in the skeletal muscle. So you don't have muscle side effects with benzodiac acid.
We expect a lot of patients to be enrolled for every trial before we use a drug. We go and check that. Here we have a trial data about 4,000 patients. Remaining 14,000 patients trial data is not out. But still, the usage has gone up. Everybody wants to use. What is your take on it? You talk a lot of trials on every meeting, but with only 4,000 patients, are we ready? We know the therapeutic effects of this.
See, the point is there is an unmet need for cholesterol lowering. So this fills the gap. Even though the outcomes, clear outcomes does not in public. Unofficial news from another one, I got this clear outcomes is just moderately there. It's not fantastically there. But the point is, there is a requirement to reduce LDL cholesterol, which is not met by statins and ezetimibe. He spoke clearly about PCSK9, which costs about 35,000 rupees per month. How many people can afford it? The benzodiac acid costs 24 rupees per day, so it's hardly anything. So you have a requirement. And if you combine statin, ezetimibe, and benzodiac acid, your LDL lowering comes to 60%. You can bring down the LDL by 60%, which I think is fair enough. That is the reason why you are adopting benzodiac acid. The number of patients, like you say, is less, but one thing is it seems to be quite safe. Muscle side effects are much less. That is clearly there because of the mechanism of action. So I think it should work.
I have a patient now on PCSK9. Its LDL is only 3. What do you do?
Is pushing it a little too hard. Long-term safety, less than 15 milligrams deciliter is not known. So you don't bring it down. But there is data to say that there is no problem even in the single-digit number in the development trial. They said even single-digit about 100 patients or something achieved that, and they were all safe. Neurocognitive function also did not decline. So they are quite safe. But for 3, I think you're pushing it a little too hard. You can bring down. You don't have to bring it down so hard. You don't have to bring it down so hard. Less than 15, European Society of Cardiology has given a statement that don't try to keep less than 15. That is there. So I don't think it is good.
Thank you.
I think we will end up near. No? You can probably try because there are a few case reports and data which say that once you do PCSK9 a couple of times, it stays down. I don't know how. There's no mechanism attributed to it. But there are people who have watched for it that it stays down. Thank you, Prabhakar, for this session. I think all right.
Thank you very much, Dr. Barraj, and a special thanks to our special speaker, Dr. Prabhakar. And I think this session will close to the program for a
chairperson and the speakers. We had a nice discussion on various aspects of the DAPA as well as the nuclear medicine and the dyslipidemia. Then we move on to the next session. Waiting for the next session. The chairpersons invite to be on the stage Dr. Tilakavati, Dr. Rohini, and Dr. Gozai to conduct this session. I think the speakers are well known to you. Dr. Dharmaraj, Dr. Asha, Murthy, and Bhavadar, and both the chapters. Please stick on to the time we are running late.
Good morning, one and all. We welcome you to the second session. At the outset, we'd like to thank the organizing team, in particular Leela Madam and Dr. Shekhar sir, for giving us the opportunity to chat this session. I have the privilege in welcoming Dr. Dharmarajan sir in delivering the first talk on pre-diabetes. Are we doing justice to them? As you know, we have moved to the concept of primordial and primary prevention. So we have to address these pre-diabetics in order to prevent them from proceeding to chronic diabetes mellitus. Over to you, sir.
Good morning, ladies and gentlemen. At the outset, I'd like to thank my teacher and organizing channel responsibles to the seminar and the organizing and the scientific committee of the Preventive Congress for asking me to be part of this prestigious conference. The topic that we are going to discuss today is pre-diabetes, and there is a writer or a question to that. Are we doing justice today? The agenda of my talk for the next 15 to 20 minutes will be to give you an introduction about pre-diabetes, discuss the current prevalence and the significance of pre-diabetes, discuss some of the basic pathological aspects of pre-diabetes, and the intervention strategies and the effectiveness of the management strategies in pre-diabetes, and then summarize and conclude. Pre-diabetes, the term pre-diabetes refers to both IFG, impact fasting glucose, and/or impact glucose tolerance, called combined glucose intolerance in some, who are at risk of developing type 2 diabetes in the future. By definition, pre-diabetes is an intermediate state of hyperglycemia with glucose levels above the normal state but below the diagnostic level of diabetes. And pre-diabetes is a reversible condition which increases the risk of people developing type 2 diabetes and cardiac disease. And IGT and IGT are two distinct separate clinical entities with different metabolic abnormalities or distinct metabolic abnormalities different from each other. Prevalence of pre-diabetes varies based on the ethnicity, age, or sex, or the criteria that is used for the diagnosis of pre-diabetes. The definition of screening criteria differ between guidelines published by different organizations, so the prevalence also varies widely. According to ADA, the prevalence of pre-diabetes is about 34.6%, whereas according to WHO, the prevalence is about 19.8%. This difference in the prevalence is because of the diagnostic criteria that is given by ADA and WHO, which is different as regards the fasting plasma glucose is concerned. If left untreated, about more than one-third of individuals with pre-diabetes may proceed to develop diabetes in the succeeding 4 years. So this underscores the importance of identifying and treating pre-diabetes in the initial stages. And treatment goals should be to prevent a deterioration of the glucose levels, and not only that, should also be to modify the other risk factors such as obesity, hypertension, and dyslipidemia, and treat the patient as a whole. If you look at the global prevalence of pre-diabetes, we find that the prevalence of pre-diabetes is much more in the American continent and the MENA countries, the so-called Middle East and North African countries, when compared to Southeast Asia or the Western Pacific. If you look at where we stand, the top 10 countries, the number of people with IGT, you find that currently we are about the fourth, but then we are projected to move up the ladder to the third and second position as the number of population increases. The current prevalence of pre-diabetes in India, according to studies, is about 10.3%, which is quite a significant amount of prevalence in our country. So it is our duty to take care of these patients. So how do we diagnose pre-diabetes. You all know fasting plasma glucose of less than 100 is normal, above 126 we call it as diabetes, and between 100 to 125 we call it as impact fasting glucose, which comes for pre-diabetes. At the 2 hour post glucose or OGTT, less than 140 is normal, more than 200 is diabetes, and between 140 to 199 we call it as impact glucose tolerance, which also comes for pre-diabetes. As far as HbA1c is concerned, less than 5.7 is normal, more than 6.4 is diabetes, and between 5.7 to 6.3 we call it as pre-diabetes. So definition is very clear, and any abnormality, remember, should be repeated or confirmed on a separate occasion. Never diagnose diabetes or even pre-diabetes with a single blood sugar value. And again, remember, any abnormal value to confirm a pre-diabetes, you have to do a OGT. We see that in substance. Risk factors for developing pre-diabetes. Screening for pre-diabetes or diabetes should be considered in all high-risk individuals, overweight or obese individuals, or one or more of the following risk factors. This is very familiar with all of us: first-degree diabetes, ethnicity, history of CVD, hypertension, all features of metabolic syndrome, PCO, physical inactivity, or other conditions like severe obesity or hypertension. Now let's look at some of the basic pathophysiological aspects of pre-diabetes and see how IgG and IgG differ from each other. Pre-diabetes is basically not a disease state, but it represents a state with a high probability of progressing to type 2 diabetes or the development of cardiovascular. That's why we are worried. And subjects with pre-diabetes often have only a minimally elevated HbA1c levels, but they have other features of metabolic syndrome, which increases the risk of cardiovascular disease because it is a common sign of hypertension that happens together. And fasting plasma glucose, we all know, pathophysiologically, fasting plasma glucose is determined mainly by the ability of the B cells to secrete insulin in the basal state, which is appropriate to suppress the hepatic glucose production. It is mostly unifactorial, whereas the 2 hour plasma glucose is multifactorial. It is determined not only by the fasting plasma glucose, but also by the ability of the B cells to respond to a sudden rise in the plasma glucose that is following food, and also the impact of the insulin sensitivity on the therapeutic dose utilization, whether it is normal or not. So, as a result of these basic pathophysiological processes, people may have only IgG, or people may have only IgG, or in a minority, they may have both IgG and IgG. So, all permutations and combinations are possible. All of them are together put in a common basket for pre-diabetes. Subjects with IgG and IgG differ not only by their fasting 2 hours glucose concentration, but also the shape of the OGTT curve. If you do an OGTT in a normal glucose tolerant individual, the peak is achieved in 30 to 60 minutes, and the peak does not cross 160 milligrams per kg, and then it should fall to below 140 milligrams in the 2 hour value. Whereas in case of isolated IgG, there is a rapid continuous rise in the plasma glucose concentration, but it waits to decline at the end of 2 hours. And in isolated IgG, whereas in isolated IgG, we find that the plasma glucose, fasting plasma glucose concentration is higher than normal glucose tolerance or in an IgG, and an exaggerated early rise of the plasma glucose concentration, which will decline to normal levels at 2 hours. That is isolated IgG. So the shape of the IgG, the OGTT curve itself differs in all these individuals. What happens to insulin resistance in patients with pre-diabetes? The faster plasma insulin concentration is increased because of prevailing insulin resistance in both isolated IgG and isolated IgG. But it is more in people with isolated IgG because isolated IgG is a state of severe insulin resistance. And this insulin resistance is manifested in multiple tissues, like the skeletal muscle, liver, or the adipocytes. So, just a point to say, what happens to the skeletal muscle, liver, or the adipocytes? In the skeletal muscle, you will find that people with isolated IgG have a normal insulin sensitivity, whereas subjects with isolated IgG have an increased insulin resistance in the skeletal muscle. In the liver, you will find that in patients with isolated IgG, the basal hepatic glucose production is modestly increased, secondary to insulin resistance. But in isolated IgG, the hepatic insulin resistance is increased, but it is less severe. What happens in the fat cells? In the fat cells, in isolated IgG, the plasma free fat concentration is normal, but in isolated IgG, the plasma free fat concentration is increased in the fasting, and post-fasting suppression of the plasma free fat is in fact. So there is basic difference in the pathophysiological causes in insulin resistance in patient pre-diabetes, even among the different stages of pre-diabetes. What happens to the insulin sensitivity in pre-diabetes? The glucose-dependent insulin secretion is impaired in both IgG and IgG. IgG subjects show defects only the early phase of insulin secretion, whereas IgG subjects have impairment of both the early as well as the late phase of insulin secretion. And a decrease in the incretin hormone levels for the so-called incretin resistance also contributes to the decrease in beta sensitivity in insulin secretion in patient pre-diabetes. And remember, in fasting, if the fasting only 2 hours plasma glucose is in the upper limit of normal range, then it means the beta cell loss is already decreased by 50%. And if the 2 hours plasma glucose concentration in the OGTT is in the upper limit of upper quartile of normal range, it means that the beta cell function is already lost by 80%. So the clinical implication of this is that therapeutic interventions that are known to preserve the beta cells, like what we use the lipidosomes or the GLP-1 analogs, all of them should be used early after diagnosis of a pre-diabetes or early in the course of diabetes if you want to reverse it. What is the risk of development of type 2 diabetes or cardiovascular disease in patients pre-diabetes? The risk for future development of type 2 diabetes in patients pre-diabetes, when compared to normal glucose tolerance, that the conversion rate is just less than 0.5%. In patients isolated IgG, the conversion rate is about 4%. Patients isolated IgG, the conversion rate is about 6%. In patients combined IgG and IgG, the conversion is about 10%. So there is a significant rate of conversion from pre-diabetes to diabetes if left untreated. So this underscores the importance of identifying these individuals early in the disease and treating them appropriately if you want to prevent the progression to diabetes. And also, pre-diabetic individuals also have a 50% increase in the risk of cardiovascular disease. And IgG carries a greater risk of cardiovascular disease than IgG. Remember that. Pre-diabetics also have insulin resistance syndrome or syndrome along with the other components of metabolic abnormalities that we all know. What about pre-diabetes in children? We are seeing more and more number of children developing pre-diabetes. The prevalence of pre-diabetes is rapidly increasing in young adults and children. 10% of obese children have isolated IgG and 15% have isolated IgG. Metabolic abnormalities which underlie the IgG and IgG in children are almost similar to that in adults. Similar to adults, children with pre-diabetes also have an increased risk of developing type 2 diabetes and with a conversion rate of about 1/3. That is about more than 30%. And remember, weight gain is the most important risk factor which predicted the development of type 2 diabetes in children with diabetes. So, any child who is already obese or which gains weight during the adolescent or the pubertal period is always a high risk of progressing to type 2 diabetes in patients with pre-diabetes, in children with pre-diabetes. This underscores the importance of encouraging weight loss and increased physical activity in children. Now, if you look at the spectrum of the cardiometabolic disease as a whole, you'll find that genetic determinants are basically required for a patient to develop pre-diabetes or diabetes, and superimposed on it is obesity, and both of them play a big role in increasing the insulin resistance or worsening the insulin resistance, and this leads to pre-diabetic states, which is part of the natural course of history of development of diabetes. And the pre-diabetic states, it should be part of metabolic syndrome or isolated IgG or isolated IgG or a combination of all these things. All these things can progress to type 2 diabetes and ultimately to the development of cardiovascular disease, either primarily from pre-diabetes to cardiovascular disease or through the development of type 2 diabetes if left untreated. So intervention at an appropriate early stage is very, very important in these patients, and for that early diagnosis is also important. These are some of the medical or surgical interventions which have been shown to delay or prevent the development of type 2 diabetes in pre-diabetes. Several drugs like metformin, alpha-glucosidase like acarbose, and insulin sensitizers like cardiolizone or residual, all these studied in patients with pre-diabetes with significant follow-up period, and they have shown a significant reduction in the risk of development of type 2 diabetes. The metformin has shown almost 31% reduction in type 2 diabetes, progression to type 2 diabetes, and acarbose has shown 20% reduction in the development of type 2 diabetes, and diazepam has also shown significant reduction. But other weight loss interventions like orlistat, phentermine, or dopamine, all show significant reduction, risk reduction in the development of type 2 diabetes. Unfortunately, these drugs are not available in the market today for treating our patients. Ultimately, and then finally, bariatric surgery. Surgical bariatric surgery has been shown to significantly reduce the progression of patients pre-diabetes to diabetes. There is almost 72% reduction in the development of type 2 diabetes initiations. So all the medical and surgical treatments have shown significant response or significant reduction in the development of type 2 diabetes. But remember, lifestyle modification should be used with all these pharmacological or surgical interventions. It has to be effective in prevention of type 2 diabetes. So to summarize what we have seen so far, pre-diabetes is a rapidly increasing pandemic. Subject to pre-diabetes manifests with poor resistance and impaired gains of function. Dominant hepatic insulin resistance, while IGT subjects are dominant skeletal diseases. Insulin resistance in combination with impaired gains of function is responsible for the increased risk of type 2 diabetes. Direct risk factors associated with insulin resistance in pre-diabetic subjects are responsible for the increased risk of cardiac disease. And again, as I told you earlier, never diagnose pre-diabetes with a single test. Always do an OGTT. In any patient with pre-diabetes, with an IFG or IgG, for all we know, if you do an OGTT, we'll be surprised that the patient already has diabetes. Surprised if the patient already has diabetes. So without doing an OGTT, never confirm pre-diabetes, IFG or IgG. No clear consensus on whether IFG or IgG can be considered as disease states, but IFG is a risk marker for diabetes, IgG is a risk marker for cardiac disease. That differentiation we should know.
Both are protocol, Bruce protocol.
And try to answer the question whether we are doing justice today. And my answer should be a clear no, because we don't see them effectively. We find still there are about more than half of the patients being undiagnosed without going without diagnosis, and more than 50% of the patients having pre-diabetes when compared to the number of people having diabetes. So, interesting studies have shown that 5% reduction in body weight and increased physical activity can reduce the risk of diabetes by 50 to 80%. And lifestyle modifications are highly effective in delaying or preventing onset of diabetes and may reduce cardiovascular disease and mortality in patients with diabetes. Oral therapies like metformin, alpha-glucosidase inhibitors, glicosomes, lorcaserin, etc., and beta-glucide are surgical interventions or bariatric surgery for weight loss are all shown beneficial effects in the prevention of progression from pre-diabetes to type 2 diabetes. And IFG patients are more likely to benefit from agents which reduce hepatic insulin resistance, like metformin, whereas IGT patients will benefit more with agents which reduce the skeletal muscle insulin resistance, like Ketone. And so, if you see a patient with isolated IFG, you want to reduce the risk of progression, you should use metformin, and in patients with isolated IgG, there's nothing way better. Prevention strategies for the prevention of type 2 diabetes should be instituted at a much earlier stage. If you want them to be effective, if you want to prevent the progression to type 2 diabetes, or if you want to prevent the development of cardiac disease, or else it could be a case of too little, too late. And once the progressive decline in the rate of function has started and moved into an irreversible phase, thereafter it is difficult for us to prevent the relentless progression of degradation of physical function and the progression to type 2 diabetes. So, any intervention strategy should be instituted at quite an early stage, which we are not doing presently at this stage, and which we should all take up and do it in an effective way if we want to prevent the development of type 2 diabetes and reduce the risk of cardiac disease. Thank you all.
I just want to make a clear things that everybody mistake postprandial 140 to 200 for IGT. Is it so? IGT is a pure glucose tolerance. Yes, IGT is a pure glucose postprandial or post glucose, post GTP glucose abnormality, post GTP glucose abnormality. That's why I told you, post mean blood glucose, if it is between 140 to 180, don't diagnose that IGT and don't confirm this IGT. Do an OGTT. For all we know, we'll be surprised to find that the patient has already developed the diabetes. You'll have a high fasting or in the diabetic in the OGTT, you'll have a diabetic.
So that's what. And another thing, you are saying IFG is hepatic glucose output as well. It's better to do metformin in the night or in the night.
Dominantly, it will be better if you do.
Thank you, sir, Professor Vasan, to talk. Actually, you really did justice to the talk. And accepting the fact that we are not doing justice to the patient. The session is open for discussion. Immediate question.
Are we doing injustice?
We are not doing justice.
Wonderful lecture. especially you highlighted the point that the IFG leads to diabetes, IGT leads to cardiovascular arrest. That's a wonderful point. And also how to when to be metformin, when to be diabetes for IGT, metformin for IFG. That's right. So I'd like to know the concept called alpha-cell dedifferentiation, dedifferentiation. Is there any abnormalities of glucagon metabolism before the diabetes starts, even before the beta cell disturbance? Is there any alpha cell disturbance which is triggering this here? That's what something called some dedifferentiation.
Yes. Dedifferentiation. Once the beta cell dedifferentiation starts, thereafter it is a relentless progression or deterioration in the natural history of type 2 diabetes. That is why all these intervention measures should start even before the dedifferentiation starts. But then we don't, unfortunately, we don't have any clinical studies or tests to find out the stage or the point at which the dedifferentiation starts. So, in general, once the stage of IgG or IFG or IgG starts, then it means already the stage of dedifferentiation started. So that is why effective intervention should start even before the stage of type 2 diabetes for it to be more effective. We talk about reversal of type 2 diabetes also, but that reversal of type 2 diabetes again is more effective only if it is instituted during the first initial phase of first few months or years of terminal type 2 diabetes. Thereafter, it is difficult.
Thank you, sir. How about the gestational diabetes? They are, I mean, there are no documentation of any elevated fasting hyperglycemia. But during the gestation period of trimester, first and fourth trimester, they are documented that they have elevated fasting blood sugar. How many of these would go to the prime diabetes, even despite of good lifestyle and good everything, reduction and body weight?
Yes, great lecture, I think. Prime GDM, again, prime GDM is different and pre-GDM is different. We get to see more and more number of pre-GDM nowadays. Prime GDM also, without good intervention, they can progress to develop type 2 diabetes, obesity, and type 2 diabetes later in life. Almost more than 8-10% will develop diabetes later in their life. So, GDM.
So basically, now we see a lot of apps and other reversal of diabetes. And we are not prepared for this. So I just want to know one incident I will tell you. One of the patient of mine, his wife is diagnosed with a pre-allergy and they started a metformin. Right? So she came for a review of her husband. She asked me, sir, my husband is very much glad to work for the when can they will stop my medication? That is a question. Whether we will be able to stop the medication?
No, the question is that as long as you continue the drug, you will continue to have the beneficial effects. Once you stop the drug, you start losing the beneficial effects. So there is no time limit or no definite time point where you can stop the medications. Because we know we give metformin only to improve the insulin sensitivity. And as long as you continue the drug, you will have the beneficial effects. In spite of that, if she continues to progress to type 2 diabetes, thereafter you take care of the patient, additional other drugs. But there is no point of stopping the drug.
But what does it mean? A lot of apps nowadays like reversal, type 2
Yes, reversal, that's what I was telling earlier. Reversal is possible only during the early stages of type 2 diabetes. Even after diagnosis of diabetes, reversal of diabetes is possible only during the initial period of, say, few months or years of diabetes, say 1 to 2 years of diabetes. Thereafter, reversal is not possible or difficult. And the reversal is not possible without good lifestyle intervention. That is very, very important for us to understand. Reversal is not, drugs are there which have been proven in the reversal of diabetes, but without lifestyle intervention, the reversal of diabetes is not at all possible. With good diet as well as good physical activity. They are more important than drugs in reversal of diabetes or pre-diabetes.
Okay, I think we shall don't mistake it. Reversal can happen, as Professor said, it's only in very few patients, but many of them they get remission.
Really, the word is different, no?
Thank you very much, sir. It was such a wonderful session. So we should now carry on the next session. I now invite Professor Asha Murthy
to talk about a very important topic with respect to current concepts in perioperative cardiology. Madam is a senior consultant cardiologist from Ramchandra.
Good morning, ladies and gentlemen, Chairperson. At the outset, I would like to thank Dr. Chandrasekhar and the team members of Metabolic Congress for giving this wonderful opportunity to present to the August gathering. So I'm going to present on peripartum cardiomyopathy coming out of diabetes, coming out of dyslipidemia. The definition is it's a heart failure which is secondary to the left ventricle systolic dysfunction with the ejection fraction of less than 45%. The presentation is always towards the end of the pregnancy or in the months following the delivery. And till now, there is no identical cause has been documented. If you look at this global time frame about the peripartum cardiomyopathy, you can see majority of the patients they occur after 3 months of the postpartum period. And only limited about 17 to 24% occurs antepartum period. And also 3 to 6 months, they are less, about 40 to about 50%. What is the reason? The etiopathogenesis of peripartum cardiomyopathy. The most important causes, if you look at this the graph, you can see there is a peaking of cardiac output, there is a peaking of prolactin, and there is a peaking of SFLT1, tyrosine. So during this trimester, that is at the end of the pregnancy, or at the beginning of the postpartum, you can see there is a peaking of these two important hormones, and due to which there is a incidence, higher incidence of the patient going for postpartum presentation. That is at the peak, the last trimester. Now, the pregnancy hormone elicits a very important cardiovascular specific effect. You can see the 60-day prolactin, estrogen, and FSH2 progesterone. You can see that they have very bad effect on the cardiovascular system as well as the vasculature. They prevent apoptosis, angiogenesis, oxidative stress at the level of vascular area, and the cardiomyocytes they have a hypertrophy, vasodilatation, FSH oxidation, glycolysis, oxidation, and oxidative, and also apoptosis. So these are all the toxic effects of the prolactin on the muscle as well as vasculature area. So this is the diagnostic representation of pathogenesis of PCM. You can see that the prolactin is liberated from the pituitary gland, and the SFLT which is liberated from the placenta. They have a toxic effect on the endothelial cells of the vasculature and on the cardiac myocytes. You can see that there is a liberation of RNA 146A, 16 kb, and CAT. So all these have got endothelial dysfunction. At the same time, they cause at the level of cardiac ischemia as well as metabolic insufficiency in addition to apoptosis. This came in circulation in 2016. So you may ask the question that what are the various apoptotic presentations which can cause potential cause of peripartum cardiomyopathy? The viral myocarditis is one of the most important. Hormonal abnormalities, abnormal immune response to pregnancy, malnutrition, abnormal response to hemodynamic burden of pregnancy. That is, there is an increase in the volume output, there is a cardiac output, slow volume, inflammation and apoptosis. Age. 50% of cases occur in the women of the age of 30 years, and preeclampsia and hypertension have contributed to a very important strongly predisposed peripartum cardiomyopathy, and also multiple gestations, twins, triplets. All these are a high propensity for giving rise to peripartum cardiomyopathy, and in addition, you have anemia, asthma, diabetes, obesity, malnutrition, the contributing factors for this physiological condition. Now, how do you suspect a case of peripartum cardiomyopathy? You should have a high index of suspicion, because any pregnant woman, normal pregnant woman also can be breathless. So you cannot present that the patient say that the patient is peripartum cardiomyopathy. So breathless women during the late pregnancy and early postpartum, number one.
You should take a detailed medical history, electrocardiogram, nitric oxide, do an echocardiogram and CMR if necessary. If all the investigations found to be normal, it could be because of non-cardiovascular causes of breath loss. If there is abnormality, you can refer to your physician or cardiologist. So normal pregnancy is a fatigue and mild shortness of the breathlessness is mild edema, almost expected from the outpatient. In patients who come with acute failure, they necessitate admission and specific to intensive care so that specific care can be taken. The usual symptoms of dyspnea, exercise intolerance, orthopnea can be observed as unusual symptoms. And the symptoms of congestive cardiac failure with the comes with abdominal discomfort, periodic and palpitation. So this is the list of the conditions differential diagnosis with periodic cardiomyopathy. So I'm not going to enumerate all these. So you have to differentiate on the basis of electrocardiogram, on the basis of echocardiogram, like you have myocarditis, you have idiopathic cardiomyopathy, pregnancy as myocardial infarction, pulmonary embolism, amniotic embolism, and HIV and pre-existing congenital heart disease. So please differentiate all these by assessing the biomarkers, the onset of the condition, and also by looking at the echocardiogram so that you can differentiate all these different clinical scenarios. So the diagnosis, as I mentioned to you, you have to have a clinical examination because index of suspicion only is mainly by the clinical examination. Of course, the investigation base comes later. The clinical examination is very important. So look for the clinical examination, the echocardiogram and echocardiogram. Chest X-ray can be done with precaution. Cardiac MRI is done with specific condition to rule out any cardiomyopathy, that is sarcoidosis and amyloidosis, other conditions can be ruled out. These conditions are given to patient with symptoms. Then you have cardiac, that is the coronary CT angiogram, and coronary angiogram can be done. Suppose if you have a high rate of suspicion of myocardial infarction. So the overall view of the different clinical scenarios in patients with perioperative cardiomyopathy is that the echocardiogram with the list of ejection fraction 30 to 45% will come under the category of mild case of perioperative cardiomyopathy. Those who come with 20 to 35, they are moderate, and those patients who come with the ejection fraction less than 25%, they come with the severe perioperative cardiomyopathy and they require intensive care or hospitalization. So this moderate case can go for intensive care, and those patients, the 30 to 45% can go for normal admissions, and they can be stabilized and then can shift to the normal dose. Now, I have an interesting case, 41-year-old female who had presented with a history of recent onset dyspnea and swelling of feet, and she had delivered about 3 months back. On clinical examination, the heart rate was high, about 120, VO 90/60, little lower, and prominent third sound with Galileo collapse. Electrocardiogram showed signs of tachycardia. You can see the intraventricular conduction defect, and you can see the cardiomegaly in the chest, the enlargement of both the ventricles, both the right ventricle and left ventricle, and there is some amount of condition, there is some amount of perfusion. And echocardiogram shows all the chambers are dilated, left ventricle, right ventricle. There is an association of the annular dilatation with the result that there is a leak. Across the patient can present with mild multiple tricuspid, and you can assess the pulmonary artery pressure by seeing the tricuspid jet and adding the RE pressure. So you can assess the PE pressure. The CT pulmonary angiogram was done for this patient was found to be normal, and cardiac MRI also was done, it was found to be normal. There was no evidence of any associated lesion to cause the cause for the perioperative cardiomyopathy. So how you manage this initial management of patients who come with perioperative cardiomyopathy? The initial evaluation, confirm the diagnosis by routine investigations, naturalized biomarkers, echocardiogram, lung ultrasound can also be done of recent onset. Then you have all the assessing cardiovascular distress. Suppose the blood pressure is going down below 90, the heart rate is going above 130, and you have that respiratory rate also going up, patient is in altered mental state. So you, in patients who come with acute perioperative cardiomyopathy, you optimize the preload by giving a volume diuretic, optimize the oxygenation, add inotropic vasopressors, urgent release essentials with the need of for such patients who come with acute perioperative cardiomyopathy. And consider the patient is severe cardiopulmonary distress. So if the patient recovers, two options, whether the patient has to re-talk or whether the patient has to go for further transplantation. Second set of patients who are without cardiopulmonary distress, because you may come across two sets of patients. One may be very acutely unstable, one may be stable. So whether they are in antepartum period or postpartum period. So if they are in antepartum period or postpartum, they have to be stabilized with decongestion therapy with ART, ACI, ART, or whatever group beta blockers, whatever group is suggested. Then you consider for vaginal delivery if possible, and then always consider to give in addition to heart failure therapy, give bromocriptine start from 2.5 mg and slowly increase the mg. So consider all these therapy, continuous heart failure therapy should not stop in between. So the pre-prescribed protocol of interdisciplinary work with acute heart failure as mentioned to you, if the fetus is not viable, please deliver. And supporting give a maximum heart failure therapy to support the psychotherapy. If the fetus is viable, two options, patented and mandatory fetal status has to be assessed. Deliver if the patient with the maximum heart failure therapy, and pregnancy can be continued if the patient is stable, and then titrated for anti-heart failure therapy. So this is the example of all the management of patients to start assess the pulmonary artery wedge pressure. Impeller can be given for those patients who come with congestive heart failure or not get managed the routine protocol management of heart failure therapy. Inotropic, dopamine, norepinephrine, levosimendan, IV furosemide has to be given, and in addition anticoagulants, heparin, bromocriptine treatment has to be continued. Now the peculiarities in the management of patients with acute heart failure is caused by perioperative cardiomyopathy is a multidisciplinary approach which focus on health of mother and fetus, because the role of cardiologists, the role of physicians, the role of practitioners, the role of anesthetists, the role of gynecologists, all come into play. So avoidance of heart failure, please remember, ladies and gentlemen, that you should avoid all the fetal toxic drugs like ACEI, ARTs, and metabolic antagonists, and breastfeeding should be avoided in patients who are patients with acute failure, because it is possible that in fact the prolactin supplements can be integrated in the breast milk, so it is avoided, and standard heart therapy has to continue. So consider the bromocriptine 2.5 twice daily for 2 weeks, and then you can titrate the dose according to the response of the patient. So anticoagulation with heparin to avoid cardioembolic complications which can be encountered, especially those with ejection fraction low of 35%, and also you have to combine whether it's acute or whether it's subacute or moderate or severe, you have to continue bromocriptine. In case of patients who come with cardiogenic shock, consider levosimendan is a very ideal drug of choice, 0.1 micrograms per kg per minute for 24 hours instead of other catecholamines like dopamine or other groups of first line inotropic. This stands for first line inotropic drug, and early transfer to the experience center and early evaluation of mechanical circulatory support according to the center's experience, and prevention of sudden cardiac is very important because you can document a ventricular arrhythmia such patients, and also the role of ICD, that is cardiovascular defibrillator in those patients, especially if they have ejection fraction less than 35. So in total, please remember BORD, that is bromocriptine. O stands for oral heart failure drugs, A stands for anticoagulation, R stands for relaxants, D stands for diuretic. So please remember this total management of acute peripartum cardiomyopathy. Just remember BORD, you can remember everything. So this is one of the largest studies which was done, bromocriptine, which came in the European Society of Cardiology in European Heart Association in 2017, in which they found that when the patient was given administered 2.5 milligrams of prolactin, that is bromocriptine in earlier stage, they had a significant LV ejection fraction recovery, and also they have to be continued treatment, they should not stop in between. So the management, according to this, it's early delivery is not required if the maternal and fetal condition are stable. Please remember, it is not necessary that if you diagnose peripartum cardiomyopathy, immediate delivery. It's not that. If the patient is stable, please wait. Epidural analgesia is preferred drug of choice. In advanced heart failure, prompt delivery is a matter of choice. and planned cesarean section is preferred for women with advanced heart failure requiring inotropic therapy or mechanical circulatory support. And as I mentioned to you, breastfeeding should be avoided because of the potential effects of prolactin supplement and benefits of breastfeeding for stable patients if it is compatible with the other medication. So what are the maternal outcomes? What the studies have reported that the recovery of every function almost after 6 months is almost about 45 to 78%. It is irreversible. It is not irreversible condition like you see in other cases of perioperative cardiomyopathy, other causes of viral cardiomyopathy. So it is reversible. About 78% have recovered, and mortality is only 0 to 19%. The rate of cardiac transplantation is also, it comes on the way, it comes about 6 to 11%. The predictors of maternal mortality is poor embryo status, ejection fraction less than 30%, higher maternal age, black race, and multiparity. So these are the higher predictors of maternal mortality. Now, ladies and gentlemen, the patient will come to you. What about the subsequent pregnancy? Whether I can go for the second pregnancy, third pregnancy. So, how you plan this? According to the echocardiogram, you have to do echocardiogram. If the ejection fraction is less than 25%, please remember, or diagnosis, then this patient should be advised not to go for the further pregnancy. Number one. Number two, if the ejection fraction is normal, please advise for stress echocardiography should be performed. It is not necessary, but if you do a echocardiogram and if you see the ejection fraction 30% for normal ejection fraction, you can immediately advise the patient. No, you have to do a stress echocardiography, dopamine stress or exercise stress for echocardiography, and patients who come with abnormal LV inotropic response to dopamine or to stress echocardiography or by treadmill have a moderate risk of relapse, and pregnancy is not recommended. Right? Women with the complete recovery on both echocardiography as well as dopamine stress test can be informed about the low rate of complications. In this group only, despite the 35% rate of risk of recurrence, pregnancy can be completed in almost all cases. Right? So this is one of the fetal complications which can be encountered in subsequent pregnancy in patients who have a perioperative cardiomyopathy. That is, those patients with the ejection fraction less than 25% have a prematurity of 50%. And they have therapeutic abortion 25%. While those patients who have ejection fraction are nearly about 40-45%, their prematurity is only 13%. And therapeutic abortion is only 4%. So please remember, it both maternal as well fetal complications can also be encountered depending upon the ejection fraction. So in the postpartum period, contraceptive counseling is essential to educate the patients about the existing alternatives. Pregnancy should be avoided till the end function recovered. Combined estrogen and progesterone contraceptives are contraindicated as estrogen increase the thromboembolic process. Please remember, progesterone only contraceptive is permitted, and barrier methods are not favored due to high failure rates. IUCDs are the most efficient and safe methods of contraception, including vasectomy, tubal ligation, and insertion of intradural stents may be considered. So, have to do a serial monitoring during the subsequent pregnancy. From prior conception to the end of first trimester, second trimester, 1 month to delivery, after delivery, prior to discharge, and 1 month after the delivery. Please follow the patients with all the clinical assessment, echocardiogram, BNP at regular intervals, and see for any concerning symptoms. Ladies and gentlemen, what is the take-home message? The definition, as I told you, is uncertain. Still now, we are not able to come to the root. What is the cause of this? So the commonly it occurs upon 1 in 1500 live pregnancies. As I told you, the developing most commonly it occurs in multiparity, ethnicity, preeclampsia. We are more exposed to this PPH and and the complications encountered is heart failure, death, sudden cardiac death, arrhythmias, thromboembolic complications. Diagnosis based on ECG, biomarkers, echo, and CMR if necessary. Treatment to treat both the patients as well as lactating mother before and after delivery. The natural history is that high rate of recurrence. Risk stratification of PPCM is very much important. We have to assess with the goal of ejection fraction. And diagnose with the help of biomarkers. And also, what is the role of that is device therapy? Device therapy is IOD, that is defibrillator. Those patients who come with a malignant ventricular arrhythmias, those who have been documented ventilator tachycardia by our Holter monitoring,
So please remember that these patients can go for the IUD, that is a defibrillator device, and this has a limited dose and should not be given before. So the future directions of peripartum cardiomyopathy is to do a genetic counseling, assess the patients, those who are prone to go for a peripartum cardiomyopathy, and do all the hormonal therapies so that to know what is the particular in such patients so that we can prevent the biomarker diagnosis will be helpful in pre-existing cardiomyopathy. So with this, ladies and gentlemen, I thank you very much. I thank once again the Chairman, Dr. Chandrasekhar, and all the committee members. A very good hostel, very good arrangement and very excellent arrangement. And I thank you once again for the silence. Thank you, Chairperson. Thank you, ladies.
Thank you so much, ma'am. Thank you very much for such an extensive discussion. We all learned quite a few important points. I myself learned that the pregnancy system being
Best of luck in
and the role of Robert was also nicely elucidated.
Best of luck, Nikia.
If that is the case, can you do prolactin in the future in pregnancy? Prolactin level is prone for this complication, whether it's postpartum. So we can predict and we can counsel them and we can. Because as I mentioned in the future direction, that those patients who are susceptible.
No. It is only for
Patients you do all those subfragments. Essentially, tyrosine, all these
Yes.
subfragments are assessed and then indicating the patient that
learn
likely to go for this problem. So you'll be prepared for that. So this can be done.
Second one.
Comes to the acute complications like infection, sepsis, or some DNC done post medical service like that. They undergo the surgical procedures like give anesthesia and surgery. Most of the time, pre-procedure echocardiography was normal, and post-surgical complications acute cardiac failure develops, like almost like a postpartum cardiomyopathy. During pregnancy itself, they undergo any interventions, and is it due to the hormonal effect on the myocardium, and is it they are prone for such a failure following procedure? Because that the ejection fraction is 660 before procedure, and after procedure surgery, it becomes 25-30. So most of the cases in that situation,
Newborns on the red.
the proposal of safety, 25-year-old pregnant. That's why there are so many cases. It's possible that some of the patients have toxic. Exactly. They have suddenly facilitated this problem of yes. Yes. Any problem is what is very stress in the during pregnancy. Problem is and now the heart rate increases during pregnancy 10%. The problem is down regulation gets up on the myocardium. But being accelerated by this hormonal effect of the myocardium. Even slight stress that there is a sudden growth of increases of cardiac output. During that time, there is a reduction of prolactin and thyroid. So during these scans, suddenly all the toxic effect on the structure as well as the myocardium. And suddenly they can perform.
Now I invite Dr. Paudani to talk about enigma of breathing problems and solutions. Go to Dr. Paudani.
Very good morning. Thanks. Thanks to Dr. Chandrasekhar, Dr. Shanmugam, and all others for giving me this wonderful opportunity. Actually, I'm going to talk about the enigma of GDM. This is like catching two persons in a single shot for the prevention of non-communicable diseases in the future. What is GDM? We all know it is the glucose intolerance of any degree occurring for the first time. See, maybe unconnected diabetes or that occurring only because of the harmful human develops GDM? No, of course, it has this hormonal stress, that is the diabetogenic stress, but still it is overcome by the hypersecretion of insulin, which increases from 80 to 180 during pregnancy. Again, if you take the types, as I said, medium, which is diabetes, undirected diabetes during pregnancy, or the, and also the true gestational diabetes. What happens in this condition? Of course, if this occurs in the first trimester, it can cause excessive organ formation, can cause multiple anomalies. In the second stage, that is in the second trimester, it can cause impact cell function, behavioral abnormalities, and in the third trimester, of course, so in the first trimester, they can have multiple malformations, growth retardation, fetal wastage, and in the second, they can have hypertensive cardiomyopathy, as Madam was discussing, and polyhydramnios, erythema, placental insufficiency, preeclampsia, wants a baby with low IQ, and third trimester, of course, after it is born, and as well as have hypoglycemia, hypocalcemia, hypobilirubinemia, distress, macrosomia, hypermagnesiemia, and intra-IVF death. And of course, in the female, she can have more of insulin resistance, hypertension, more of cesarean section, preterm labor, polyhydramnias is due to the glycosuria in the fetus, because the renal threshold for the fetus is 110, not like us 180. So whenever the mother's blood sugar crosses 110, it's going to enter the fetal side and cause glycosuria, which is polyhydramnias, and the lady can have postpartum uterine atony as well as a premature placenta and pelvic trauma. So our aim in GDM is to prevent macrosomia or IGR beyond the normal range, 2.5 and 3.5, that is Indian standard birth weight, prevent fetal death and also maternal and fetal complications. You know, this obesity in children, congenital malformations, hypertension, macrosomia with difficult labor, cardiovascular diseases, metabolic syndrome, and recurrent hypos, UTR, respiratory distress, hyperapneas, all these, what is the cause? Of course, GDM is the mother of all these non-communicable diseases. Remember, GDM is nothing but that Dr. was talking, the IGT, you can see is GDM diabetes in pregnancy. So remember, if you are preventing reverting IGT, it is not only you are preventing diabetes, you are preventing the cardiovascular disease also. Here, if you take care of GDM, you are going to prevent all the non-communicable diseases in future. You know that this fetus who is in hyperinsulinemia is going to have more obesity in childhood and also 10 times more IGT by 12 years of age compared to the one with normal fetal insulin. So what is the solution? Of course, early detection and care. And if you see, according to IDM, in the low and middle income countries like us, in India, we have 85% of the annual urban deliveries and 80% of the urban diabetes, and 90% of all these and perinatal deaths and poor pregnancy outcomes are due to this. So we have to step down from ivory towers to ground reality to take care of this rural areas where we have majority and also low socioeconomic countries like us. And if you practically take pains to go and see what is really happening in the non-metro areas, there is scenery to see from A to Z. And we have done this non-metro centers and found, and most of them, we did about 5,000 cases, which only around 600, less than 400.
My husband yaking madatti neenu. Vishnu.
You know that the antenatal ovary is only on Tuesday
Is my husband, okay?
and here we
Is my love.
100 to 100
Love of life. We cannot do that.
to do the fasting, do the glucose load in fasting, all it may take just 2 minutes for the case. By the time they finish, they were crossed 1 hour, 2 hours. They don't come for this test alone, they have many other tests to be done. And we know the CHCs and non-metro, they open just by 8 or 9 o'clock, and they to see all these 50 cases, to see the medical officer itself, it takes 2 hours, and this women, that is the GDM female, she is not only outside taking care of her family,
Oh my
members,
God.
she also has to take care of all the other domestic animals, and then only she can report to the hospital. And she is in the interior of the villages where there are no transport facilities. So she has to come to the bus stop, walking for the 1 kilometer, then travel. A long time, and she cannot stand fasting for such a long period. And the family believes they believe that the pregnant lady should not fast for a long time, and they want her to take something and go for the test. And she cannot come alone; she is always accompanied by somebody else. So 2 vehicles are gone for a single visit. We are on daily basis. And you ask them to come again for the test in fasting. There are many dropouts, and in these we are mobility. See, this woman, she is working even on Sunday, May on Labor's Day, because she is not working. She herself and the whole family is going to be deprived of bread and butter. And we know that in fasting, in pregnancy, the fasting is very low because of the high sensitivity, and the muscle build up more, the liver is also less, and there is less hepatic glucose output. The fasting is very low, and pregnant ladies, they go in for early ketosis because of accelerated starvation. They always continuously eating parasites and intermittently eating mother. She has to eat for 2, so she feels hungry early. And above all, she has hyperemesis also. The hyperosmolarity associated with the glucose solution causes irritation, and she feels better if she takes the solution after food. So pregnants refuse to undergo GPT and tolerate glucose better in the non-fasting state, and vomiting is also less, and this becomes very useful for us. She need not get repeated the test. And in the PHC, GH, or where the crowd is more, they all want something which is very easy, but at the same time, it will prevent the mortality and morbidity. And all these problems, our professor, Dr. Seshia, always used to say that Indian problems need Indian solution. We are all Indians. All these practical problems make them unable to come in fasting. Dipsy solves the problem. We need to be very careful in this because we are going to save 2 generations, that is the mother herself as well as the child. We need to educate the medical officers and paramedical staffs on whom to screen for GDM, when to screen and how to screen. Of course, in our country, it is a universal screen because we are 11 times more sedentary, and they all have late marriages. After that, they delay the child, more PCOS, there is no insulin resistance, we have an unhealthy lifestyle. All these again adds to the genetic predisposition, so we need a universal screening. There is no doubt that every other pregnant woman has to be screened. Of course, the usual recommendation is so far at the late trimester, that is 24 to 28 weeks. But the present, according to the national guidelines, is the first trimester, that is the very first visit, if possible, pre-conceptional control. But remember, if found negative in the first trimester, you should not stop with that. You have to repeat the test in the second and third. And why, when it has to be screened, early, because all the congenital anomalies, they occur before 6 weeks, that is 8 weeks of gestation, and the fetal islets, they develop by 4 to 6 weeks and starts functioning by 11th to 12th week. If you are delaying the diagnosis to the second trimester, what happens? The fetal cells, they will take care of the mother's blood sugar, high blood sugar. As I said, if it crosses 110, there is more secretion of insulin in the fetus, and this hyperinsulinemia is the problem for all the non-communicable diseases later, and this will continue. So you have to screen early in the first trimester or in the first visit. Again, I want to say that our professor again has shown that there is helium occurring in all the three trimesters, the first, second, and third. And now this they have shown. This he has shown in 2007, and again he has repeated that in 2017 and shown whatever incidents he has shown has doubled, and we are getting less cases in the third trimester. This was highlighted in the 2020 ADA economic clinical lecture. There is a paradigm shift. Our Indians have shown long back this, and we have how to screen. Of course, it is by the national guidelines. Whenever the patient enters, the pregnant lady enters the clinic, you just give 75 grams of glucose and do a single test 2 hours 140. This is again as Dr. Dharmarajan was saying, this is a GTP test.
Don't be worried that normal glucose tolerant was already at this glucose load is not going to alter or increase the blood sugar, whereas it will happen if she happens to be GDM. There is no chances of false positive or overdiagnosis or underdiagnosis. Remember, the 2-hour forced glucose is to be more than or equal to 180. The advantage of this test is the pregnant women need not be fasting, non-fasting to simplify the procedure and cause these disturbances in the pregnant women's routine activities and serves both as screening and diagnostic procedure. And again, this fulfills the expectations of WHO and what they say in low socio-economic countries like India, we have to do something in pregnant women, whatever they can, depending on the resources available. That is to screen every pregnant woman for glucose abnormality for a diabetes generation in the future. Most complicated problems in this universe have a very simple solution, said Albert Einstein. Like says, given a simple test procedure with 75 grams of glucose in fasting or non-fasting state and just one value to diagnose like IgG, it is more than or equal to 140, and for further monitoring, just remember all
post-meal 2 hours has to be within 120. That's all. It's very simple. And how to manage, of course, 90% of DDM can be managed with proper lifestyle. That is with medical nutrition, therapy, and exercise. Only if after 2 weeks, still if the blood sugar fasting is more than 90 and 2 hours more than 120, think of adding insulin. Insulin is the best drug of choice during pregnancy. What insulins can be used? Of course, human insulin, all can be regular, intermediate, and mixed can be used. And rapid-acting analogs, aspart and not glucosamine, and fast-acting aspart PS, very good in pregnancy. Analog mixers, no mix, analog mix, all can be used. The long-acting glargine, Dapagliflozin, not approved, and also Residual is not approved. Metformin is an alternative. You can start after 20 weeks of pregnancy. Nothing can be done. And remember, lactation is very important because it has got a favorable effect in the maternal metabolism and protects herself and the child against all these non-communicable diseases. And whatever happened because of TDM, it reverses all the metabolic pregnancy adaptations and reverses the metabolic, better metabolism. And prepartum, the postpartum follow is more important than the prepartum care. Because we need to follow these ladies. They are the ones who are going to develop, as Dr. Dharmarajan said, they have to be caught and they have to be prevented from getting diabetes in future. So you repeat the test in 4 to 6 weeks and after 6 months and every birthday of the baby. Only thing, the fasting is enough if it is less than 100, not like 90 during pregnancy. And the 2 hours again 140, it is pre-diabetes. Above 200 is diabetes. So the timely action now taken in screening all pregnant women for glucose intolerance, achieving euglycemia in them, and ensuring adequate nutrition may prevent in all probability the epidemic of diabetes and all non-communicable diseases. Thank you.
Thank you, ma'am. Wonderful session. And I thank our organizer for this arrangement. Thank you very much, ma'am. Any discussion, any questions from the audience?
So okay, something about transgenerational effect, what is happening with fetus and progress and we develop to diabetes or is there anything in addition to controlling blood sugar? Is there anything to do to prevent the
Yes, that's what is transgeneration. But it's genetic is of course it will be transmitted from generation to the we all the epigenetic system adds to that. That is the environmental factors during pregnancy. Folic acid, of course, it helps, but it has to be given high doses, homocysteine, all these are vitamin D, all these are useful during pregnancy. But the thing is, we have fuel to the fire. It is already, we are more prone. But still, through environment, we are loading more. So this again gets transmitted. The overloaded thing gets transmitted again from generation to generation. Thank you.
Thank you, ma'am. With that, Dr. Chandrasekhar, thank you.
Close the session and move on to the next session. Thank you.
We move on to the next session. I invite Hypertension and cardiologist chat session. The first speaker will be Dr. We're talking about extended repeat how to interpret and utilize for daily practice. The next speaker, I think, just is the word that is handed in the airport. But I think you are we have 1 or 2 minutes over the chat.
Good morning, everyone. And thankful to the organizing committee and the Chandrasekhar for inviting for this wonderful conference on cardio-metabolism. I think cardiology has been so far, and only the heart as heart muscle vascular organ. Everyone is thinking about heart attack. Heart is so much metabolism. Metabolism in general nowadays means primary diabetes. We have understood that the disorder of carbohydrate metabolism. Unfortunately, it's not true. It's also everything. We metabolize protein, lipid, carbohydrate. We are going to have 2 topics now. Dyslipidemias, probably in general as well as in diabetes. And I welcome Dr. Dapagliflozin to talk about this. So we are going in depth into
IPS workshop ಐತಿ national workshop.
Welcome Dr. Dapagliflozin. Colleagues and friends. Today in the next 15 minutes or so, I'll be talking on extended life profile.
2,500 registration fees. ಎರಡು ಒಂದೇ. ಇಲ್ಲ ಯೂಶುವಲ್ ಹೆಂಗಿರ್ತೈತಿ ಒಂದೊಂದು ಕಾನ್ಫರೆನ್ಸ್ ಅಲ್ಲಿ ರಿಜಿಸ್ಟ್ರೇಷನ್ ಮಾಡಿದ್ರೆ ಯು ವಿಲ್ ಬಿ ಅಲೌಡ್ ಟು ಪ್ರೆಸೆಂಟ್ ಈ ಪೋಸ್ಟರ್ ಇವ್ರದ್ದು ಸಪ್ರೇಟ್ ಮಾಡ್ಬೇಕು. ಸ್ಟ್ಯಾಚ್ಯೂ ಆಫ್ ಯೂನಿಟಿ, ಲಕ್ಷ್ಮೀ ವಿಲಾಸ್ ಪ್ಯಾಲೇಸ್, ಸಯಾಜಿ ಗಾರ್ಡನ್, ಸಾಗರ್ ಆರ್ಕಿಯಾಲಜಿಕಲ್ ಪಾರ್ಕ್, ಜಂಬುಗೌಡ ವೈಲ್ಡ್ ಲೈಫ್ ಕಬೀರ್ವಾಡ, ಹಜೀರಾ ಮಕ್ಬರ, ಮಹಾರಾಜ ಸಿಂಗ್ ಮ್ಯೂಸಿಯಂ, ಸರ್ದಾರ್ ಪಟೇಲ್ ಫ್ಯಾಮಿಲಿ PM E temple, Hatti Mata temple, Trimandir, Sri Aurobindo ashram, these are the places to visit. Conference venue is 1.5 kilometers.
Patients have hypertriglyceridemia, then or the LDL
Flight right.
in the extended life profile is also very high. So
On the way to Ahmedabad.
the usual formula, which is what applicable only if the right less than 400.
Yeah,
The value includes LDL, IDL, and LCA. And the South Asian population has never been validated, and there's a lot of fallacies of the pre-12 formula. And non-HDL cholesterol is a very simple measure. It measures all the atherogenic upper B containing lipoprotein. And the total cholesterol estimation and HDL estimation
Ahmedabad airport in the
we mean that total cholesterol minus HDL and LDL. So what is the definite positive correlation to this? So whenever the total cholesterol increased, LDL increased, HDL is decreased, non-HDL cholesterol increased, ApoB increased, and LPA increased. These are all where we have definite positive correlation to this. However, the treatment targets, what are the targets we can reach? One is LDL target, non-HDL cholesterol target, and ApoB target. And why I'm trying to highlight this is because if we reach the LDL target, always there is a tendency to kind of de-escalate, whereas we will not check whether we have reached non-HDL and ApoB targets. Only when we reach all the three targets, I think there is justification de-escalation. So Indian dyslipidemia, all of us always look at this and we kind of underestimate low HDL, LDL high, and we call it dyslipidemia. Sometimes LDL is not so black. Low HDL. And look at predominant majority is that it's
ಏನ್ ಬೇಡ ಬಿಡ್ರಿ ಅವೆಲ್ಲ ಅಂತವೆಲ್ಲ ಸೀದಾ ಇರ್ಬೇಕು.
LPA, how are we going to use it? Measurement, visualization, and the interpretation of data. And how do we look at ApoB measurement and concordance and discordance in LPA? LPA is a particle and it's mapped to chromosome 6. And the ApoA component shares structural homology to plasminogen and competes with the plasminogen binding site, resulting in reduced fibrinolysis. And we know that LPA is thought to speed up the process of atherosclerosis by binding to LDL, calcium, and other components of the vessel wall in the atherosclerotic path. That's got pro-inflammatory properties, and it's been linked to stroke and also.
ಎಲ್ಲಿಂದ ಎಲ್ಲಿಗೆ?
But in the first bar,
the father of.
ಎಲ್ಲಿಂದ ಎಲ್ಲಿಗೆ? ಬೇಡಪ್ಪ.
What's our point?
And they found that 25% and chromosome and atherosclerotic disease.
Dr. Rekha.
Levels remain constant throughout life in men. And in women, so when we get an LPA after the age of 2, LPA is going to be giving a good part of this diabetic cancer. That LPA from 40 small isoforms deteriorate over time. So anything less than 20 is low risk. And 50 is high risk. And anything more than 180, this is like
ಇಂಟರ್ನ್ಯಾಷನಲ್ ಕಾನ್ಫರೆನ್ಸ್ ಹೇಳಿದ್ರ ಮಂಜುನಾಥಿ ನಡೀತಾ ಇದೆ ನೋಡ್ರಿ. ಲೇಟ್ ಹೇಳ್ಬಿಟ್ಟು ಇಲ್ಲಾಂದ್ರೆ ಇವಾಗ ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ತೀವಿ. ಇಟ್ಸ್ ಅನ್ ಇಂಟರ್ನ್ಯಾಷನಲ್ ಕಾನ್ಫರೆನ್ಸ್. ದುಬೈ ಕಾಲೇಜ್ ಒಂದು ಚೆನ್ನೈ ಕಾಲೇಜ್ ಸೇರಿ ಮಾಡ್ತಾರೆ. ದುಬೈನಲ್ಲಿ ಮಂಜುನಾಥ್ ಅಂತಿದ್ದಾನಲ್ಲ ಅವನು ಹೇಳಿದ್ರು 1,500 rupees ಆನ್ ವರ್ಚುವಲ್ ಚೀಪ್ ಅಂಡ್ ಬೆಸ್ಟ್. ಚೆನ್ನೈನಲ್ಲಿ ನಡೀತಾ ಇದೆ.
Dr. Naik, please silence yourself. Please mute yourself.
So, specifics now is that LPA greater than 50 should be a risk enhancing factor, and LPA more than 180 is a lifetime risk, like that of familial hypertension. So, when do we screen for LPA and when do we treat? Premature atherosclerotic vascular disease, family history of premature CVD, and recurrent atherosclerotic disease. This despite optimal lipid lowering treatment and poor response to maximum lipid lowering therapy. And after an ACS, we use it for risk stratification. And also, for every 10 milligram reduction in LPA, the risk reduces by 5.8%. But then, this is not the primary focus, that we don't try to go after the LPA levels. And only those patients who are fortunate to get the PCSK9 inhibitors, then the LPA reduction is by 25%. And now move on to ApoB. And ApoB in a single line says that it unifies, amplifies, and simplifies the information from conventional lipid models. And the atherogenic risk is attributable to the ApoB lipoprotein. And we want to say about ApoB, with the principal event in atherosclerosis is the retention of ApoB containing particles that is involved. And in general, we have to consider that ApoB is a marker of residual risk. It is also a primary target if we are able to get ApoB done for all patients. And when do we measure ApoB? In patients with elevated triglycerides, diabetes, obesity, metabolic syndrome, and low LDL post-treatment. Low LDL post-treatment is a situation where we have to be sure whether we are justified in de-escalation. And statin therapy reduces LDL more than ApoB. And this is the reason why there is a discordance once we start treating with statins. And the goal for ApoB is less than 8. So this is the interplay between ApoB, LDL, and non-HDL cholesterol. So the lowest is when the ApoB is low, the LDL is low, and the non-HDL cholesterol is low. If we reach all the three targets, then the lowest risk. And of course, conversely, the highest risk will be when high ApoB, high LDL, and high non-HDL cholesterol. But then if you have this discordance that there is a low ApoB, high LDL cholesterol, and high non-HDL cholesterol, still the risk is low. So the ApoB is really a true reflector of the atherogenic potential. And if you look at a high ApoB but low LDL cholesterol or low non-LDL cholesterol, HDL cholesterol, still there is a discordant high risk. That's why we still have to continue statins and try to hit ApoB targets. So the effectiveness of statin therapy, if you look at once you initiate statin therapy, the LDL cholesterol drops by around 42%, the non-HDL cholesterol drops by around 40%, and ApoB actually drops by around 30%. So what happens is once you initiate the therapy, it looks as though that ApoB lags behind the LDL cholesterol reduction. And what is the treatment goal? According to the American Association of Clinical Endocrinology, the ApoB goal is for high-risk patients is less than 90, and for extreme-risk patients is less than 70. And the Lipid Association of India guidelines, I want to take a few minutes on this because this was far ahead of its time. When it came out in 2015, we thought it was too extreme. But then, for Indian patients who had high risk of coronary artery disease and who had premature coronary artery disease almost a decade earlier than their Western counterparts, this guideline actually is quite exhaustive and is quite very much evidence-based. And there's not much of type C here. And it says that if your goal ApoB for extreme high risk group, and so I'll just try to go to the next slide, where we'll be looking at the risk stratification and according to the Lipid Association of India. So now the extreme risk is something we need to concentrate. Anybody who has got CAD with more than one risk factor of the very high risk group, that is pre-existing atherosclerotic disease or diabetes with two major risk factors, or familial homozygous hypertension, or the category A, which is CAD with more than any feature of the high risk group. So if you look at this, then the targets are very stiff. The LDL target is less than 50, and our LDL target is almost even up to 30, and ApoB target is 50. And of course, they have classified all the risk factors for major atherosclerotic risk factors and other risk factors and the non-conventional risk factors. These non-conventional risk factors has not been given much importance in the other guidelines. And also when to do calcium scoring and when to use lipoprotein A, because this lipoprotein A, even at 20 to 49, should be considered as a risk factor. So non-HDL cholesterol is a simple tool. There is no extra cost. It's well standardized and measures all atherogenic lipoproteins. And it measures the excess atherosclerotic risk due to small, dense LDL. So if you cannot do an ApoB, then this should be considered as a surrogate for ApoB. So this is illustration where you can see that non-HDL cholesterol encompasses all the ApoB containing lipoproteins. So the non-HDL cholesterol is a more accurate predictor of atherosclerotic risk, and it's an additional target, especially if the target is less than 100 and relevant in patients with diabetes and hypertension. And lipid association calls it as a pro-primary target, and should not be more than 30 milligrams of the LDL goal for that patient. And also it's useful for monitoring patients on therapy and does not require a fasting sample. And for any patient whose non-HDL was more than 100, is a threshold for therapy in addition to LDL cholesterol. And a disproportionate increase in non-HDL cholesterol is seen in familial risk fetal hyperproteinemia and in patients with elevated LPA. So now I go to the practice problems where this was an extended lipid profile done for a young patient, 30 years, who had presented with hypertension and dyslipidemia. Now, in this young patient, his cholesterol is around 200 plus, his non-HDL is 167, LDL is 149, the lipoprotein is 79, his HSCRP is elevated, and ApoB is also high. So straight away he goes to moderate to high risk, and for him a SPIF target of LDL 75 was kept in mind, and he was started on moderate dose statins. This was the second patient whom I had stented, and this patient is on follow-up. But for him, if you look at the targets achieved, his LPA is 68, so this is a patient who has got a high risk, so you have to be constantly on the watch with this particular patient. I reached a good ApoB target of 74. LDL cholesterol still remains high. So for this patient, he's on sustained dose of 40 milligrams of rosuvastatin along with estimate. The third patient is something he's on therapy, he has been stented. His lipoprotein A is only 4. When you look at his triglyceride was 272, his HDL was 6, non-HDL was 142, and I was still worried what is happening, and his LDL cholesterol is 61. Quite worried what's happening to this patient and why we are not able to see a reasonable HDL. So the problem is HDL has got multiple isoforms, and it all depends on the kit being used. This was repeated in 2 labs, and we got the single bit value of HDL. And then I repeated this in our reference lab, and this is what the patient had. His triglycerides was 687, HDL cholesterol was 68, and non-HDL was 134, and LDL was 106. So this patient is on high dose of statin, estimate, and he's, he was counseled for PCSK9, but is not at the moment taking it. And also Dapagliflozin was started for elevated triglycerides. So to conclude, actually, when you look at all the tests, we have to look at is the test able to quantify them? Is it telling the truth? And does it tell the whole truth? Is it giving the full picture? And does it obscure? Does it do too many details to obscure the findings? If you kind of leave this criteria here, the best evidence for looking at residual risk is with ApoB, then with non-HDL, and then with LDL cholesterol. So I will end with an unusual case of inferior volume MI. So this is a 34-year-old male who presented with inferior volume MI. He was not thrombolized because after loading dose in heparin, actually his SPA settled down. He had no traditional risk factors, and he was taken up for coronary angiogram the next day after medical stabilization. So this was what his angiogram showed. So what was worrisome in this patient is that, of course, the circumflex is occluded, but what was worrisome is a thrombus which is hanging in the left main. So this left main thrombus, fortunately for this patient, was a large left main. So this was not occlusive, and it had followed the part of the thrombus had followed the rheology and gone down to the circumflex. So initially, I was first thinking, had we got a thrombus, was something from the catheter had gone inside. But then we are very sure that this is a thrombus which is moving, and rheologically had gone down and occluded the circumflex. So now what we did, I did the right side and then thought, okay, let's do intracoronary pharmacotherapy. And after 15 minutes, what we saw that the thrombus started melting in front of our eyes. And with the same diagnostic catheter, we went inside and aspirated out this thrombus and post-thrombus aspiration. It looks quite clean. The distal circumflex has also started flowing. And for the angiogram or for that intervention that day, it was a very good result. And it was a pharmacoinvasive with no stent and no thrombolysis. So this patient, I got him back after 5 days of heparin and thought I must know what's happening in this patient and got an OCT done. This was the first OCT which I did in my institution, and this was an eye-opening and practice-changing for me. So that's why I want to share this OCT. After 5 days of heparin, you can see that the circumflex is recanalized. Of course, some trained eyes can pick up that this is a sluggish flow here, but then it is recanalized, and for all practical purposes, this coronary arteries look quite okay. But then when we started the OCT, I want to pause here. So this is a classic Lago phenomenon. You can see that the atheroma is there in the LAD, and the vessel size has actually increased to accommodate the plaque, and almost is 4 millimeter vessel. So this is the plaque, and as we enter the left main looks quite okay. This is the plaque in the LAD. And we were more interested to see what was the problem, why the thrombus formed in the left main. So I will just try to freeze the point where we found the pathology in the left main. So what we found was a plaque erosion. And plaque erosion, you can see here that this area has eroded, and you can see some thrombus fragments. So plaque erosion is one of the common mechanisms of atherothrombosis. And this was a patient whom I left alone. Only thing what I did was kept him on high dose of statins and estimate. He did not show any prothrombotic state during follow-up. He had immediate dyslipidemia, low HDL, high non-HDL cholesterol, and LPA was normal than during follow-up. And he developed diabetes 1 year post-index event. So I wanted to conclude saying that estimation of residual risk is to be done, and it is to be always for secondary prevention. We have to hit all the targets. There is ApoB target, non-HDL target, and NDL target to keep the plaque quiescent and stabilize the vascular. Thank you very much.
Any questions from the floor?
Bempedoic acid experience is quite limited. Of course, it's going to be, if at all, if I'm going to use bempedoic acid to reach these targets. So the only market for us, see, the vessel wall, stabilization is with statins, and the pleiotropic effect is with statins. Bempedoic acid helps to reduce the cholesterol, but the pleiotropic effects are not like as strong as that of statins. For additional LDL lowering, I would be using it.
Dr. Mohan, what we had asked, actually, there is a paper last week in JAC, I think JAC was which says that the absolute numeric reduction is more important. It really doesn't matter if you do the high intensity statin, the pleiotropic effects, it seems to be slightly going away after it. Initially, we said only statins are pleiotropic, but then estimate started working, PCSK9 starts working. So it looks like probably the numbers are more important. So in future, we may have more say about the numbers than the statins. Here, projected three case reports. If you notice those 3 case reports, all 3 had an LDL that was calculated by feed-wall equation. When you go for low levels of LDL cholesterol, the feed-wall equation error margin is 50%. It's very high. That's one of the reasons why I think he's not able to achieve targets. And so you have to do a direct LDL or probably apolipoprotein B. Actually, apolipoprotein B costs about $500. 400 to 500 is good. So I think that's a better market and better way to do it. Now, if you average using feed-wall equation, there is a newer equation called the Sampson equation, which came in 2020, much superior to the feed-wall equation. Probably do that. In fact, I published a paper on that showing that the error margin is much less in the Indian population.
The reason why when we use the feed-wall equation, it's never been validated in South Asia. That's why we try to hit as many targets as possible. You can hit ApoB target as the best because you have achieved near reduction of the atheroma risk. But once you take LDL, that low LDL, what happens? There's still non-HDL high and ApoB high. That's why we try to, I do all the three. And I'm doing 1 year course, high dose statins. How do I know that I've achieved, whether I can de-escalate? Only if I reach ApoB targets and non-HDL targets, I de-escalate.
Why do you de-escalate?
I don't de-escalate, that's what I'm trying to say. Because the thing is, when we want the plaque stabilization, it's only with statins, and we want the vessel wall to be as stable as possible.
Thank you, that's a wonderful point. And regarding this cholesterol, this estimation, the more important is oxidized LDL and small LDL, rather than the apoprotein, LDL, VLDL, all these things. Yes. So instead of measuring all these things, is there any way to calculate the oxidized LDL or small LDL so that we can directly focus on this rather than going around and
for small dense LDL, the non-HDL cholesterol actually encompasses with small dense LDL. There's no separate measurement.
Okay, there is an article by Snyderman which shows the difference between cholesterol-rich LDL particles and cholesterol-depleted LDL particles. Both have different mechanisms of action. More or less similar to what you're saying as oxidation or oxidized LDL. The cholesterol-depleted LDL particles both have apolipoprotein B. Both get attached to the vessel wall. Cholesterol-depleted LDL, once it gets inside, is taken by the macrophages and then it is destroyed and it produces inflammation, plaque rupture, and acute coronary syndrome. The cholesterol-rich LDL particle is taken inside the cell, deposits the cholesterol, increases the plaque size, and comes out. It's not destroyed. The ApoB particle stays out, and the LDL is still waiting away. So mechanisms are different. So both are harmful in different ways. Mechanism is different. That is the reason, one of the important reasons why we say, look at ApoB, get ApoB down. Your thing about checking with the oxidized, non-oxidized required very highly advanced immunogenicity technologies. It's all possible only in reference laboratories. It's not possible in clinical trials.
I think I can make a comment on this. See, all these risk factors are polygenic in nature. Even a high lipids we have come across is not affecting the vessel wall. So it is the interaction between the other risk factors that matters. If you know the relationship between the blood cholesterol and serum cholesterol, you know the answer. What is the relationship? We expect a linear relationship. It's very, very difficult to prove that point. Because the endothelial, there should be an endothelial dysfunction, there should be a destruction, and these LDL particles generally can invade the vessel. So at sufficient blood pressure. So that's why we are linking the mean blood pressure, endothelial function, as well as the absolute level of voltage. So all these things are acting together.
EPA plays a lot of importance. It's not just a therapeutic factor, it's an inflammatory factor also. That's what it contributes more to our health. Generally, to take at EPA levels, there are not much steps to reduce the EPA. What is this? We decide the dose of statin, whether we go for statin more aggressively in this group of patients. Is there any other implication?
Patient who has got high LPA. So this is a patient whom I keeping very much on follow. He'll be on high dose. His targets are going to be anything. LDL targets are going to be less than 55 for this patient because he's at high risk for both atherosclerotic coronary disease and stroke. So and also young patient when we see a patient with this patient, we see the additive risk. Always we have to look at LPA because it's a South Asian population. We know that patients who subset to got premature atherosclerotic disease, the LPA levels tend to be high. So I think it's a good risk stratification tool. And also patients who have coronary disease, it's a good time to stratify it. At some point in life, any male patient should have had a LPA done, and a lady should have it done once, even after menopause.
Happy, a very good point about LPA. Whatever he says is correct, 100% correct. Be very clear. The LPA correlates more with aortic stenosis than with coronary disease. It's more correlated. How to reduce LPA? There are two ways. PCSK9 inhibitors reduce LPA. The problem with the reduction of LPA is most of the reduction is shown in percentage, while most of the persons are a normal group, it doesn't work. So you look at absolute reduction of LPA.
So very high level patients alone, if you look at it, you bring LPA. What brings it down? PCSK9 inhibitors will bring it down. Now there is phase 3 trials going on with antibodies. mRNA, M-sense antibodies. It's going on, so it's not yet come out. The point that what Dr. Venkatesan said about high levels of cholesterol, plaque disruption, you don't need any of that, sir. It has clearly been proven in at least one study that, not one study, it is now accepted there is something called plaque years. The total cholesterol into the number of years of exposure. So let's say you have 150 for about 4 years. And your age, you're going to have it for about 40 years for 150 LDL cholesterol. Your plaque burden or LDL burden is 6,000. Only after 5,000 coronary artery disease manifests. So 5,000 is the threshold, or it's now called the ASCVD threshold. It's both for hypertension and LDL. Cumulative burden is very important. That's the reason why we say earlier the better, lower the better, and longer the better for LDL cholesterol.
Measure HDL. The values above 65 are by themselves atherogenic. So many people have the concept that higher the HDL, the better. That doesn't seem to be true.
High HDL is a protective factor, yes. But then if they have high LDL, that needs to be treated. Because, therapeutically, if you have somebody who's got a low HDL, getting it up, there's no therapy which has been shown to be beneficial. Of course, there is HDL high is beneficial, protective, but does not obviate, does not decrease. If the LDL is also high, then we need to get the LDL down.
6-7 years ago, the first time I heard about HDL being bad was by Krishna Seshas. Yeah. Krishna spoke about that and showed that the dysfunctional HDL can actually be harmful.
Yes.
And in fact, European Society of Cardiology has accepted this, and it has come up with a ballpark figure of 90 milligrams. If your HDL is more than 90, it is actually harmful because it's dysfunctional HDL. It can work like LDL and it create all harmful effects. But having said that, the reason why HDL does not work, like increasing HDL by therapeutic means does not work, is because what you measure as HDL is not the functionality of HDL.
Yes.
You measure only the absolute number of cholesterol inside. It doesn't do the reverse cholesterol transport. It increases. All the studies have shown 100%, 130% reduction with all these what drugs are called?
Torcetrapib. Torcetrapib failed.
And all those drugs. They also bring down the LP little a.
Yes.
But they're not shown benefits. So what you need to do is you need to be careful. And HDL as a risk factor, but physiological increase is beneficial. Physiologically, by exercise, if you do it, it is beneficial. But drug-wise, it doesn't seem to be beneficial. I think these guys want to close the session. They wanted to extend the session for a few minutes. That's why I've been talking so much.
Thank you for all the enthusiastic participation.
Thank you
very
very
nice
much.
session, and I think it has generated a lot of interest. And the Lipid Association of India can be proud of its origin today because of so much interest in lipids in all sectors.
Dr. Vamsi Mogan, Dr. K. Mohan on stage to chair the next session.
Good afternoon, everybody. Let me start with thanking Dr. Chandrasekhar and the organizing team for this wonderful opportunity. There's a slight couple of events. Dr. Krishna Shetty would be talking the first thing. He's a ABA certified diabetes metabolism and internal medicine consultant in endocrinology and diabetes metabolism. Specializes in type 1 and type 2. He's a professor and head of endocrinology and diabetes in Sri Ramchandra Institute of Higher Education. Thank you, sir.
I may age, but I think the slides don't age. I have other affiliations. Okay. So I should first get hold of Dr. G. Vijay Kumar and tell him that you got me into this trap. I think for the last decon, he asked me to do this talk, and for some reason, this talk has gotten into people's mind, and I get to do this. But the nice part of all of this is that while I get to do all these unusual talks, I learn the most. I'll try to make it as simple as possible. It's a very, very complicated issue. And that's why we don't have clear answers. But I'll talk about things like we talked about just a few minutes ago. I think I talked about dysfunctional HDL about 2014 or 15, and talked about the protein that is involved is PON-A. And thanks for remembering that. So why do some patients do well? I have an uncle who's no more now, but he was 75. He developed diabetes when he was 50 probably, died at 84. He was on half a tablet of Rastinon, right? And he would not eat his food without payasam. Very clear. And my mother was his favorite cook. And the first thing he will say is chakara porada. So even if my atte would say, this man will come to my mother and say, so that is how he was. On the other hand, you will find another patient who's absolutely not doing well. 2 years in diabetes, they're inching closer to dialysis, right? Why do people do differently? No conflicts of interest for the stock. So let's look at a couple of things. One is genetics involved? Is a question that we all have. And then, of course, is the environment involved, which is another question that we all know. But does the environment affect the genetic expression of disease is the third question. So whether we develop diabetes, whether we have hyperglycemia, or whether we develop complications, these seem to be based on what we do. Some of the early, and I'm going to tell you that this is early work, was done when the Swedish study and then subsequently Dr. Mohan's data from India on choosing a large population of patients and allowing a computer-based algorithm to see if there are some common threads. We use something called k-means clustering. There are other machine learning techniques that are available that can deep dive into an algorithm, into a database, and show you what are the predictors of what patients are doing well. And you will notice in these clusters, the one that doesn't do well, of course, is this one, the cluster 3. But none of these seem to have any genetic markers. They did about 5 genetic markers, but none of these had any genetic markers that predicted the expression of bad disease, right? But it is very interesting because subsequent work on these clusters showed that the cluster that did bad actually was doing higher markers of inflammation. So clearly, this amount of work that looked at the clinical features actually showed something. But I can tell you, this is the beginning because the future seems to be something even more. So let me go through this quickly. So we have genetics, and there are some markers of genetics. Then some scores that are developed from genetics. Then I'll talk about this very exciting protein called TXNP, which I think is going to be a marker that we're going to use very soon, and therapeutic target. Spend a little time on epigenetics. I don't want to bore you with too many details, but just to tell you that this is the future of medical care, and I'll sum it up in the end. To take you back into history, this is the Jocelyn medalist cohort. What do you mean by medalist cohort? These are people with type 1 diabetes in the Jocelyn clinic who have diabetes for more than 50 years, type 1. Which means these are people who have already selected out to be very good, right? And in the Jocelyn medical cohort, they looked at what was the predictor for longevity. Good way to look at it, right? You will see that irrespective of what you have, not more than 30 to 40% of patients did badly. Very interesting. But there was only one predictor of who did worse. And that was the presence of rage. Again, telling you, remember that this is an old study, 2011. I'm much younger than that, right? So just to remember, why am I saying old study? Because the tools that were used 10 years ago are inadequate for the kind of stuff we are seeing today. with technology and the GWAS and the genomics, our children and grandchildren, many of your children are probably doctors. You will not recognize the way they practice medicine 10 or 12 years from now. So I'm just giving you this heads up. So let us see and go to this. The first thing you understand is who you are determines, where do you live determines what kind of disease you have. If you're Mexican in origin, you probably do very badly. If you're Caucasian in origin, you probably do very well. In many of these studies, you'll find, and I'll show you the Accord study, the Caucasians did well. So if you choose your parents wisely and choose the country of origin wisely, you probably do very well. Just to let you know, we have chosen our country quite wisely. But if you look at the history of diabetes, and if you look at non-autoimmune diabetes, right, you will find a few proteins or few genetic loci that mark excess amount of diabetes, but none very important. In fact, you may identify a few rare causes of diabetes, but there are no common markers of either diabetes or its complications. In isolation, genes don't do very well. If you do the GWAS, you will find that you'll find a lot of common variants, but their dose size, how much do they contribute to the incidence of diabetes, or how much they contribute to the complications of diabetes, you will find it is very low. So that is why a genetic alone approach has never helped. I don't want to go into this. Let's move on. So you will find a whole bunch of detections of genetics that are available through GWAS. And today GWAS is a old technology. But what you realize is that it is not the genes related to diabetes that are important, but the genes that are important in regulating metabolism and inflammation that seem to be more important in determining if somebody is going to have a complication or not. Just one point. So genes that regulate are probably more important than genes that determine this. Second, there are things that we haven't heard about in the last 30 years that are making impact on the outcome of diabetes and any disease. One of this is how is a gene rearranged? These are called copy number variations. In many diseases such as Turner syndrome, in my own specialty, you will see that the copy number variation actually determines how it is. Is it a recurrent rearrangement? It's a non-recurrent rearrangement. Is there a problem with how the chromosome recombines? I'm just giving you a Tiffin sampler. You can go into each of these slides for 45 minutes. But how these genes are arranged and rearranged determines the expression. Is the gene fully coming in? Is it half coming in? Is the gene arranged in the right way? Each of these determine the expression. But I want to tell you that even these are not responsible for all the effects. They are part of the spectrum that I will show you. For example, even more important than whether a gene is present or not, how is the gene transcribed is important. See, we are able to see this is like a blind person seeing an elephant. We're seeing bits and pieces of it. The full picture is not available, but it's important to understand this. For example, this FLCN is a gene that is involved in diabetic retinopathy. If you have diabetic retinopathy, the transcription of this gene is different. If the gene is transcribed in one way, you don't have diabetic retinopathy. It's transcribed in another way, you do have diabetic retinopathy. So it is not just the presence of a gene, it is how the gene is expressed that seems to be even more important than the genes. That is why you're not able to get genetic markers. You only get some SNPs, single nucleotide polymorphisms that work, but more importantly, and remember, till 5 years ago, we did not even have the tools to look at these, but now we do. And that's why we are seeing this. Let me bring you to something we know. You remember the Accord trial, right? I'm going to use this as an example. The Accord trial, remember, long duration of diabetes, those who had intensive control did worse than those who had standard control. Correct? The question is, beautiful question to ask. Is there a subset of those people in the intensive control group where the intensive control could have worked? Beautiful question to ask. Are there some people in the intensive control where intensive control will actually help? The first study that came out with this showed that if they had a combination of 3 polymorphisms, this was called the genetic risk score, that group did worse. One minute. Right? But that's scratching the surface. So for people at that time, we're talking about the genetic risk score. But that's not application of technology. Let's look at the technology. So in the Accord study, they took people and they looked at the A1C trajectories. And then they found a clinical cluster, just like the cluster study. Then they divided these people into 4 groups and found a cluster that was actually benefiting by intensive control. So that was right. So here is that group. This is the intensive group. And there was a bunch of people, the C4 group, that actually did well. These were people who are not on sulfonylureas, who are not on insulin, who had shorter duration of diabetes, who are also not on metformin. Not all of them, but this is a clinical group that did better. It had the lowest risk of hypoglycemia, but had MACE positivity. Very interesting. Low MACE, some clinical characteristics. Then they took these people and then they GWAS'd them. Very interesting. A very different approach. When you did that, you found some proteins or SNPs that were present in this group. For example, this MASH1. Right? So there is a clinical group that is doing well. If you did a genetic profile, you found these particular SNPs. Don't worry about the names. And it showed that if you had these SNPs, you were doing better in terms of MACE. Beautiful concept. Don't worry about the details, but just understand how they're approaching it. So what they showed is, what you can now do is, you can take a bunch of people, the clinical characteristics are present, they have these genetic markers, and you can predict, for this patient, don't worry about the A1C, you want to bring the A1C down and they will do well. For all the others, keep the A1C at 7.5. See how this information is helping us make a decision. So how do we simplify this? Look for one marker that tells you all this information. And it looks like increasingly that marker is this particular thioredoxin interaction protein, TXNP. Cardiologists will remember this. It is in the endothelial, it is secreted in the endothelium. But the reason to know this one is from the 2000, our first understanding was in 2002, but we know that TXNP is the most regulated protein by glucose. If you have high glucose, TXNP is the first thing that is produced. And it is involved in the redox pathway. That means it's a harbinger of any metabolic abnormality that is present. If you have high TXNP, you're going to have complications. If you have low TXNP, you don't have complications. It's an evolving field, but let me give you the previous. It's like HDL that I talked about 5 years ago. So TXNP, remember I've talked about this, I won't spend time. But this is a talk I give very often. Basically, there is a glucose fatty acid partition. What happens in diabetes? Glucose generates its own metabolism. Fatty acids control its own metabolism. Because we eat at odd hours, there is no partition between glucose and fatty acids. When that is not present, the mitochondria dysfunctions, there is ROS production, there is apoptosis. At the same time, there's TXNP generation. Works through the inflammasome. That is, causes inflammation, apoptosis. In fact, TXNP When TXNIP is present in the pancreas for a long period of time, the beta cell undergoes apoptosis. When it's present in the heart, it causes cardiovascular dysfunction. This is what happens normally, but you can see that when TXNIP is present, the reactive oxidation species, it causes dysfunction. TXNIP is increased in neuropathy, in MACE data, but very interestingly, and I want to stop with this and go to the next one, is that it is controlled by calcium channel blockers. In several studies, we saw that patients who were started on verapamil, their MACE values were actually lower and people started looking at it. Not consistently reproduced, but one of the targets is to get a good CCV in at some point of time, and that reduces TXNIP. Again, don't do it tomorrow, but this data is coming. Lastly, epigenetics. One, histone acetylation. Anything that the environment does imprints the body and targets it. They were talking about GDM today. Remember, it is epigenetically modified. If the mother is thinking of Kuttu dance during pregnancy, the Kuttu dance is imprinted. If the mother is looking at a beautiful face and smiling, good thoughts are imprinted. They are imprinted. But what does do? Hyperglycemia, what it does is it activates certain genes that cause the imprinting of that information. For example, look at this. This is what is happening when hyperglycemia has occurred. Some proteins are imprinted there. Some changes are imprinted there that remain and they are heritable. I won't go into it, but this is what happens. Of course, miRNA. This is another whole story. So it works through histone acetylation with DNA methylation and miRNA. miRNA 204. Don't worry about these numbers. Just worry about the big picture of what is happening. Give me an example. So this is a normal retina. In hyperglycemia, if there is a genetic background, remember I said FLCN gene and its expression. If it varies and the environment is also conducive, TXNIP is present, right? The epigenetics are impinged. Then at some point of time, the diabetic retinal barrier works down, there is neuronal apoptosis. So what is happening is multiple factors determine that include duration of diabetes, your genetic makeup, the kind of risk factors that you have, the presence and whether TXNIP is up-regulated or down-regulated, ultimately lead to this final common pathway. And this is the pathway. I won't spend time on it, but it also impinges on how drugs work. You know, it's not only how diseases express itself, but how drugs work. In some patients, drugs don't work, right? 10% of the patients on GLP-1 RA or an SU or an MF, the drug doesn't work. How does it do? It is exactly through these pathways. Some amount of genetic background, some epigenetic expression, the drug interaction itself that causes it. This is what we do in our EMR. The information that at some point of time, we're not going to be just using genetic. We're not just going to be using clinical. We're probably going to get a microbiome sample. We're probably going to get a chip. That information is going to be put in, and then the treatment is decided based on each of these factors. And that's the impact of what we're going to do, right? 10 years from now, your kids who are doctors, you will not recognize them. It will be like in Star Trek, right? But they still have to talk to patients and communicate. In fact, let me go out on a limb today. The next drug that is going to be developed is not going to be by serendipity. It's not by molecular mimicry. It's going to be by a machine learning program that has looked at various combinations. And it's quite possible that sometime, based on the information that I shared with you today, that drugs will be personalized, right? So this is my summary. So the genes set up the base, the environment fires it, multiple factors combine together to give an expression of disease and its complications. And understanding these, and we now know that there are markers. TXNIP is the most important of them, but inflammation is the simplest of them. Each of these determine how the disease gets expressed, or its complications get expressed. And today we are also starting to think about how these can be addressed by understanding this. Again, I've tried to make a very, very complicated environment into some simple understanding points. Don't get worried about the numbers, the SNPs, but just the overall concept. And again, thank you for making me read more and more into this. I really appreciate it. Thank you so much.
Questions? Thank you, sir. Very, very interesting lecture. So one point, sir, this Jocelyn metals, they're all type 1 diabetes.
Yes.
And from that, we also learned that some advanced glycation end products were protective rather than destructive. That was the statement they gave. But which advanced glycation end products they're not sure.
So the most important I didn't talk about is the methoxyglycol. It seems to be the most representative of the RAGE products. And we know that that is the key to the expression of the disease. Others are probably, some of them are protective, but the one that is most important is methoxyglycol.
TXNIP that correlates with insulin resistance. Is there any link between those?
Yes, there is. Yes, there is. In fact, in insulin resistance, anything that causes expression of glucose increases TXNIP. Anything that decreases glucose expression decreases TXNIP. Interestingly, I did work on vitamin D and GLUT transport about 7-8 years ago. TXNIP is actually vitamin D upregulation protein. It's very, very interesting, the relationship between vitamin D and TXNIP. It looks like, you know, I wish I could go back. Maybe I will go back to the lab and look at. We did what is called siRNA knockdown. One of the few in vitro studies that I've ever done. Is we did a knockdown of the vitamin D of the vitamin D receptor, and we're looking at GLUT expression. Meaning, I wanted to see if vitamin D contributes to insulin resistance. That's what we did, and we showed that GLUT4 was reduced and vitamin D receptor was reduced. What would be interesting, and I didn't know about TXNIP then. What would be interesting is to see we knock it down. What happens to not just GLUT4, but is there a coexisting decrease in TXNIP? So very early days again, but this is fabulous stuff. Be very careful. Anything that comes with reversal, app-based, don't have to use drugs. Please be very careful. And I don't have stock in any of those companies. But what is important to remember is that ultimately, the best way to conquer this is to eat less, eat more sparingly, and definitely there is some data about eating in alignment with the circadian rhythm, right? I think there the data ends, but I think you're right.
Sir, it's a great learning from always your lecture. Learn new things. This lecture has given more points than any other things, sir. So one point I like to know, sir. Suppose to prevent a complication, so to bring down the
Excellent. Yes.
And bring down the methylglyoxal and to improve the gene expression or genetic inflammatory markers to prevent the genetic inflammatory markers. Can you use verapamil, metformin, and exercise? The exercise is supposed to modulate the inflammatory genes in the production of inflammation. So if you combine all these three, can you prevent complication even right from the beginning?
Okay, so metformin, interestingly, two parts, right? You saw the Accord trial. In the Accord trial, metformin use was not associated with improvement. They were not in the C4 group. However, that's just one association, not statistically significant. Second, metformin decreases TXNIP expression. So you have a point there. Third, Dr. Mulasari is here. So verapamil, I would be careful about verapamil. We have data on verapamil as an association, but not necessarily, prospective randomized trials. There are several studies that are going on, at least 2 studies that I know that are going on, but of adding a CCB and seeing how things work. But you really need huge numbers.
Any other questions from the audience? Thank you very much, sir.
Somebody got up? Yeah. Can you shout?
So recently, a lot of benefits have been like elucidated about intermittent fasting and lowering like the oxidative stress. Is there any like role of that in diabetes control and the outcomes?
Okay, so that's $1 million question. I can give a full talk on it. But I think what is important is the bottom line of all of these is that it reduces calories. Correct? Caloric restriction is the reason that they benefit. This is one. Any additional benefit of time-restricted fasting, time-restricted eating, right? The data is double-edged. The Chinese study says no benefit. The US study says benefit, right? But I would think the Chinese study was not looking at hypocaloric diets. Is there added benefit of time-restricted eating on hypocaloric diets is the big question. We don't have data on it. But all of these ultimately work by reducing the amount of food you eat. And that's all it is.
Thank you very much.
Okay, thank you.
I welcome Dr. Sandeep Mahajan. He'll be talking another very interesting topic today, non-proteinuric diabetic nephropathy.
Well, good afternoon, everyone. First, thanks to the organizing committee, Dr. Chandrasekhar, for having me here and for some excellent hospitality. Well, the whole day we have been having some really very fascinating topics, very fascinating talks. And as a specialist, it's always better to actually go to a more general conference and get to know what more is happening in the other fields, which is not aligned with you or not directly related to you. So it has been a huge experience for me as far as the learning is concerned. So what I'm talking about today is non-proteinuric diabetic kidney disease. So, well, we have, let's see a case scenario, which in fact was a patient we saw in the clinic just few days back. He's a 65-year-old gentleman who has been a diabetic for 12 years, diabetic for 15 years, hypertensive for 12 years, has had coronary artery disease for which he has undergone a bypass surgery 2 years back. And it was at that time when it was noted that he had an impaired, he had a chronic kidney disease with a serum creatinine of 2.5, which would be approximately a GFR of around 26. He has been on a follow-up for past 2 years with some nephrologist and an internist, and his current creatinine is 3.2, which again is a GFR around 7 mils lower than what he had at the baseline. He has had no evidence of either neuropathy or retinopathy. The albumin creatinine ratio is less than 30 and has no evidence of obstruction on an ultrasound. He is currently on a mixed insulin regime with statins, aspirin, and losartan, as you would expect. So what I would be talking about today is that are these really patients of a diabetic kidney disease? And in addition, what more we can do for these patients to prevent the subsequent progression to end-stage kidney disease. Well, this is what we conventionally believe a diabetic kidney disease behaves like. We initially have a stage of hyperfiltration, which then progresses onto a stage of microalbuminuria, and then to macroalbuminuria. And it's at this stage or a cusp of micro to macroalbuminuria that you would have a decline in renal function. And with each progressive year, you would have progressive decline in GFR and a rise in albuminuria till they reach the stage of end-stage kidney disease. And this is what we classically see in the histopathology, the classic nodular or KW lesion. What we have to realize here is that this classic cause of diabetic kidney disease was done around 4 to 5 decades back, before we had regimes of good glucose control, multi-targeted therapy with good blood pressure control, statins, antiproteinuric agents like ACE inhibitors and RAS. So this is the conventional understanding of a diabetic kidney disease. However, we have to realize that in a good set of patients, if not majority, you have a significant dissociation between the albuminuria and the glomerular filtration rate or the renal function. So a non-proteinuric diabetic kidney disease is classically defined if you have a GFR of less than 60 and a urine albumin creatinine ratio of less than 300, that is a stage of microalbuminuria less than a macroalbuminuria. So what I would be talking about in next 10 minutes is to give a broad concept of non-proteinuric diabetic kidney disease and its prevalence, highlight the clinical features and their outcomes, what could be the presumed pathogenesis which makes them different from a proteinuric kidney disease, and how to manage these patients. Well, the concept of non-proteinuric diabetic kidney disease is comparatively new. The first report actually came around 2 decades back in the 3rd National Health Assessment and Nutritional Examination Survey, which showed that of around 1,200 patients who had diabetes, 14% had a low GFR. And interestingly, what they found was that 81 of these patients who had a low GFR actually had normal albuminuria. So what they found was 80% of patients who had a low GFR or had kidney disease actually had a normal albumin, which is quite opposite to what we normally believe. If we look at a more restricted or a more well-preserved cohorts, the CRIC cohort is one, which showed that the incidence of patients having a low GFR with a normal albumin is around 28%. And 3 beautiful cohort studies from Europe, Asia, and Australia again have reconfirmed that around 1/3 of the patients who have chronic kidney disease actually would have a normal albuminuria. So if you have to see, around 1/3 of our patients who have chronic kidney disease with diabetes would have non-proteinuric diabetic kidney disease, so which actually is a huge burden. What about type 1 diabetes? If we look at the ADDIC study, which is follow-up of the DCCT, again, they showed that 25% or a quarter of patients who had chronic kidney disease were actually non-proteinuric. And another cross-sectional studies from the Steno group actually showed that 58% of the patients with type 1 diabetes having chronic kidney disease were non-proteinuric. So the incidence, if we believe, is anything from 30 to 50%. It is common, it is prevalent, and it definitely requires better study. So what are the clinical features of this cohort of patients? The clinical features that have been associated or reported with non-proteinuric diabetic kidney disease is increasing age, female gender, history of smoking, absence of retinopathy, and higher prevalence of coronary artery disease. However, we have to realize that all this is predominantly from various cross-sectional cohort studies. There is no definitive study which has prospectively followed up a cohort to see which patients develop proteinuric and which patients develop non-proteinuric disease and how are they different. Hardly any study has reported biopsy findings. So most of them are actually presumed chronic kidney disease of a diabetic etiology. They could be of other etiologies as well. And most importantly, you have varying definitions and methodology which have been employed in determining whether these patients are non-proteinuric or proteinuric. So there comes the conflict of normal albuminuria, non-albuminuria, non-proteinuric, and proteinuric. So we all know that proteinuria is different from albuminuria, but these studies would try to use them interchangeably. And this is the basic flaw of majority of these studies. So this is a meta-analysis which was just published last month. This basically looks at comparison of non-albuminuric and albuminuric diabetic kidney disease. Again, as I said, some study would call it as proteinuric and most of the studies nowadays call it as albuminuria. And if you go by the current KDIGO guidelines, even albuminuria is no longer the term to be used. We use them as moderate albuminuria, moderate proteinuria. So this basically looked at 31 articles, of which 18 looked at differences between non-proteinuric and proteinuric diabetic kidney disease. And what they found was that the patients were older, more often, more likely to be females, had shorter duration of diabetes, had better diabetic control, lower HbA1c levels, lower incidence of diabetic retinopathy, and interestingly, lower use of RAS inhibitors. We would have presumed that they would have high use of RAS inhibitors because they were normal albuminuric. However, interestingly, there was no difference in either lipid profile or the BMI in these patients. Well, this is our experience which we presented last year in the World Congress of Nephrology. We looked at 400 type 2 diabetic patients who had chronic kidney disease, of which 106 were non-proteinuric. So around 1/4 were non-proteinuric. If we looked at the difference between non-proteinuric versus proteinuric diabetic kidney disease, again we found that these patients were more likely to be older, though as opposed to the Western world, our population is a lot younger. They develop complications at a much younger age, so it's at least a decade earlier. The Western population had an age group of 65 to 68. We are talking about 56. They had lesser diabetic retinopathy. And again, we also found they were less likely to be using RAS inhibitors. So maybe we still start RAS inhibitors if the patient is albuminuric and don't start RAS inhibitors if the patient is non-albuminuric. Interestingly, we didn't find any difference between the gender, the duration of diabetes, other comorbidities, the BMI, the blood pressure, and the glycemic control. So interestingly, we all believe that if the patient is more albuminuric, he is likely to progress to chronic kidney disease faster. So these are the patients whom we categorize as high risk to progression to chronic kidney disease. And this is there in all guidelines, including the KDIGO guidelines. So what happens to these patients who are non-albuminuric? It's believed that they have a low risk of progression to end-stage kidney disease. So 20% of them would progress to end-stage kidney disease in 10 years. But still, if we see these patients, if we compare these patients to those who have non-albuminuria without diabetes, the risk is still around 8 times higher. So even though the patient is normoalbuminuric or non-albuminuric and has diabetes, his risk of developing end-stage kidney disease is still 8 times higher as opposed to a person who does not have diabetes and has no albuminuria. The annual decline in GFR, this was noted in a cohort of patients after 60 mils per minute. That is what we call as chronic kidney disease stage 3. For non-albuminuric, microalbuminuric and macroalbuminuric was 1.9, 2.1 and 3. So though these patients are at a higher risk in those patients who don't have albuminuria, but it's much lower than patients who have gross albuminuria. Interestingly, these patients had a significantly higher risk of death of causes other than chronic kidney disease. So they still represent high risk profile of having other cardiovascular complications, if not end-stage kidney disease. Similar results have been noted in type 1 diabetics, including the ADDICT study and the steno cohort, which I had talked about. So now, what about the outcomes in meta-analysis? So we only had 5 studies which compared non-proteinuric versus proteinuric diabetic kidney disease. And what they found was that there was a lower annual eGFR decline in non-proteinuric diabetic kidney disease. However, if we compared patients who had non-proteinuric diabetic disease versus those diabetics who didn't have any kidney disease, the risks were inconsistent. But interestingly, the adverse outcomes, especially death, were much more common in patients who were non-proteinuric. What had been our experience? We had a very short follow-up of 1 year, and what we found was that these patients had around 9% risk of doubling of serum creatinine, which is in chronic kidney disease a valid endpoint. And good 5% of them actually in a year required dialysis. So in our cohort of Indian patients, as opposed to what we have from the Western population, even in this non-proteinuric cohort, we have a higher risk of renal deterioration as well as need for renal replacement therapy. So how is the pathogenesis different from a proteinuric versus non-proteinuric kidney disease if the basic problem is diabetes and hyperglycemia only? As I highlighted that the classic non-diabetic kidney disease cohort, which is proteinuric, was described in patients prior to strict BP and diabetic control and use of nephroprotective agents. the higher prevalence of non-proteinuric diabetic kidney disease could actually be just a reflection of better care of diabetes. The patients are surviving diabetes longer. And this could be because of increasing age and duration of diabetes. And that's why we are seeing these patients, which we were not seeing 3 or 4 decades back. And these patients therefore have higher microvascular complications, including coronary artery disease, cardiovascular diseases, and peripheral vascular disease. And this macrovascular complications are leading to increased vascular resistance and accelerated nephrosclerosis. In fact, there is a process, there is a thought process that non-diabetic, non-proteinuric diabetic kidney disease actually is just nephrosclerosis, which we had classically with long-standing hypertension. So it's only the patients who have diabetes are surviving longer, having complicated diabetes are surviving longer, and that's why you are having now patients who significantly have kidney disease without proteinuria. But as I said, even internationally and even in our cohort of patients, duration of diabetes actually was lower in patients who had non-proteinuric kidney disease. Again, because we are using RAS inhibitors more frequently, then the patients who otherwise would have been albuminuric are made non-albuminuric because of the use of RAS inhibitors. Again, data from the cohort studies is not consistent regarding this. We have had patients who actually were using lower RAS inhibitors, both in our study as well as in the international cohort, and still they had normal albuminuria. So the pathophysiology, the pathogenesis actually is supposed to be slightly different from what we have in proteinuric kidney disease. So what happens in classic diabetic kidney disease is a stage of hyperfiltration, which leads on to glomerular hyperfiltration, leading on to nodular nephrosclerosis, proteinuria, and therefore a decline in GFR. While in non-proteinuric diabetic kidney disease, it's predominantly the macrovascular complications, the oxidative stress, which play a major role in progression of kidney disease. The pathology, again, very few studies have really looked at the pathology between, because we rarely perform biopsies in a diabetic kidney disease. And that's the reason we have very few pathological slides. The largest study actually had only 30 biopsy specimens. And again, higher tubular interstitial chronicity, less of glomerular lesions, more of arterial lesions is what we find in non-proteinuric diabetic kidney disease. So how do you manage these patients? Unfortunately, whatever data we have, whether we talk about RAS inhibitors, whether we talk about the SGLT2 inhibitors, they have systematically excluded patients who don't have albuminuria. So you talk about the renal trial, you talk about the life trial, you talk about the various SGLT2 inhibitors trial, and if you see the fine print, GFR less than 30 and proteinuria of less than 300 or 500 were excluded. So you don't have really huge data as to how to treat these patients. Also, if you have excluded proteinuria, then how to identify these patients who are likely to develop chronic kidney disease but don't have proteinuria? Because once we follow up diabetes, we only see albuminuria. The moment we see albuminuria, we see this is the patient who is likely to develop chronic kidney disease. But we are talking about a cohort which developed chronic kidney disease without albuminuria. And there comes a role of ultrasonography. There has been a study which has shown that renal resistive index, which measures the renal vascular resistance, actually can tell you if it's more than 0.8, that these are the patients who have intrarenal complications, have higher nephrosclerotic burden, and these are the patients who are likely to progress on to chronic kidney disease. Potential therapies, I believe there is no reason to believe otherwise. We should have a good glycemic control, we should have a good BP control, we should have a good lipid control, we should be using RAS inhibitors, we should be using SGLT2 inhibitors. They should be beneficial even in non-proteinuric kidney disease. Interestingly, only Empiric trial reported outcomes, renal outcomes in non-proteinuric diabetic kidney disease. So if you see the Empiric cohort, what they showed was that they still had a significant patient, around 46% patients who didn't have proteinuria, but had a GFR of less than 60. And they, in their supplementary data, did report as to what were the outcomes. And the patients, even if they had a GFR of less than 30, had a significant decline in progression of chronic kidney. I think so. It's my last slide, sir. Diabetic kidney disease clinically and pathologically is heterogeneous. And this is the one point which I have to highlight and give you as a take-home message. Not all, in fact, 30% of the patients who have diabetic kidney disease don't have albuminuria. So if you understand that, I think so my job is done today. They have a lower risk of progression to end-stage kidney disease, but interestingly, as they have a similar risk of cardiovascular and all-cause mortality. So they need to be followed up and treated aggressively. This phenotype, unfortunately, is easily overlooked and is often associated with lesser use of renal and cardioprotective regime, as we had data from ourselves as well as the international data. Absence of albuminuria necessitates use of new biomarkers for early diagnosis and understanding pathogenesis of this non-proteinuric diabetic kidney disease. As I highlighted, these patients unfortunately have been excluded in all the major studies. Some data to suggest that SGLT2 inhibitors might still be beneficial in this cohort of patients. And this study, a lot of study still needs to be done in this cohort of patients to actually give final answers. Thank you.
Thank you, Dr. Mahajan. Because of lack of time, we are posting section now. Only one point of clarification, sir. What exactly is the cutoff?
300, below 300. By definition, we still make it below 300. So that would still be a stage of macroalbuminuria. So microalbuminuria has been included in non-albuminuric kidney disease.
Thank you, sir.
So excellent presentation again. What we doubt is there are some people with chronic kidney disease with the normal uremic, like urine output is normal. There are people with the same levels of creatinine that will be oliguric. So can this be applied the non-proteinuric nephropathy with the non-oliguric nephropathy? Can you translate like that, or can you correlate such a correlation? Is there any such a correlation?
No, there is no such correlation, sir. In fact, the commonest or the earliest symptom for any kidney disease actually is nocturia. So the tubular concentrating defect is the first thing to go. So even if you have an oliguric kidney disease, if you go back in the history, the patient would have presented with nocturia and poor tubular concentration. So as the kidney disease advances, especially the glomerular disease, you would have oliguria. A tubular interstitial disease is predominantly a concentrating defect, so you don't have oliguria. So oliguria basically differentiates a glomerular disease from a tubular interstitial disease. Not really.
Thank you. Sir, in fact, the old teaching was that people who have too short period from diabetes, or people who do not have proteinuria, or the causes of disease is not due to diabetes, you look for other causes. That was the teaching.
So one of the indications which we say the patient is non-diabetic kidney disease was that the patient does not have albuminuria. But as I said, 1/3 of the patients who have no other cause for chronic kidney disease still don't have albuminuria. And that's why this concept of non-albuminuric diabetic kidney disease has come up. The only...
spent long years in IFG IGP status by the time the macrovascular.
So my take on this is most likely our care of diabetes has improved significantly, and the patients are living with diabetes and its complications much longer. And that's why it gets translated as chronic kidney disease, which could be just because of cirrhosis. And you don't have albuminuria as a classic disease. But the incidence is also increasing. So it's both the incidence as well as prevalence which is increasing by leaps and bounds.
Thank you so much, sir.
Thank you.
Thank you, sir. I think I request both the chairperson to continue. We will request Dr. Ajit Mullah Sadi. He is the director of Madras Medical Mission, an interventional aggressive cardiologist. Now he is going to talk about preventive cardiology. What is the way ahead? Whether we can prevent all the interventions, I think we will learn from him.
Can I have my first slide?
Sorry. So I'm glad I'm speaking on this because this is of a lot of interest to me now because of some work I've been doing on this area. So why are we talking about this today? If you look at last week, what happened, the first patient with familial heterozygous hyperlipidemia got a one-shot gene CRISPR-Cas treatment for familial heterozygous hyperlipidemia from New Zealand through Verve Therapeutics, which is a one-shot fix, hopefully, for high cholesterols, especially LDL. So it is no more the future, it is today. And 40 patients are on this phase 3 trial in humans, where one treatment will set your lipid levels at least for 2 years, your LDL below 30. So we are talking about this, and it's very interesting because the person who runs this company is Shekhar Kathiresan, who's from Chennai. And he was in a hospital a few years ago, and I did some study with, he was in Harvard before, and we did some polygenic work with him. And he was very happy to tell me that the first patient got recruited on the study. Now, traditionally, you know, we used to look at your family history, we could look at sugars, we look at lipids, we look at blood pressures. We look at ASCVD scores, which are app-based scores to look at your risk, whether you're low risk, you're intermediate risk, or you're high risk, and then decide about treatment for these patients. And we are limited, obviously, treatments. We have just got, change of lifestyle, you have statins, and then the usual antihypertensives and anti-diabetic treatment. But things are now changing very, very rapidly in this landscape. And I'm telling you, in 5 years, you will have a lot of new treatment because of how. Now, the important thing in this whole group is, do these traditional methods of evaluation help you to screen patients? And the answer is clearly a no. So we have novel invasive techniques, non-invasive techniques, and this is a very common thing we use, which is a CT scan for a calcium score. You have arterial ultrasound, both carotid plaque and CIMT. And then something very fascinating, which I think Krishna Sheshadri spoke on diabetes, which is a fact today, and that is polygenic risk scoring. And then is the proteomic markers of various issues like inflammation, lipids, and stuff like that, which is the multi-marker risk for CAD. Now, so despite conventional risk treatment management, cardiovascular disease is increasing. And especially in the West, in middle-aged women, it's increasing. In India, it's increasing over the whole spectrum. And timely initiation of therapy is the most important thing for primary. The question is, when do I start or should I start? And this is the question everybody asks you all the time. And you can't just blindly give some dose of a treatment, which is you think may be useful for patients. So this is a usual ASCVD risk score I suppose everybody has on his app. A patient comes in, I look at very simple thing. What's your age? What is your, what is your sex? What is your race? What is your systolic blood pressure, diastolic blood pressure, total cholesterol, HDL, LDL, history of diabetes, yes, no, smoker, yes, no, hypertension, yes, no on the statin. And then you define a number and you make 3 groups of people. One is low risk, which in 10 years risk is less than 7.5, an intermediate risk, which is 7.5 to 20, and above 20, which is a high risk group. And then you say, okay, now you are in high risk, so I'm going to start you on something, which could be a statin. And everybody else, you say, okay, you may use lifestyle for some time. Now, is this good enough is the question. And are we missing a lot of patients? And we are sure we are missing a lot of patients by this traditional way. So this is an increasing appreciation of drawbacks inherent in the traditional risk factor-based approach, and a full display of risk factors is not captured, especially chronic inflammatory and metabolic conditions. Especially, we see so many people who are young MIs who come to you who do not have anything, maybe only smoking as a risk factor, but most of them are not diabetic, no hyperlipidemia, no hypertension, nothing. First event, myocardial infarction, which can be the most drastic event. And although risk factors and disease enhancers like psoriasis, family history, rheumatoid arthritis have been suggested, but they don't capture the whole thing. And how do we capture this whole thing is the question. So these can be captured to personalize the risk of a patient, and these are categorized as imaging, which is calcium scoring, not CT coronary angiogram, just simple scoring. PRS or polygenic risk scores, multiomic strategies, and this will precisely get your risk estimation and put preventive measures through. So what is chronic artery calcification? You put a patient onto a CT, no dye injection, just look has his calcium to something called as Agatston scoring. And these current guidelines of ACC and ESC use CAC scores were intermediate. That is, when you have 7.5 and above is where you use the calcium. Below, you don't put the patient under the CT because there is some radiation for those patients. The clinical risk calculators like the ACVD scores and other scores tend to miss younger individuals, women, and again, when CAD is clearly placed, will the calcium scores predict it is the question, because calcium ultimately, remember, is a tomb of the atheroma. End of the day, it's like your tomb of atheroma. So it takes time. You need a disease with a long time to get calcium into your arteries. So if you get a young issue, would you get a calcium score? That is the question you need to do. So this is a simple scoring which you do in your hospital. This is a colorful picture, but basically what it shows is calcium, and you can see calcium in the coronary arteries, and you put the score in the left main LAD circumflex right. You put the total score, and you say, okay, your total score is about, there are 16 lesions. The score is 705. So you're above 100, but below 1,000. So you're in an intermediate risk score. Very simple, 10-minute scan, and you know this. Should we put these to all patients? The answer is no. And why not? I will tell you. So the absence of coronary artery calcium and all-cause mortality. And this is a very important thing which is published in JACC. And this is a very simple study, which I have not been able to show my pointer here, but what it shows is that if you have a 0 score, your survival is excellent up to 12 years. But that is not true in certain subset of patients like young patients. But overall, if your risk scores are 0, very low. If your risk scores are 1,000, you can see your survival is 85%. So clearly, your risk scores tell you where you stand in calcium in terms of your survival. If you have calcium score which is high only in one vessel or no vessel, it's better than in 3 vessels. So it's not only the amount of the score, it's the amount of the territory involved with the calcium scores. And this again, you can see is the association of survival with the number of vascular territories. And finally, the cumulative survival of scores more than 100 and less than 100, which I talked to you. If you're less than 100, you can be relaxed a bit. If you have 0, you're fantastic. If you're 1,000, you're worried. And if you have 1,000, which are in multiple vessels, you're more worried. So this is the way you look at patients. So a calcium score of 0 is associated very low, right? Statin therapy is suggested for calcium scores more than 100, where your intermediate risks are more than 7.5. You can reclassify an intermediate risk group for an upgrade of his risk with the calcium scoring, and it is superior to traditional risk factors in predicting outcomes. So it's a key tool for primary prevention, and we should use it more nicely in our practice. Not everybody, but use it usefully. But the predictive cover is good, but the relation to underlying atherosclerosis is poor. For example, if you have a soft plaque, which is typical of a young myocardial infarction, you don't get calcium at all. But above 60 years, if you get a calcium, you're more or less predictive. There's a JAMA paper, less predictive, less than 60, but above 60, very predictive. So again, we can't use, there's no test in medicine, which is a fit for all. Remember that. Everything has to have some caveats and attachments. Now, the type of calcium is also important. For example, if you have diffuse low density calcium, which is seen in CT, that's a high risk group. But you get a focal coalesced sheets or nodules, they are more stable plaques. So these are the unstable plaques. Those are the stable plaques. So the type of calcium is also important. So you have to get your radiologist to tell you what is the type of calcium you have. Spotty calcium increases risk. Microcalcium, you can't see it on CT, but on OCT and IVS increases risk. Volume increases risk. At individual plaque level, a grade 1 marker of stability. So there are two diverse issues going on. Calcium is important, but the type of calcium, how it behaves, how it is seen on the CT and other tests is also important. So a high-risk vulnerable plaque is a harbinger of ACS, but calcium scores and vulnerable plaques are independent predictors, and elucidating them is important. Despite total coronary calcium or an agastin derived clearly correlates with the risk, we need to be clearly sure about the local calcium burden and the type of calcium. Vulnerable plaques have less calcium and they have microcalcification rather than dense calcium. Remember that. And precise intraplaque calcification is important. And this is a nice diagram, not going into details, but showing how the calcium comes. And the clear important thing, what I described before in that simple slide, was what this shows, that it's a type of calcium which is important. So taking the paradox of this calcium and CAD relationship, we need to be clear what we are saying in a patient who's coming to you, especially with ACS. The disadvantages of calcium scores reduce power of the zero in patient groups, which are young adults, especially smokers. There's some cost to obviously a CT, and there's some radiation exposure. The next is a CIMT, which is now currently going out of fashion, because we used to say carotid intima gets disease which corresponds to atherosclerosis, and you could measure a CMT by ultrasound. If it's less than 1, it's okay. It's more than 1, it's a problem. But this correlation is now not clear, so it's sort of going out. Carotid plaque density is another way we can use non-invasively to see how bad, because if you have bad plaque here, you're going to have bad plaque there in the heart. So we can use those things, but I think that this is going to be less likely. In the last 1 year, if you look at every journal copy of the New England Journal of Medicine, the JAMA or the JACC, you'll have at least 2 papers on polygenic risk scores. And that's why this is important. What is polygenic? I think Krishna has made it very clear. You have something called single nucleotide polyphenols. Most diseases of, diabetes or lipids or hypertension are not single gene disorders. There's only familial heterozygous or homozygous, which is clearly one gene, or monogenic. But most of these are polygenic. And what does the simple mean of polygenic? There are multiple single nucleotide polymorphisms. Each of them in isolation don't do the problem, but in combination do the problem. And if you add all these genetic risks together, you get a score which is validated in what we call as GWAS. The GWAS scoring is in a particular ethnic population. You run these peptides, which are creating disease in small order, and see as a combination what is at risk. And that is what you create a PRS score. Most of these PRS scores are created from huge banks called as UK biobanks and stuff like that, but it's very important. Why? We just published a paper in JACC from India. The PRS score of Indians is 30% more than the Western population Caucasian, whether you're born in India, you're in Bangladesh, or you're a UK citizen of Indian origin in the United Kingdom. So you carry your genes across, and therefore your SWIS score is good. If you're young and less than 45, you're 2.4 times the absolute risk than a Western Caucasian. So as a South Asian, let me tell you, guaranteed that you are at higher risk for coronary artery disease genetically. And we need to be more aggressive with people. So polygenic risk score is an aggregated effect size of each single individual variant, which can show substantial heritability and is used for both prediction and disease biology. Why is it great? Because it's relatively cheap. Today in India, there are multiple scores available. You get it for 8,000 rupees. It's not very expensive. It's a one-time cost. That means you do it in your birth or you do it and your 90 euro score is the same. It's not going to change. Your environment may affect it, but this is going to be the same. PRS have very variance, but it can define a lifetime risk to an individual. If my PRS score is 2.5 times what is a white guy's risk at this kind of time, if I take my blood, I better be on 80 milligram of rosuvastatin, even if my LDL is 72. And that's the thing I can take away today. And if my LDL is 140 on a good dose of statin, I will take a PCSK9 inhibitor, because this is the person who's going to, or I am going to be the person getting coronary artery disease. And if I am a guy who can afford, and I'm a familial homozygous hepatocyte, you know that. You give statin, nothing happens to the LDL. They just develop coronary artery disease, they develop stroke, they develop carotid artery disease, they develop aortic stenosis. What do you do today? You no way. You give them PCSK9, it still doesn't fall. Inhibitors, monoclonal antibodies to PCSK9, you don't get it. Evolocumab, you don't get it. Then what do? We may have to do two things. Either do siRNA treatment, inclisiran. It's already available in UK with 2 shots, like a COVID 1 shot and a booster, already available in UK. Or go in for something new, which is studying, which is the Verve Therapeutics type of treatment with a single knockout of the gene. So these are what's happening today. And it's very important that we understand in its perspective what is going on. There's no single CAD post. And I think today it increases your risk stratification in individual. It assesses monogenic disease for sure, but it also helps you to look at polygenic and tailors primary and secondary prevention treatment for these patients. I think we're not going to go through all these scores, but let me just say that these are very, very important. And tomorrow, if you want to do something apart from this ACVD score or your lipid pattern, and you may have to give them a PRS score when you send the patient off from the clinic. Now, is PRS score associated with calcium? And the funny part is that PRS score is more predictive in young patients, while calcium score are in older patients. But a high PRS score means more atherosclerosis progression possibility and will develop calcium in the later on more likely. So I think it's though not linear or straightforward, it has a correlation which is important. And we should look at these as complementary. One is an imaging tool, one is a genetic tool, one is traditional biochemistry, which we look at, and then is the multi-omics like, HSCRP, cyclophin. We saw trypsin antibody testing, which Krishna talked about. So many other multi-omics or proteomics, which is coming into the whole thing. I think the problem here is that most of these PRS studies are Eurocentric. It's not Asian, and we need more data from India, and we hope to create that data. There's a potential for discrimination. You give somebody a PRS score, and you may get a negative, thing for the patient. You may not get his insurance, maybe. We have to worry about these things before you go into all these things. And the communication of the genetics. And also, as I said, if you have a gene which is a problem, doesn't mean you'll get a phenotype. We have seen it with HCM. You get the bad gene for HCM. Everybody doesn't get the bad disease in the family. Some will get sudden cardiac death. Some will be asymptomatic. So the phenotype is an expression of something different and not the genome. Again, I'm not going to go to these, the multiple risk markers which are available through NMR, mass spectrometry, immunoassays. We have some work with serum cyclophin, which is a very important diabetic biomarker. And these will help us in addition to what we have. Now, unstable plaques have a lipid signature, which is based on plasma lipid plus, along with what we see in increased risk markers. I think that we saw in the Jupiter trial that if you have an LDL more than 130, unless your HSCRP is high, you don't need a rosuvastatin. So the same way, you add something onto a basic biochemical test and tell you what you want to do. So I think what we are coming to ultimately is a risk prediction tailored to an age of the individual. And this is a very important slide. When you're virgin coronary arteries and you're young, possibly a PRS score will be useful, because at least it tells me at the age of 30 whether I will have the risk at the age of 50. And one simple thing clinically I ask is, do you have a family history of CAD? If you have a family history of CAD at 50, or your father, mother, or brother had some problem, and you're 30, and you don't have a traditional risk factor which is seen on the test, and you're not a smoker, I will ask for a PRS score, because that will tell me whether I need to statinize the patient and what dose I need to give them. The second is a nascent plaque with microcalcification in a middle-aged guy, where what do? I can use a PRS score and a multi-myox if I do a CT and show. And then is a third group, where there's over the age of 40, mature plaques with microcalcification I will use multiple things to help me out. And finally, in ACS, we still don't have great ways of except intravascular imaging, but that is too late. But when you're having the event, when I put an OCT or IVS, I may get some more information. But today, I think CT will replace that. CT coronary angiogram, we are getting it more correlating with OCT and IVS, and we may be able to help that. So in conclusion, ladies and gentlemen, conventional risk prediction tools underestimate the risk and classify a substantial proportion as low or intermediate risk, which we can upload. We can incorporate coronary calcium score and polygenic and multi-risk scores into this picture. And this will improve your risk assessment. And the future of medicine is not going to be, in my opinion, anything more than three things. If everybody, all of you, I understand, are physicians or cardiologists, the last ACC had Eugene Braunwald talking on the future of training of cardiology trainees. And he said three things. Every cardiology in training will go through genetics, machine learning and artificial intelligence, and some form of surgery. If you don't have these three, your cardiology training will not be complete. Thank you very much.
Thank you, sir. That was a wonderful lecture. I hope none of us are confused so much. And only one thing, sir. When you say a polygenic risk score, in the Indian population, what is the critical number you need to assess or test to get the critical number of the data of the gene pool before you can say go ahead with risk consideration?
So what we did was the European GWAS study was from the UK Biobank, and we have 50 genes which were studied in the UK Biobank. We took the same 50 genes and ran it through 3,000 cases of coronary artery disease and 3,000 controls who proven no coronary artery disease in 18 centers from India, 2 centers from Bangladesh, and took the Indian data of the the South Asian data of the UK Biobank and looked at their PRS scores. What was remarkable was it was exactly the same, 1.3 times. Now you tell me, is 1.1 important or 1.6 important? I don't know, but it is higher than the Caucasian. If you go higher, the worse you become. So that's what you need to learn. That we are at higher risk, that is for clear. Now, whether all of us will develop the disease, not necessarily. If I look after myself, I do good, exercise, I look after my epigenetic risk, I look after my sugars, lipids very early, I will not get the coronary. I don't look after, I may get it. But if I have a 2.4 risk, I'm in certainly high risk. I'm going to take a high dose statin now. I won't tell the guy, go and run on the treadmill and take your diet. That's okay. But this risk is too high for you to develop an event. And I would suggest a good treatment for them. So this is where PRS scores come. Monogenic risk, no confusion. Familial heterozygous, homozygous, we know. We have to get aggressive with them today. But these group of patients which are not sure is what these scores have.
Sir, wonderful. Very excellent learning today at micromolecule level. Sir, one thing is I have a doubt, sir. So when you say that vulnerable block would have microcalcification and stable block has dense calcification. If to form a dense calcification, they should have microcalcification, only then become a dense calcification. Do you say this is more vulnerable? These people are more prone in the early stage than the late stage of the disease?
Okay, so that's a huge topic in itself. What is vulnerable plaque? So vulnerable plaque is a plaque with a high lipid content, which has a thin fibrous cap, which has macrophages in the periphery with neointimal revascularization, and through which the microcalcification spotting happens. This cannot be seen on a CT. You need intravascular imaging to see it today. We see it on OCT. The big calcium, what you get, is the graveyard of atherosclerosis. So a soft plaque becomes hard plaque becomes more harder, calcium deposits, the macrophages take it, dump it, calcium gets deposited and becomes hard plaque. That is a sign of more stable long-term plaque. But if you have multiple hard plaques all your body, it means you have multiple atherosclerosis. So some of them will rupture. It is not saying that for that plaque, it is different, not for the patient. Don't get confused with that. So today we are not clear yet which calcium where, but one thing is clear: as your calcium scores go up and your amount of calcium in the coronary artery goes up, you have more events. If you have 0 scores, your events are very low. Unless you're a smoker and you're very young. That group still we don't have an answer in calcium scores.
I think with this, we'll wind up our session.
Thank you, sir. I think we will need more genetic labs. Yeah. I think the next session will be very interesting and very practical because it deals with most of the physician for assessment of the surgery, preoperative, sometime postoperative. For that, we are going to have a panel discussion which will be led by cardiologist Dr. Prabhakar, very dynamic individual. And the panelists are Dr. Mala, Dr. T.R. Muralidharan, Dr. T.B. Uma Devi, and Dr. Vijay Chakravarti. I think the moderator will introduce the panelists also, and he will proceed with the panel. Perioperative assessment and management of cardiovascular disease in non-cardiac surgery. Over to the moderator, Dr. Prabhakar.
Am I audible? Yeah. Thank you, Dr. Shanmugam sir, for the introduction. And thanks, Dr. Chandrasekhar, for giving a very important topic. But unfortunately, to stand and assess perioperative cardiac assessment just before lunch is going to be a little difficult. We'll try to do how much justice we can do. Now, basically, perioperative MACE is important. It happens in about 5% of patients undergoing non-emergent cardiac surgery, which is going to be 1 in 20, which technically means that it is going to be more or less there every other day in your operative practice. So you have to be a little careful. And to unveil the crystal ball, we have 4 people: Dr. Muralidharan, Professor of Cardiology, and Dr. Mala, anesthetist, all professors here, Dr. Uma Devi, physician, professor, and Dr. Vijay Chakravarti, who's a critical care consultant. He's also a physician and a critical care consultant. So we have 4 people who are trying to unravel it. So what I will try to do is give you a couple of cases, and we will discuss what they practice and are they practicing it correctly. The first case I'll give you is a 50-year-old hypertensive diabetic on OHA for abdominal hysterectomy. This is what commonly the OGs give you. No previous heart disease, blood pressure 150/90, hemoglobin 11.5, creatinine 1.1, HbA1c well controlled 6.9. Case is sent to the physician and the anesthesiologist. Now, first they meet the anesthetist, Dr. Mala. Dr. Mala, what do you think about this case? Do you want anything else further? ECG is normal.
Good afternoon, everybody.
We'll keep it a little
Thanks
short.
for the opportunity given. I'll go through the risk factors fast. So, putting in the clinical risk predictor list, she has anemia, diabetes, hypertension, which is in stage 1, probably 150/90, as given by sir. And her functional status not mentioned. Probably she may be having more than 4 meds. Probably she has no cardiac disease. So I assume that it is more than 4 meds. Or it may be less also, we have to evaluate. And she comes in the intermediate risk as far as the predictors are concerned. So considering the risk, she has to undergo intracavitary surgery. It is abdominal hysterectomy. So I'll put her in the risk group of more than 3% as far as surgical risk for MACE is concerned. So apart from the routine investigations, I'll ask for 12-lead ECG, then echo. Then for the control of hypertension and also for optimization of glycemic status, she's on OHA and she has to plan for major abdominal surgery. And also for the improvement of her anemic status, initially I'll go for physician referral, and I'll get the physician optimizing the patient. Over to
your ASA risk scoring in this case is supposedly? So patient has got a mild systemic disease without any significant problem. So you have a well-controlled diabetes, hypertension, and an intermediate risk surgery. So you don't expect much of a problem in this particular case. So I I have a simple algorithm for people who can do it. This is called the Yample algorithm for anesthetic assessment. Have you heard of this? This is called the Yample algorithm, which might be useful for all of you practically. Y stands for why the surgery, which is what the anesthetist asks. Is it really essential? This is what most of the time anesthetists ask you. Your anesthetic history, medication history, your past medical history, which is going to be system-wise, the last meal and examination. How do you like this? I thought it's a very simple algorithm.
Yes,
So I thought for a non-anesthetist, if you look at it, you will know what the anesthetist is looking for. So with that, we'll go to.
The first point is why the surgery.
No,
that I have
just
no control. Then anesthetic history. Anesthetic history, I'll go through a detailed history. Then any previous history of anesthesia, any allergies.
Madam,
any
you have
untoward
answered.
events.
Don't worry, you have answered all these questions already.
Okay.
So I'm
Then,
just giving you an algorithm. This is just making life simple. Dr. Uma Devi, what is your assessment? What is your take on the case? She has referred the case to you for assessment.
Yes. So first, as physicians, good afternoon to all of you anyway. First, as physician, so history taking becomes very important here. Now, it has been referred as hypertensive diabetic for OHA on OHAs. So first, the detailed history taking. Now, we want to know the functional assessment. That can be taken only by the history taking. Then diabetic history also is very important because is there any micro or macrovascular complications and what is the present status? Then seeing the, like I'll come to BP last, hemoglobin was 11.5. What now during this, when the topic was given to me, I went in detail and I found that now ideally hemoglobin should be maintained more than 13 gram per TL. Now what they say is in a surgery where you expect a blood loss of more than 500 ml, ideal to keep hemoglobin above 13. And maybe in Indian setup, maybe more than 12 for a female is okay. So I will evaluate for anemia, most common now because of hysterectomy, iron deficiency. So if it is an elective, so we can either plan for oral or IV iron sucrose. Then HbA1c 6.9. So definitely more of optimal control is required. Then now during surgery, what is there are two ways. One, we can ask them to stop OHA on the day of surgery. They can undergo, they can plan for surgery, and post-op either insulin or OHA can be restarted. But anesthetists prefer insulin, so I'll start human actrapid, short-acting insulin, monitor the glucose level. Ideally, it should be more than 180 milligram per DL, means less than 180. So more worrisome is hypoglycemia, which we don't want to occur when the patient is in intra-op and post-op period.
We agree with your part. We'll restrict to cardiac aspect. Diabetes, if you go, we are adding some more time because everybody is hungry. So we'll restrict to cardiac assessment.
Yes. Yes, sir. Yes, sir. Yes. Sir.
So do you send these kind of patients to the cardiologist?
BP 150, 90.
We'll come to the blood pressure separately. At this point, do you wish to send to a cardiologist? Which cases do you, both of you, prefer to send to a?
Because I want to know the.
Just because he's here, you don't have to refer.
Sir, I'll see
which is what happens in most of the corporate hospitals.
Sir, I'll see the ECG first. If there is any T wave inversion or if there is any pointers for ischemia, definitely I'll like to know the LV function.
Let's say non-specific T wave changes in bleed 3 AVF. This is what most of the
Still,
ECG
I want to know the LV functions, sir. Diabetes may be having diastolic dysfunction, so the risk stratification is important.
So I think we'll send it to Dr. Murli and ask what his opinion is at this point of time.
I think thorough discussion has been made on this. So two ways to look at it. Like you may help me by giving some more detail. But what we are aiming for, the whole idea is to prevent event. We want to prevent MACE. Cerebrovascular secondary maybe. The coronary event you want to think. So here you are seeing a milieu for a coronary event. Like patient diabetic, hypertensive, we know the lipid status. And we are going to go into the details of it later. But our aim will be, are we going to clear the patient for surgery? Can we have some scoring pattern? That's what I would like to look for. Now we have all the data. Madam has given how to manage diabetes, hypertension, we'll wait for it. In this situation, I would like to think of some of the standard scores that can be imparted among us, among all our colleagues to go in. One is the revised cardiac risk index. That's what we regularly follow in my practice. You can elaborate. It's your slide
No, no.
only.
Basically, I think whenever we do a cardiac assessment, this is probably the most validated score. What Madam said, I will come to that in the next slide and show you. She made 2 additional points about anemia. I will come to that. But the most standardized scoring is just these points. These points, what is the type of surgery? High risk surgery. High risk surgery is basically any kind of vascular surgery. Low risk surgery is anything like an endoscopic procedure or a cataract, breast surgery, or any daycare surgery. Possibly is a low risk surgery. Anything else is intermediate, like you open the abdomen, open the thorax, or open head and neck surgery. Anything else, most of the other surgeries are intermediate risk surgeries. So high risk surgery is one, history of ischemic heart disease, congestive cardiac failure, and cerebrovascular disease. So these are 3 important risk factors. Diabetic already on insulin is a risk factor. The important other thing is creatinine more than 2. So you have 1, 2, 3, 4, 5, 6. You have 6 factors, and as the risk factors increase, the risk for a perioperative major cardiac event increases. So 0 seems to be good, 1 seems to be good, but when it goes more than 1, it is always a risk factor. So you have to be careful. So I think in your clinical practice, when you start looking at it, please look at these risk factors. There are several other risk factors that are available, like the cardiovascular risk index. And apart from this, there is another score. But today what has happened is, this RCRA also, even if you don't have the creatinine or diabetic on insulin, if you remove these 2 also, just look at these 4 factors, the remaining 4 factors: type of surgery, history of ischemic heart disease, congestive cardiac failure, and cerebrovascular accident. They are also equally predictive. So please get those 4 into the history. So you must look at these 4. And as this increases, the risk increases. The other point she made about anemia and this thing is there in another score called the cardiovascular risk index, CVRA, or the AUB HAS index, which includes 2 other points: age more than 75. And they also include hemoglobin less than 12 standard. So these 2 are there. But having said that, it doesn't say anything about preoperative increasing the hemoglobin, because there are orthopedic surgeries which have clearly shown that keeping a hemoglobin of 8 or 10 or 11, the perioperative mortality is the same. So it doesn't change. So acutely increasing the hemoglobin beyond 8 is a little questionable. So we're not very sure about that. But there are several other risk factors. But what I thought is we will stick to one particular score. All of us will try to remember the RCRI, which practically is going to be very useful in all of us. So TRM has already given his opinion and clearly said this is what happens. Now I'll come to Dr. Mala again, or Dr. Uma. One of you can answer this. Now, this is what you were talking about, the blood pressure of 150/90. Do you think it's acceptable? Dr. Uma can go ahead.
Sir, now ideally diabetic and hypertensive, I would prefer less than 130/80. But now this patient is going to go for surgery. So I think 140/90 will be acceptable, sir. And surgery, metoprolol can be continued, but telmisartan will have to be stopped 24 hours before surgery. Now over to Mala.
So many patients, we do take up 140 to 150/90. And the main concern intraoperative will be to maintain the map according to the pre-op measurements. That is the BP that the patient has been used to for quite some time. So depending on the BP, we maintain the map. So the outcome is also good, sir. That is the practical thing that we have observed. There's no need to restrict to 130/80 and all. We don't bring it down. 140/90 we give assessment.
Beautiful
and
point.
we go ahead with the surgery.
Excellent point. Stating that 150/90, don't be scared. Don't go for an ideal blood pressure at that point. Dr. Murli, your point about this.
Same thing. Like trying to make a person normotensive is not the aim of the thing, because we know not only by practice but by strong data that doesn't make an impact. Whereas by making him hypertensive, going to have a massive impact on the outcome of the surgery or the anesthesia. That's the most important. So given a choice, I don't want to stop the thing. But here I would like to open this discussion. Like it's a fear. I do see with my colleagues also anesthesia, like AC and ARB in a perioperative period. Highly sensitive, anesthesia is highly sensitive with these 2 things rather than other antihypertensives. Maybe a few opinions, but little going deviate in the topic. But our aim or the message I would like to convey will be mild to moderate, or even a BP 180 and diastolic even 100 to 110. Most of the time doesn't affect the outcome by data, by practice. So aiming for that to bring it down is should not be the idea of physician or cardiologist, anesthesiologist. We can take up. But most important thing, as Madam said, perioperative, intraoperative, maintain the mean arterial pressure, preventing hypertension, avoiding the low perfusion state is most important.
As far as ARB and ACE inhibitors are concerned, And if the patient is going to have lots of blood loss during surgery, or if we resort to some regional anesthetic procedure like spinal or epidural, it is going to be additive for hypotension. So in that, so to prevent all those intra-op, thinking them in mind, we want to cut short ACE inhibitors and ARB 24 hours prior to surgery, and restart them once the patient start gaining back the original BP.
That's
That
a
is
little bit
our
of
concern.
controversy that you have clearly said, but what she says is very practical, because they say if it is on the day of the surgery, you need not always, but you can withhold the ACE inhibitor and ARB on the day of the surgery. And because if the hypotension happens, it is going to require multiple inotropic supports up to vasopressin. That is clearly mentioned. So be more careful. But actually, between hypertension and hypotension, you look at this BP and perioperative mortality, blood pressure less than 119/63. Basically, hypotension pre-op is more dangerous than hypertension pre-op. Please remember that. Hypertension pre-op can be very high, and it is not a problem. Even a blood pressure up to 180, 110, you need not acutely bring down the blood pressure pre-op. This is for Dr. Umadevi, who wanted a blood pressure 130 or 140. So even up to 180, 110, you are justified. And never start a drug on the day of surgery. That's very, very important. Just before wheeling in, they call you and say, sir, BP is 160, 100. What should you do? Our knee-jerk reaction is give a calcium channel blocker. That is absolutely dangerous, because these calcium channel blockers will actually increase the bleeding. And intraoperative, when the hypotension happens, that's when the drug acts and all kinds of problems. So on the day of surgery, you don't give the drugs. Up to 180, 110, you can take up the patient for surgery. Remember, this is guideline directed and it is not a problem. Beta blockers, I think she had clearly said continue. All of us agree that beta blockers should be continued, but don't start 24 hours prior to that. If you're going to start a beta blocker, start preferably at least 1 week prior to it. Who are the patients you want to start? The high-risk patients. When the RCRA is more than 2, these patients are protected by beta blockers. So you can start beta blockers. So when you see preoperatively, start them at the outpatient. So by the time they come in, they're at least more than 24 hours following on the beta blockers. So beta blockers are beneficial. Any other antihypertensive drugs you want to talk about? You already mentioned about ARB. Any other drugs you want to talk about, Murli?
2 points only about the PISTyle also. PISTyle, though very well done, and it was against using beta blocker, the dose was very high, 200 milligram metoprolol and all. That's what we don't use it nowadays. That's our problem. Other thing is the other trial which tried, probably it's for, I'm not able to recall the name, clonidine was tried, which also negative only, it didn't show any superiority. So currently, if you ask, I prefer beta blocker in our practice, and as you rightly pointed out, we would like to, as you said, rightly start much early, not on the day of.
So if you are giving a diuretic, remember this point also, you stop the diuretic on the day of the surgery. Be careful, look at the hemodynamics and start the diuretics. That's the only other additional point. And never start an alpha centrally acting agonist also at that point. Be careful. The point about intraoperative blood pressure you clearly made, but the one single factor is a mean arterial pressure less than 55, even for a transient time, is dangerous. MAP less than 55 can be dangerous intraoperatively. Be careful. And like you clearly said, there is a clear case for maintaining 10% around the preoperative blood pressure. That is a concept that seems to be working. Yeah, 25%
of baseline.
So that is clearly understood. So try to maintain what your previous pressure was, and that is quite acceptable. Vijay, what's your thought? When do you see post-operative hypertension? When do you start intervening? Vijay is feeling bored, sitting there between 3 people.
No, definitely not. It's a very good talk going on. So post-operative hypertension, this patient is a chronic hypertensive patient. So I'm definitely expecting a post-operative hypertension for this patient. We call acute post-operative hypertension if the patient is having a blood pressure of more than 180/100. But he is already on metoprolol. She is already on metoprolol and telmisartan. Now there is no particular target in the post-operative period. There is no systolic target. There is no diastolic target. There is no MAP target. Only thing I have to see is watch for the hypotension, which is very bad, and the baseline pre-op blood pressure is very important. So my target in the ICU or in the ward post-operatively is going to be the 150/90 plus or minus 10%. That is going to be the target for me. And the problems with the antihypertensives I might be seeing is the beta blockers. Again, it might mask the hypoglycemias and the sympathetic. During the surgery, they were completely taken off the sympathetic drive, so that is going to be there for some more time. And first, the patient might be having a hypertension like around 180, 190 immediately post-operative.
There are several causes for that. Patient factors, yes, he might have skipped the medications, or the sisters might have forgotten the medication. Then the second thing is that pain, bladder retention, all these things should be considered. Inadequate anesthesia, inadequate all these reversals, everything should be considered for the patient before directly jumping into the blood pressure antihypertensive medications. So all these things, and sometimes the drugs, vasoconstrictor, what we use, fluid, what we have given, they would have given 2 liters or 2.5 liters of fluid, or some FFPs, whatever thing they would have transfused. So all these things have been taken to the consideration to maintain the blood pressure around 150, somewhere between 140 to 160. And
advantage of having a physician intensivist is this. He thinks beyond that intensivist point of view and goes beyond. It's, I think, perfectly correct. Look at the pain management, which is absolutely important, because that sympathetic drive is the one that precipitates the cardiac events. So that pain management post-operatively
not only
becomes
that,
important.
the sisters might be doing a suction post-operatively, some suction. Someone would have been palpating the abdomen or something. So everything will stimulate their high sympathetic system, and that is going to cause the hypertension for.
So a little addition. Come again, sir. Yes.
I told bladder distension.
Right. So post-operative hypertension, Vijay was liberal at 150/90, but don't worry, up to 180. It is up to 180. You actually should treat it if there are symptoms of either cerebral myocardial ischemia, cardiac failure, or dissection. Otherwise, a blood pressure of up to 180 initially in the post-operative period is still acceptable. You can be a little more liberal with your patients henceforth.
No, I'm just telling the pre-operative thing.
Now we're coming to that. And when you're trying to reduce the blood pressure, don't reduce it too much, more than 25%. So don't try to reduce it more than 20%. That's also important. Some amount of asymptomatic hypertension is permissible always within the first 3 to 5 days. Don't be strict, because the hemodynamics are variable depending on the several factors that he said. And if it's more than 180, probably the best control is the IV drugs, because you can stop it anytime you want, because you don't know what's going to happen at that point. So IV drugs are going to be very, very useful. So I think we had learned a lot of new things. You can be very liberal in your blood pressure management is the most important thing that we discussed. And the second important thing is use a simple risk scoring like the RCRA risk scoring for preoperative risk assessment. Now this case is going to be for Dr. Muralidharan with a very simple question. Diabetic hypertensive post-CABG on aspirin comes for fitness for cataract surgery. Specific question. We're not going beyond that. What is the role of stopping aspirin in cataract surgery, which comes to all of us? All physicians see these cases. Do you need to stop aspirin?
Simple answer, no need.
No. I think that's very, very important. It's not only aspirin. Perioperative events, when you look at patient on no aspirin use, discontinued or continued use, in fact, the patients who were not on aspirin had more side effects in a large scale study, which is about 10,000 patients data. So it is clearly shown that you need not stop aspirin. Please tell all the ophthalmologists, none of the ophthalmologists believe me that, but I don't know what. So I write that you need not stop aspirin, but if you're scared, you can stop aspirin. That's what I write in my preoperative assessment. Seriously, I write that and send it across. Similarly, with warfarin, there is enough data to say that for a cataract surgery, you may not actually stop the warfarin. There is data to say that anticoagulation need not be stopped, because that's actually a bloodless surgery. Nothing happens in that. So you have to be a little careful and start doing that. What about dental extraction?
Same thing. For aspirin, nowadays we don't bother, but dual antiplator, we get worried. Other anticoagulants, of course, we are really worried, like warfarin or Novax, but that's a little away. Maybe a short term. In fact, we are more comfortable with Novax off late in this situation. We can just skip one dose and get it done. Also, most of the
Yes, ma'am. The answer is started.
Cataract surgery, you are saying no need to stop aspirin. But for cataract surgery, we resort to blocks. So if there happens to be some kind of mishap, intravascular or some kind of mishap, will this aspirin continuation will give trouble?
All these cases had.
On that only sometimes
Agreed.
we stop.
But how often have you seen? How often have we seen data clearly shows that it doesn't happen? We are talking about the ocular hemorrhage, the medical events. Everything seems to be clearly showing that you need not be worried about it. This is what they keep saying. This is what the problem is. Exactly same question keeps cropping up. So nothing happens. And nowadays, all your blocks, you use an ultrasound and give a block. So you know where the vessel is. Retrobulbar, you can't. Fine. So basically, it is clearly mentioned for a cataract surgery.
It doesn't happen. Effects are negligible. But
have you seen one case so far?
No, I have not.
Nothing.
I've given blocks, but I have not seen one.
Right. Same thing for dental extraction or minor oral surgery also. Even dual antiplatelet therapy can be continued. Remember one thing, all these can be stopped by local measures. So no major events happened. So like Murli clearly said, remember for dental and cataract, you don't have to worry about it. And this patient, when they was wheeled into theater, developed an irregular pulse, and the anesthetist was called and found out that there is an atrial fibrillation. So what do you do?
First of all, I will see the ECG pattern, then see the hemodynamic status, if she is stable or not. If it is something related to ventricular event, if it is going into arrest scenario, immediately start CPR and the rest of the
Patient is
thing.
comfortable.
And if it is
No, patient is comfortable lying down. They
Comfortable.
found irregular pulse. Somebody took an ECG and you said atrial fibrillation. So what do you want to do?
okay, if it is atrial fibrillation, what is at hand? If the patient is stable, I will observe. I will not intervene immediately. I will observe. If the patient is stable, I will observe and see whether she is comfortable. Is there anything that is precipitating event? Obviously, we have all the pre-op
Only one
investigations
question for
ready.
you. Only one question for you. You
One.
do the surgery or postpone the surgery?
We will postpone the surgery.
Clear.
Definitely, we have
That's
to
all.
observe and
So
postpone.
obviously it goes to the cardiologist next. I'll skip
Yes,
Dr.
yes,
Uma.
I'll call the
You want to say
cardiologist.
something?
I'll observe. In the meanwhile, I'll get the
Stop.
investigations ready.
So as anesthetist, you
Mainly
stop the surgery.
electrolytes,
The message here is clear. You have a newly detected atrial fibrillation for an elective surgery. What she said is the single message. Newly detected atrial fibrillation prior to surgery, you stop. Till you evaluate and find out what's wrong, you don't send him for surgery. So Dr. Mala, Dr. Uma, you want to add something or will skip to Murli straight away? So Murli, go ahead. So what do you want to do in atrial fibrillation? Newly detected.
The first point is the problem in this situation is not the surgery, not the day. Rather, how the patient going to perform over the next several months or several years. So, per se, as surgery per se, he will be fit. Even a newly atrial fibrillation, even if totally stable, as we say, it will be fit. Only thing is that we will be monitoring a perioperative, any increase or increase ventricular response, whether we need to do a rate control measure or we have to go for cardio. That's one thing. But a stable patient, atrial fibrillation, control rate, hemodynamics are stable, that's not a major risk. But we know from that moment, this patient goes to a different fold. Like we always worried about coronary artery disease, but we worry about heart failure more than coronary artery disease situation. Number one, this type of patient are more prone for heart failure events. Number one. Number two, more risk of thromboembolic event. Even the mortality and morbidity goes up, not in this period, but going to go up and up and up in the next several months. So perioperative atrial fibrillation to be watched, postoperative you have to watch, and obviously you said this patient initially is normal. So I presume that is a paroxysmal atrial fibrillation. So I may have to start complete different algorithm for atrial fibrillation management.
So basically,
but for surgery, go ahead.
So actually what you say is you, for an elective surgery, stop the surgery, assess for the usual things like thyroid, the LV function, rheumatic heart disease, electrolytes and other things, and then plan for surgery. There's a very interesting data that came up about 1-2 months ago in JAC, which actually says patients on atrial fibrillation, there is an increased mortality, there is an increased heart failure and stroke, but incidence of myocardial infarction is less if you have atrial fibrillation. The reason they say is very simple. Most of these patients are on anticoagulation. So that seems to be protecting these patients. So any atrial fibrillation intraoperatively, like Madam said, she actually came into the intraoperative part and overlapped and gave the answer to what I wanted. Intraoperative atrial fibrillation, depending on the hemodynamic status, if your heart rate is maintained less than 110, possibly because the beta blockers, you really don't have to worry. But if it is more than hemodynamic compromise is there, or there is a problem, you have to treat it. And if there is a compromise, you either cardiovert or amiodarone them. Otherwise, you can just go for a rate control and accept this. And post-operative atrial fibrillation, I think Vijay must be saying, due to shortage of time, I will skip your question and just give you the answer. It happens in the first 4 days usually. And usually maximum the first 24 hours, but it happens in the first 4 days. And unless the same criteria is applied to postoperative atrial fibrillation, the intraoperative atrial fibrillation, unless there is hemodynamic compromise, stay cool, take your time and treat these patients. Don't panic. You don't have to really panic on these patients. But when do you anticoagulate these patients? Murli, probably same is there.
Okay. Any first time atrial fibrillation or a paroxysmal in this type of situation?
Just a post-operative. If you're pre-operative or something, Chadwick score, yes, fine. But post-operative atrial fibrillation, first time.
Of course, you have to anticoagulate. But the risk of thromboembolism going to go up.
Long-term anticoagulation. Huh? Do they need long-term anticoagulation?
Long-term going to be decided by his overall profile. That's why I said no. Take him as an AFib patient from that moment. Proximal atrial, it is going to be intraoperative, post-operative. We are going to the repeater proximal atrial fibrillation. So the whole idea is going to be what is the risk of thromboembolism in this? Is a female patient. We have to go for a Chadwick score. We are going to score it according to that. Then decide. As I said, we have done the assessment already. We have done every assessment of this patient already. So we can easily place the patient at what place he stays, plan for the anticoagulation long term if it is needed. So
basically you go by the CHADS-VASc score for most of these people. But any atrial fibrillation more than 48 hours or recurrent atrial fibrillation, at least 30 days of anticoagulation, even if nothing is there. So remember this part extra. This is additional to what he says. More than 48 hours of atrial fibrillation or recurrent atrial fibrillation, you have to treat it. I don't think we'll have time to discuss this. If time permits, probably if Chandrasekhar gives me time, we'll talk about anticoagulation, or just one word on the difference between NOACs and warfarin preoperatively. Any surgery, when you want to send them, patient is on warfarin and
again, it comes to whether it's going to be emergency surgery or elective. Shall we discuss both?
Just 2 lines about when to stop, when to bridge,
big problem
whether to bridge or not to bridge.
That's the biggest problem we face. Like if the emergency surgery, patient will anticoagulate, either vitamin K antagonist or Novax. The risk of bleeding going to be quite high. How to reverse it is the question. Patient with a prosthetic valve, mitral valve sitting in, we want to give vitamin K. That's one of the common things people do. I don't recommend it. You may get a ball of thrombus on the valve, prosthetic or dysfunction. So we may have to think something else. Novax, same thing, but we have excellent antidote now. Idarucizumab and antaxanol alpha are available now in West. In India, only idarucizumab approximately only available. So you can reverse your time. Elective, it is much convenient. So you assess the patient, when was the last dose taken. For the available, only 3 are available in India: dabigatran, rivaroxaban, and apixaban. You can, depending on the type of thing, when was the last dose, type of surgery, you can stop either just 1 dose to 1 day to 2 days, and restart also by skipping 1 dose, 1 day or 2 days. So much comfortable. Elegant algorithm are freely available, so we can follow that.
Sir, if it is very urgent, emergent procedure, patient is on warfarin, lands up in emergency, taken up for surgery. So in that situation, what is the option?
Tough question. This is the toughest question we have. You have to go ahead. You have to go ahead. I'll tell you very simple the algorithm. Like
FFP?
Generally, when we talk with the team, surgical team and anesthesia team, we make a quick team approach. We discuss. We are going to weigh it's a high risk situation. We weigh the risk with and without surgery. Maybe I can quote an example. One of our patients years ago, patient anti-all MI, 4th day. It was thrombolytic time, primary period yet to enter. Patient thrombolized, but still there is LV dysfunction. He has got a mesenteric gangrene. The anesthesia team want to say we cannot do surgery. Just 4 days of MI. So the question in the discussion, only one question I asked. I asked the surgeon, sir, what do you think the outcome without surgery? He said 100% death. I said, then go ahead and operate. Well, even the 95% death, even 95% chance of dying with recent anti-all MI, still there is a 5% chance. We all know mesenteric ischemia and gangrene. The death is going to be 100%. That means you have to operate.
So emergency surgery is a different ballgame. So you answered something else which is coming in the final algorithm. So from what Dr. Murli said, there are two kinds of anticoagulation. One is the warfarin group, warfarin acetron, and second is the newer anticoagulation, the dabigatran, apixaban, and rivaroxaban. Now these 3 drugs, within about 24 to 48 hours, the effect is totally gone. So you can plan for surgery, no bridging is required. Now the current trend to use warfarin is you stop warfarin for 3 days, let the INR drop less than 1.5, you can take them up for surgery. Less than 1.5, you can take them up for surgery. But when it drops to 1.5, and if you're delaying the surgery for maybe for your thyroid is high or your sugars are not controlled or some other issues, then you have to bridge them with anticoagulation. So you have to give them parenteral anticoagulation. And once you restart, how soon do you restart after surgery? On the day of surgery and next day you can start, because warfarin is going to take 3 days to act. So you can start on the same day, and none of the surgeons will let you do it. Don't bother, just give, because it's not going to work. It's going to take 3 days. And if beyond 48 hours, if there is going to be otherwise no other issues, you can actually bridge it post-operatively for about 3-4 days.
How early you can start, sir, warfarin?
Same day you can start, because it doesn't act.
My doubt is if there are drains which are still losing and no need to...
Warfarin takes 3-4 days to act.
The losses are going to be replaced. We are going to maintain hematocrit.
No, madam. See, here what happens, the INR has come down to 1.5. I want to take it to 2 to 3. That is going to happen. Not today, Monday, I'm giving it. It's going to happen Wednesday, Tuesday, and Wednesday evening.
No, at that point, it doesn't act, because it is going to take 3 days to act. By the time you want to start the anticoagulation, it starts acting. So that is the reason.
Taken protein C and S inhibition because of the warfarin.
Protein C and S inhibition. That is going to be in the early phase. See, that is the reason why you do the overlap anticoagulation. So I don't think we'll discuss that here. Probably that is the reason why you're talking about the bridging in the post-operative period. I think we'll skip that out at this point. The next case is probably going to be more for a physician at this point. Fracture of the humerus, patient 60-year-old female, stable coronary artery disease, anterior ischemia. Patient is on statin, beta blocker, dual antiplatelet therapy and nicorandil. Had an ACS 1 year ago. You don't have the details. Patient comes into your hospital, comes to the physician for an opinion. Hemoglobin, I forget all those values. You just go ahead and tell me. As a physician, stable coronary artery disease, what do you want to do?
So here again, history taking about, because post ACS 1 year ago, we have no details. Then coming back to hemoglobin, 11.9. Again, this is a fracture humerus.
You can skip that. We did that actually on the orthopedic surgery. So anything else you want to do? You want something else?
ECG is showing anterior T wave inversion. So here we want to know the ischemia status. One echo is required for the LV systolic function, and trop T also may be required, sir, for ongoing ischemia.
So you want to look at cardiac troponins in these group of patients?
Negative. So for trop T negative, madam?
Sir, LV function, sir?
LV function is EF is around 47%.
48%. He's a bad cardiologist. He's giving you all typical bad scenarios. Bad examiner is.
I'll put this way.
Okay, I have a tougher question for you. Don't worry. This is for her. The dual antiplatelet therapy you already answered, so we will not go into that. Now, suppose this patient, same scenario, is there in your case. Now, in the previous case, technically what you do is you look at RCRA. The RCRA score is high. So that will come to the enzyme elevation in the next one. So you have to look at troponin. That's a very important point. When to look at troponin, we'll come to later. Now we'll come to the same scenario, more difficult question for Murli because he's a bad examiner. If it's an acute MI, 1 month post myocardial infarction comes for an elective cholecystectomy. Similar case, similar scenario. And what happens to these cases? Suppose the patient is acute MI, patient had no treatment, post PCI, post CABG. What happens?
3 level. So untreated acute MI, revascularization done with CABG and PCI.
PCI.
Scenario. Okay. This one thing very simple. You have given a nice thing for me. Elective. The word elective cholecystectomy. It is not a gangrenous thing or emergency. That saves my time. Yeah, I like to avoid surgery. I like to avoid surgery within thing. It depends on what type of treatment you have received. If it is a PCI, I would like to know whether it was a POBA, which is very, very uncommon nowadays, whether it is bare metal stent, second thing, or decorative stent. Go and tell me how long to continue. In an elective thing, if a given time, I would like to defer surgery for variable time without stopping.
So elective surgery. Question 1. I'll go one by one. You answer in one line. No detailed answers. Elective surgery, post myocardial infarction, no revascularization. When do you want to do?
No
revascularization.
I would like to wait for
thrombolyzed.
I would like to wait for 90 days.
90 days. Waiting for 60 days post myocardial infarction is recommendation. 60 days. Now this slide is actually I picked up and made it myself. Within the first 30 days, whatever you do, whether you have not revascularized or whether you have revascularized with a PCA or a CABG, the mortality is very high. The second one is up to 60 days. Then after that, up to 60 days, the MACE event rate is high. Beyond that, it tapers off. So 60 days is the time for these patients. The post PCI scenario, suppose the patient had a CABG. How long do you want to wait?
Minimum 3 months, maximum.
So stable, if you want an early surgery, the best approach is to do a CABG. Within 30 days, you can take them up. Electively, preferably 60 days, like what he says, post CABG. If you have a PCI, bare metal stent, wait for 1 month, drug-eluting stent, wait for 3 months. It's very, very simple. So if you want earliest surgery, CABG is the best. But if you want to do it very fast, there is a problem, like let's say CA or malignancy or something, you can still do one thing. You can do a POBA and get out. Within 14 days of a POBA, you can take the patient for a surgery. Now, depends on your scenario. At that point, you can start treating these patients. Now, the cardiac enzyme is what you wanted. Now, how often do you check cardiac enzymes? Postoperatively. Madam wanted a preoperative cardiac enzyme for the patient with stable ischemic heart disease. Postoperatively, do you check?
Postoperatively, I don't check unless there is some signs of cardiac stress like hypertension or chest pain and other patient symptoms. If they have, we used to check. Not routinely, we used to check postoperative enzymes. But what I can do postoperatively is to have a controlled heart rate, have a controlled blood pressure.
So you want
decrease the LV stress. That is the main thing. Avoid acidosis. Just to check whether there is any acidosis, hypoxia, hypercarbia. These are the things, because hypercarbia is common after some infusions like fentanyl.
Let me teach you something new today. There's a new entity called MINS. Myocardial injury after non-cardiac surgery. This is a very new terminology created from Mayo Clinic. What happens is within the first 72 hours post-operatively, when the cardiac enzyme troponins are elevated. Now this happens in about 8%, of whom 84% have no symptoms, 35% had only ECG changes. Typical MI definition criteria is taken only by half the patients. So we are looking at postoperative. What is the importance of MINS in these patients is the 30-day mortality is 9.8% compared to those without enzyme elevation. So it's very, very important to look at this. So what do? Who is the patient for whom you need to look at this? I'll finish this. So what is the patient? You want to say something? Go ahead. Otherwise, I'll finish the algorithm.
But it's a common thing. In fact, they have reinvented the same thing. To understand, today universal definition of myocardial infarction has become various types. I'm not going to the detailed classification, but type 2 is common postoperative. It is not that regular MI that we come across where we take for primary PJ, mostly it is demand supply mismatch. In fact, the previous talk, nicely talked by Ajit, where you look at the classification, even such studies, we have available for perioperative thing. People who have had multivessel disease, who had a MI postoperatively, when you went into the pathology, the actual plaque was not the plaque that tighter. That is, for example, I had a LAD plaque 80%, RCA 60%. I have had a MI in the OM territory. What it indirectly means is your vascular disease is diffuse. These things are markers. The MI was not under point. It's not that my 80% LAD plaque, rather my 40% OM, the plaque, vulnerable plaque rupture and cause. Same thing has been shown in a different way in a milder form by you. That's what I want.
So what we know today is this. This is the 2021 algorithm for assessment. High risk features, patients with age more than 65, 45 to 65 with the history of coronary artery disease, or anybody with an RCRI more than 1. So it's going to be diabetes plus hypertension. Even the first case, what we should have done is, if you have any of these criteria, you have to look at what is called as troponin T and NT-proBNP. Both are prognostic. NT-proBNP being high in the preoperative period is clearly suggestive of a postoperative increase in mortality. It need not be cardiac mortality. It seems to be predicting non-cardiac all-cause mortality also. So in all these patients, today, if you're learning two things, look at RCRI and start looking at troponin T and NT-proBNP in the preoperative phase. You're looking at preoperative assessment. Preoperatively, look at NT-proBNP and troponin. If the troponin is less than 300, there is very low risk of MINS and postoperative events. So if you're looking at NT-proBNP, it is going to be prognostic for you at that point. If it is more than 300, what do? High risk, postoperatively, this is for you, Vijay. Every day you check at troponin T and then look at 48 to 78 hours postoperative ECG. So this is the algorithm today accepted for these patients. So if your preoperative NT-proBNP is elevated, you have to be looking at postoperative MINS. And how do you manage MINS without any ECG changes or without myocardial infarction? If there is MI criteria satisfied, like what Murli says, treat for like an MI. What do you do for those patients where they have asymptomatic elevation? The data is very unclear, but possibly statins and aspirin must be started postoperatively and continue. Probably assess them later. So MINS is a new term which we have to be looking at in future. This is going to be a combination of anesthesia. What is your preference of anesthesia in most of these cardiac patients?
First of all, I want to know why brufen and aspirin both are being given in this case, this particular scenario.
1 year post ACS patient
Are
is
they
on
additive, and there are controversial things like brufen and aspirin? Are they additive or they?
Brufen? Brufen was for your choice was very simple. Your choice was more for the anesthesia, choice of anesthesia.
For humerus.
For these kind of patients. Do you prefer a general anesthesia, a combination of regional with general anesthesia?
Regional blocks are being given nowadays, but considering the risk factors, if the risk is too high, we prefer giving general anesthesia itself.
What about giving a regional block with IV sedation? What we call as combination anesthesia nowadays.
Ultrasound guided regional block is safe, but considering if there are complications like last, that is local anesthetic.
See, what I notice is that most of the times the problem that keeps cropping up is with.
So we think of adverse events. So to prevent all this, and if the patient is on aspirin and Clopid together, so we want to avoid, if at all the patient needs surgery immediately. Of course, humerus surgery can be postponed till we can stop Clopid and plan with aspirin.
Plan for surgery.
But If
But
the
you,
case-
you prefer a general anesthesia in these patients. That's
GI is
what
safer.
you say.
GI is safer.
But the point is the newer things they say that you don't have to give for an intubated anesthesia for cardiac patients.
No need
basically.
for intubated anesthesia, but being a regional block with so many drugs.
Because the intubation,
Ultimately, the safety
intubation is not a problem. Extubation is when the problem happens.
So there are many events which are problematic for cardiac patients, sir.
So what about your intraoperative? One small question to Dr. Uma. Are you okay with patient taking ibuprofen preoperatively for rheumatoid arthritis?
Pre-op, okay, sir, but NSAIDs with ACS, I think it is.
Problem with the NSAIDs is they also have antiplatelet effects. They also have decreased the thromboxane. So there is a guidance clearly which says if you're going to give ibuprofen, diclofenac, or diclofenac, you have to ketorolac, you have to stop 1 to 2 days prior to surgery. And if it is a long-acting preparations, 4 days prior to surgery, you have to stop. There is a little bit of guidance on that. What about intraoperative blood pressure? What is your preferred? You already told us that you want to have the preoperative blood pressure. So it is going to be, you try to avoid hypotension or avoid hypertension. What is your choice?
So we want to match myocardial oxygen supply and demand. That is our concern in intraop. There should not be tachycardia, there should not be bradycardia, there should not be hypotension, there should not be hypertension. So we want to maintain around that pre-op BP. That is the concern. We don't want undue fall, exaggerated rise also we don't want. So preemptively we want to control BP. That is maintaining the adequate depth of anesthesia and the making the losses correct and making blood losses. So the main thing is monitoring intraop. That is the basic thing. So intraop usually nothing happens during, as you said, on extubation when there is a sympathetic surge, undue autonomic surge, sympathoadrenal stimulation that happens during suction and extubation. So there are various drugs which we use.
Murli, about poise 3, just one word about poise 3. Poise 3, the avoidance of intraoperative MAP more than 60 or more than 80, both have the same effects. There are two messages that poise 3 is the study that came up with the perioperative ischemia evaluation in 2022, had two messages. Whether you're trying to have a slightly higher pressure or lower pressure, there is no change in mortality. Second important message is about what the ACE inhibitors and ARBs, they say they are quite safe. So you don't have to worry about it. I think we will skip to this, the anesthesia part. The last case is, I will just give you a gist of what is this. This is going to be a patient with mild breathlessness on exertion, evaluated, who walks 20 minutes daily. The ejection fraction is 30 to 35% for the first time. Comes to the physician, you ordered an echo, 30 to 35% ejection fraction. What do you think you want to do?
This patient is being posted for umbilical hernia. Umbilical hernia
elective surgery.
Being sort of EF is less than 30, which is significant reduction in the function of LV. So I will ask for thorough cardiac evaluation before posting the patient.
Doctor, agreed. We'll give it to the physician and the cardiologist.
It's not an emergency.
Agreed. So she wants to postpone the surgery. Your idea?
My idea is with ejection fraction of 30 to 35%, is this surgery going to be life-saving?
No.
Otherwise, defer.
Defer. Now refer to cardiologist.
Just so you scored RCRA, clearly. So
now, clearly heart failure is more dangerous than coronary artery disease. You must understand, heart failure is much more dangerous than coronary artery disease. The risk involved with heart failure for symptomatic or asymptomatic is much higher. Remember that. Any newly diagnosed heart failure, postpone surgery. I think all three had a very clear mandate. I think all of you should also take. The surgeon pressurize you also don't accept. You wait for at least 3 months, give them good therapy, and then take up for surgery. Otherwise, the risk is very, very high in these group of patients. And we'll forget the risk of the anesthesia in these group of patients. And I think one clear point is, in heart failure, it is not a contraindication. Risk is more, but the point is you have to give them good therapy and then plan for surgery. It's not like you delay the surgery. So I think since time is very short, I will give a summary of what we have discussed so far. This is the simplest algorithm. We have more or less touched everything. The first question you ask is the surgery emergency surgery? If it's emergency surgery, take a high risk consent, go ahead. Look at the current hemodynamics at that point. Hypotension is more predictive of postoperative problem than the hypertension, point 1. Next is you look at the step 2, you try to evaluate and treat these patients according to guideline directed medical therapy for all other patients. Treat them accordingly and then start deciding what is to be done. So what is going to be the next question? Next question is going to be the risk of the surgical procedure. High risk patients, more evaluation. Low risk patients, most of the time on good therapy, you don't need further evaluation, take them up for surgery. Look at the clinical functional capacity, like what Dr. Uma had said. And if the clinical functional capacity is more than 4 meds, so what is going to be 4 meds? Anybody who can climb 1 flight of stairs. Simple. If you're going to climb 1 flight of stairs, you are more than 4 meds. You're more or less through for surgery. It's like low risk surgery. But look at RCRA score also. If the RCRA score keeps going up, then you have to be a little more careful with all these patients. Less than 4 meds need further evaluation. So you have to evaluate them, make sure you're going to be looking at all the factors. And beyond this, there is only one thing. Look at RCRA score for all your patients. RCRA is very important. What is it? Type of surgery, previous history of ischemic heart disease, congestive heart failure, cerebrovascular disease. You may look at diabetes on insulin and perioperative, preoperative insulin that is more than creatinine that's more than 2. So if there are no risk factors, more problems. And for all your patients, look at this: age more than 65, 45 to 65 with heart disease, RCRA more than 1. Look at NT-proBNP. NT-proBNP is predictive of a problem. If NT-proBNP is normal, you don't need anything. Patient is going to do well most of the time. If it is high, more than 300, postoperatively look at cardiac enzymes and NT-proBNP, and that really TROP especially is useful for the next 48 to 72 hours. And postoperative ECG is beneficial, and this is clearly beneficial and clearly been there. Now I should specifically thank all the 4 panelists, though I have kept Vijay a little away because of shortage of time. Dr. Murli, Dr. Vijay, Dr. Uma, and Dr. Mala for excellent discussion. Thank you so much. We learned a lot during this. Any questions you want to ask? Probably one question from the floor to the panelists. Parandaman is not there, so I don't think we'll have questions. Don't worry.
Thank you, sir. Thank you. Indeed, it's a brainstorming session. Give them a big round of applause. Thank Dr. Prabhakar and all the panelists. Thank you once again, sir. Thank you. We again come back for the...
Shanmugam, sir, we finish in 50 minutes, like you said.
We do have some exciting session in the post-lunch session. Please come back in the same hall by 2:30.
So I went to the breakout room.
इरफान में आएगा, पिक कर लिया, पिक कर लिया। ओए मेरा मोबाइल को चार्ज से निकाला है। हाँ क्या की मोबाइल मेरा मेरा किसी मोबाइल पर कोई हुई हो। हाँ हाँ ये इसको खोलने खोला ना
Practice every day, and we give lot of medications which can produce unexpected or serious side effects. Many times we are not aware, right? It can occur immediately or it can occur at a later period also. An underlying cardiac abnormality may be present in the patient which we are not aware many times. For example, we must have given a drug first time, patient might have had an underlying cardiac abnormality which will be revealed later on, right? So most of the affected patients had no prior manifestation, right? And not recognized until the post-marketing phase of the drug development. For example, they may progress to heart failure. It may represent a major adverse effect. For example, rosiglitazone, COX-2, painkillers, NSAIDs, TNF inhibitors, anti-cancer drugs, and anti-Parkinsonism. I give an example which will be discussed later on. So with this background, we go to the topic. What are the cardiovascular effects can occur? For example, it can affect the heart or it can affect the blood vessels or both. It can affect both or it can affect anyone. For example, they say it may be type 1 cardiotoxicity or type 2 cardiotoxicity. It may be reversible or it may be irreversible, right? Both can occur, or it can be acute or it can be chronic. For example, it can occur acutely. For example, when we give the dose for the first time, after 2 weeks, till 2 weeks, we call acute. Once the drug is taken off, it is automatically gone. For example, it can occur after some time, even after the drug is removed. That is called as chronic. The type 1, type 2 is old. Right? They have type 1 cardiotoxicity, type 2. They say overlap. What is meant by overlap? For example, they resolved after completion of therapy or even during its continuation, overlap can occur between these two, right? For example, reversible is classical example is anti-malignant drugs, which we give. It produces microstructural lesions of cardiomyocytes, necrosis, apoptosis, all those things. Type 2 basically, it is basically, once again, it is irreversible, right? Okay, what are the risk factors? Who are all the people who are cardiac adverse events? They have a list. It is standard list. For example, patient's age and females, black ethnicity. What type of anti-malignant drugs we are giving? What type of combination therapy we are giving?
Then what is the total dose? What is the other therapy they are taking, radiation therapy or any other thing? Then abnormal markers, ProT, ProBNP. Then history of heart disease, then classical diabetes, hypertension, dyslipidemia, hypothyroid, physical inactivity, smoking, genetic, all play a very, very important role. These are the people who are at high risk for cardiac adverse events due to non-cardiac drugs. Okay, right. For example, this slide shows, you can see here the blue. These drugs, the blue one, you can see the cardiovascular drugs have been taken off. Lot of side effects have come because of neurotoxicity, cardiovascular toxicity, gastrointestinal toxicity. These drugs have been banned, right? We'll talk about that later. Then now we'll go to the next one. What are the basic mechanisms they have found out why cardiovascular adverse events occurs? It can occur due to growth factor signaling because of growth factors like platelet-derived growth factor or endothelial growth factor or epidermal growth factor. All those factors may be affected, or it may be due to the problem in the contractility, or it may be due to problem in the mitochondrial functioning, particularly the QT prolongation. Then it may be due to ion channel trafficking or inhibition. These are the main mechanisms which can produce fibrosis, apoptosis, or thrombosis. I'll represent in the grid diagram. You can see this very nice diagram. You can see here it can affect the growth factor signaling, or it can affect the contractility, or it can affect the electrophysiology and ion channel traffic. For example, tyrosine kinase inhibitors specifically affect the growth factor signaling. The proton pump inhibitors, commonly we use omeprazole, all those things can affect the contractility. Electrophysiology, for example, antipsychotic drugs, antidepressant can affect the ion channel inhibition. Then once again, antiviral drugs, particularly we use ARTs very commonly, right? Nowadays, people take many drugs from different doctors. As a physician, we should ask what are the drugs they are taking from where. Everything we should have a list. Then only we can prescribe like it is safe. For example, mitochondrial functioning, they may have, for example, anti-HIV drugs. All these in combination can produce apoptosis, fibrosis, and thrombosis. So finally producing drug-induced cardiotoxicity. Okay, right. Next one. This is once again the same pathophysiology. For example, what happens to the channel trafficking? What happens to the calcium cycling and nitric oxide synthase is affected? Then TNF pathway, TGF, all those things, multiple pathways and different mechanism, different drugs at different times, finally causing cardiotoxicity that manifests in a clinical manifestation in a different form. What are the different forms by which they manifest? Because of these effects. Because of these effects, what exactly happens? Okay, right. What are the things which can happen? They may develop tachycardia, bradycardia, atrial fibrillation. They may have myocardial ischemia, even myocardial infarction, LV dysfunction, left ventricular failure. Then they may have valvular heart disease. Very commonly, they develop QT prolongation. They may develop torsades de pointes. They may develop ventricular tachycardia, sudden cardiac death, pericarditis, myocarditis, systemic hypertension, pulmonary hypertension, hypotension, thromboembolic manifestation, arterial venous, all can occur. All different manifestations can occur due to different drugs. That has been documented, that has been reported. Only thing we have to be aware. We have to be aware of these things, which drug produces which problem and why. For example, they are given a very big list just to highlight important things. For example, if you take myocardial infarction, 5-fluorouracil very commonly produces myocardial infarction, particularly the monoclonal antibodies, right? Then we can have the other one, already I told, type 1 cardiotoxicity and type 2 cardiotoxicity, particularly produced by, we use commonly tyrosine kinase inhibitor. Nowadays, we use a lot of monoclonal antibodies. A lot of people are having autoimmune disorders, right? They use monoclonal antibodies, they use tyrosine kinase inhibitors. A lot of drugs are being used. So many times they develop anti-cancer induced drugs. Yes. So they may develop tachy, brady, AF. Then I'll be talking once again about that. This is just to highlight what are the drugs. For example, you can see myocarditis, very commonly seen in clozapine. They say antipsychotic drug, it should be used only after doing an echo, doing a TROP-T. Very safe, because otherwise we may not know who will develop cardiotoxicity. Then you can see here the pericarditis can occur due to many reasons. Then cardiac valves, valvulopathy. Valvulopathy can occur due to migraine drugs. Then you can see systemic hypertension. Very commonly we use NSAIDs. Then hypotension can occur particularly when the patient is taking sildenafil, phosphodiesterase type 5 inhibitors, when they take along with the nitrates, when they take along with the alpha blockers, prozosine, all those things can have a See, other than cardiac side effects, they may have drug-to-drug interaction. Drug interaction. One may increase the level of other drug. Other drug may increase the level of, like that, the combinations can be very, very detrimental. For example, when we give theophylline, when levofloxacin is given, what happens? Theophylline level increases. What happens? Patient develops seizures, right? Like that, many drug interactions also can occur. Then patient may develop pulmonary hypertension. Pulmonary hypertension is one of the common problem. That is why the obesity drugs have been stopped, particularly fenfluramine. They say sibutramine is better than fenfluramine because the side effects are less. Then we can have arterial thrombosis and venous thrombosis also can occur because of COX-2 and other things, right? I'll be discussing once again. These are the cardiac effects because of the drugs. For example, they say ergotamine, all those drugs can produce valvulopathy. For example, ergotamine, methotrexate, drugs used in Parkinson, pergolide, cabergoline, many times used for prolactinomas. All those drugs are, we have to be very, very careful, and fenfluramine, all those drugs. Then pericarditis. Pericarditis, if you see very carefully, TNF antibodies, particularly TNF alpha antibodies and anti-malignant drugs. These are the drugs which can produce, particularly tyrosine kinase inhibitors, all TNFs, dasatinib, imatinib, nilotinib, all the new drugs. Many drugs are not even very difficult to pronounce the names, right? We say TNFs, very easy to remember, right? So these are the drugs. And you can see here, ergot drugs, all the cabergoline, pergolide, bromocriptine, methotrexate, all can produce pericarditis. So now the very common problems I'll discuss one by one. First is hypertension. Hypertension, lot of drugs, particularly NSAIDs, can produce hypertension. The drug which is used as in psychiatry wards, you can see the venlafaxine can produce not only tachycardia, it can also increase blood pressure. In a study, they found out that 12.5% develop hypertension. Particularly when they take painkillers, it exacerbates the hypertension because it inhibits the renal prostaglandins, mediate increased renal perfusion, thereby causing sodium retention, edema, and hypertension, right? So NSAID use alone is very common in many patients because many patients take rheumatoid arthritis drugs, all those drugs, they take ibuprofen, they take naproxone, all can elevate the blood pressure. The NSAID users are more likely to be on antihypertensive therapy. People who are taking long term, they take even steroids. They take steroids, small dose or large dose, whatever it is. Pulmonary hypertension, once again, dexfenfluramine and fenfluramine can produce. That is why these two drugs are banned. They use only sibutramine. Then hypotension, already I told, hypotension is very commonly seen with phosphodiesterase inhibitors, particularly sildenafil, tadalafil, and vardenafil. These are the drugs because they can cause a transient modest reduction in systolic and diastolic blood pressure without affecting the heart rate. It particularly reduces around 7 millimeters of mercury. Particularly, it should be used very, very carefully when they take with the nitrates. When they take with the nitrates, when they take with the alpha blockers, we have to be very, very careful because when they take alpha blockers, particularly for BPH, prostate and all, they may develop orthostatic hypotension and they may develop syncope, very commonly missed. For example, many times, why we should know this, all these things. Many times patient will tell different symptoms on a second day, third day, we give another drug. We give another drug without knowing the combination or without knowing the drug-to-drug interaction. What happens finally? Patient land up in another complication, right? To avoid these, all those things, this area is very important. Next is valvular heart disease. Valvular heart disease, already I told, ergot and other things. You can see here, the rate of clinically important regurgitation in the order of 25% have been found when the drugs are used more than 1 year in Parkinson's disease. The severity of regurgitation related to the dose and duration of therapy. But regression of the lesion has been observed. Once you stop the drug, regression occurs. It is reversible. But sometimes when we give for a longer period, they may develop irreversible. They may develop irreversible damage. Then ischemic heart disease, very, very important. Myocardial infarction. What are the drugs which are commonly supposed to exacerbate myocardial infarction or ischemic heart disease? Anti-malignant drugs, particularly 5-fluorouracil and monoclonal antibodies, whatever we are using. Then rosiglitazone, that is why rosi was banned. Pio was okay, but pio they say bladder malignancy, all those things, still it is going on. Rosiglitazone has been banned. Then rofecoxib, COX inhibitors, that also a lot of mortality. I'll discuss later on. Then omeprazole, these are the drugs which are linked to ischemic heart disease, myocardial infarction, myocardial ischemia, and cardiac failure. Next is QT prolongation. QT prolongation was one of the important side effects which has been observed with antihistamines, particularly astimizole, terfenadine, cisapride. These are the drugs which has been banned because QT was prolonged. So all drugs nowadays, before coming to the market, before we use, we should check whether any problem is there, whether ECG, anything is abnormal, QT prolongation. Already patient has QT prolongation. If you give, it will worsen, right? It may land up in trouble. So many drugs prolong QT interval, particularly they may develop life-threatening VTAC, particularly TDP, torsade points. So very, very important. It is the leading cardiac reason for which drugs are withdrawn from the market. So for example, particularly antipsychotic drugs, antidepressant, very commonly used is erythromycin, all macrolides. All macrolides, whenever you give along with verapamil, diltiazem, ketoconazole can produce QT prolongation. So macrolides should be used very carefully. And whenever patient is taking cardiac drugs, make sure that they don't have QT prolongation. All macrolides. Then AF, brady, and tachy. For example, bradycardia has been noticed in thalidomide and paclitaxel. Thalidomide is already banned because of amelia, phocomelia, right? But paclitaxel is still used in many malignant conditions. It can produce brady. Then high-dose steroids, cisplatin, and other drugs can produce AF. High-dose steroids can produce atrial fibrillation. Then biphosphonates and donazepam used in Alzheimer's can produce tachy, right? Then sinus tachycardia has been observed in other conditions. So the natural healing force within each one of us is the greatest force in getting well. Many times we don't know that we have to provoke. The natural healing process is individualized. It varies from person to person. MI, 2 age group, same MI, but recovery is different. I think everybody will agree with me. Now I'll go to the important drugs. For example, erythromycin, sudden cardiac death has been reported. Then other drug is 5-fluorouracil, already I told cardiomyopathy and heart failure. Then one more thing is dexfenfluramine and fenfluramine, pulmonary hypertension, right? Then for example, here you can see rosiglitazone has been predisposed. It has been associated with heart failure and myocardial infarction. Pioglitazone, some evidence of heart failure, not like rosiglitazone. Then one more drug is rofecoxib. Rofecoxib is myocardial infarction. I'll talk in detail about rofecoxib because it is one of the important area. So herbal drugs, I'll finish quickly. 5 minutes? Okay, right. Herbal drugs, many herbal drugs are very important because many times patients use native drugs. They have a drug interaction with warfarin and digoxin. Warfarin has got the maximum number of drug-to-drug interaction. If somebody says, I know everything about warfarin, they know completely pharmacology. Warfarin has got multiple drug interaction. Warfarin is one of the important drugs which is used in many patients for preventing AF and other things. So we should make sure that they are taking warfarin, and herbal drugs should be totally avoided. We always say all patients can take green vegetables except patients who are on warfarin because they cannot take green vegetable because it is rich in vitamin K, right? So we always say to the students. So warfarin definitely plays a very, very important role whenever they take herbal, particularly Zinpo, these drugs, these Chinese drugs they are taking. So many times they take. Then hormone replacement therapy. A lot of things have been done. I highlighted the red one. Estrogen replacement did not significantly lower the risk of coronary artery disease events. Coronary artery disease risk was not increased, but not lowered. It is the same compared to estrogen and progesterone. So hormone replacement therapy was routinely used for everybody previously. Later on, they did a study. They told combination is not very useful. Whenever needed, we can use only estrogen. That is what they say. They have done a lot of studies, and then appetite suppressants. Already I told fenfluramine and dexfenfluramine produces a lot of pulmonary hypertension. They have very high risk, 7.5% high risk. That is why they say it should not be used, and they say sibutramine can be tried because the incidence is less. Then NSAIDs, higher cardiovascular risk is very, very commonly seen in this group, and the risk is very high in rofecoxib. Particularly, we have COX-1 and COX-2. For example, if you see this diagram, you can see COX-1 and COX-2. Aspirin, for example, if you can read out this one, aspirin at lower dose blocks platelet cyclooxygenase 1, resulting in relative excess of prostacyclin. It increases the prostacyclin so that vasodilatation occurs and no platelet aggregation occurs. So that we have beneficial effect, so that there is no problem. It is blood thinner, right? Very simple. Suppose a person takes coxibs, rofecoxib, all those drugs. They specifically they reduce the prostacyclin, and thromboxane A2 is increased, so that platelet aggregation becomes more, vasoconstriction occurs, they get more heart disease, they get more myocardial infarction, they are more prone for coronary artery, all sorts of vasoconstriction problems occurs. That is why NSAIDs, COX inhibitors should be used very, very carefully in coronary artery disease patient, particularly patient is having heart disease, particularly patient is having hypertension. So these drugs should be used very, very carefully. You can see here the coxibs are selective for cyclooxygenase 2. Their administration leads to excessive thromboxane A2 with the subsequent risk of vasoconstriction and platelet aggregation occurs. So we have to be very careful. If at all they need, they have to be given in a very, very shorter period, not for a longer period. Many times patients tend to take 15 days, 20 days, not recommended, right? Then glitazones. Rosy glitazone was associated with increased risk of myocardial infarction, particularly in many studies. It has been removed from many countries. Pioglitazone appears to be safer alternative. What exactly happens is they cause fluid retention, increased sodium reabsorption in the distal nephron, they cause peripheral edema, they worsen the osteoporosis. Many patients come with the pedal edema. They come with a very, very bulky, they have weight gain. They have pedal edema, they have oliguria, they have facial puffiness, they have osteoporosis, all sorts of problems. So once the drug is stopped, automatically patient improves. Many times that's why rosiglitazone has been stopped. They say it should not be used. It is contraindicated in heart failure. It can produce myocardial infarction. Rosiglitazone, pioglitazone a little bit better. We can use a lower dose, 7.5 milligram rather than 15 milligram twice a day. Then tyrosine kinase inhibitors has been associated with a lot of heart failure and reduced ejection fraction. It is used in many conditions like renal cell carcinoma and gastrointestinal tumors. Suppose they stop the drug or reduce the drug, the effect comes down. TNF inhibitors also the same thing. Then complementary therapies, particularly the drug interaction with the digoxin and warfarin, already I told. Then clozapine I heard. Myocarditis has been observed in 1% roughly. It is called as clozapine-induced myocarditis. First 8 weeks of therapy. It is usually unpredictable idiosyncratic reaction, basically. Symptom range from mild to cardiogenic shock and death. It is reversible. So some people even get cardiomyopathy because of clozapine. So clozapine should be used very, very carefully. And triptans also, particularly for migraine. And ARTs, particularly protease inhibitors, we should be using very, very carefully because it produces a lot of cardiac problems. So I just quickly go through the drugs which has been banned. You can see etracoxib banned in 2007 because of thrombotic events. Then rofecoxib banned because of myocardial infarction in 2004. Then in 2009, other drugs have been banned, not very useful. Clozapine already, myocarditis, cardiomyopathy. Then cisapride, omeprazole, all those things because of QT prolongation. Once again, acimazole, terfenadine, QT prolongation once again. Then all quinolones, very commonly QT prolongation. So we have to be very, very careful. 2-fluoxetine has been removed. Ripafloxacin and sparfloxacin has been removed because of QT prolongation. And you can see here the rosiglitazone is banned because of heart failure, even though it acts very good effect on pipa gamma receptors. So now I am going to finish. These are my references. Very, very, very nice references. You can see very good details have been given. For example, this has come very recently. The other one, drug-induced cardiotoxicity. And this is a very good review. If somebody wants to read this review, is very good. This contains around 75 pages. You have to go through, very nicely given everything, every drug, mechanism, everything has been. I have summarized all the slides. And this is about the molecular mechanism has been given. Very useful for postgraduates. So it is better to change rather than persisting in a wrong one. Now I think after attending this program, we must have a different view, right? When we use a drug, we will be very careful in using a drug, right? So what are my conclusions? What are the take-home messages? Drug prescribed for non-cardiac condition can have unexpected and serious side effects. All drugs should be used whenever it is cardiovascular risk-free. Particularly, other risk also is very important. Cardiovascular risk-free should be there. Then only the drug will come to the market. Then we should be aware of the side effects. Try to minimize the CV risk. Try to analyze the drug-to-drug interaction and minimize the side effects. Then, example, Pio is better than Rosi, sibutramine is better than fenfluramine, COX-2 is better than regular conventional NSAIDs. So, Hippocrates, olden days, he told, cure sometimes, treat often, comfort always. Cure sometimes, treat often, comfort always. So, primum non nocere, first do no harm. Thank you.
Nice talk, Dr. Kannan.
Thank you, sir.
We were talking about Hippocrates, but our own Thiruvallur is there. Noi nadi, noi mudal nadi, adu thanikum, vai nadi, vai pachaya. Whether the patient needs a drug,
yes.
Whether the drug is necessary to cure the patient. This is the first and foremost question should be taken in our mind before prescribing any drug. Let it be a cardiac drug, a non-cardiac drug. Either this patient needs some people say, chumma or vitamin A kuduga sir. Vitamins, whether the vitamins are necessary for the patient, we have to find out and then only give the drugs. Nowadays the practice is The number of drugs have increased. Some people take 15 drugs, 14 drugs, their prescription. And first, one of my professors used to say, first disarm the patient. Patient ulla vanda onne avanga kitta ella paper putting nama kaiyila vechi. We have seen prescriptions, same drug, 3 prescriptions, and the patient is taking all the 3 drugs. So we have to be very careful in prescribing the drugs. Don't prescribe drugs unnecessarily. And if a new drug comes, wait till solid data emerges for the use of this drug. I won't be the first person to use a new drug, and I will be the last person to discard an old drug. Thank you.
So it was a nice summary of huge topic, sir.
Thank you.
So let me sum up actually, so we can, for the benefit of postgraduates, I want to say, so you can divide them into drugs causing myocardial infarction, heart failure, arrhythmia, and myocarditis, pericarditis, and valvular heart disease. In valvular heart disease, again, native valve disease and prosthetic valve. So coming to myocardial infarction, as Sir has repeatedly told, the coxips. So eticoxib has been banned and removed, and the NSAIDs, when the NSAIDs are used rapidly, the incidence of MI is slightly higher. Other than NSAIDs, other drugs causing MI, as are included in slides, where we have to use triptans very safely, and ART and cancer drugs, and heart failure by glitazones. And even the rosiglitazone, other than heart failure, it has caused myocardial infarction in few patients. And coming to the valvular heart disease, again, this anti-Parkinson drugs causing the valvular regurgitation lesions, as well as when patients is on prosthetic valve, taking warfarin, going for a small common cold or any other disease to a general practitioner, he has to be very cautious in prescribing drugs, because these drugs have a lot of interaction with the vitamin K antagonists, and the levels of INR might go up. Thank you, sir.
Thank you. Any question from audience? Thank you, sir.
Thank you, sir.
Mahadevan.
Good afternoon. I thank the organizing team for providing me an opportunity to speak about approach to young hypertensions in this August audience. I thank the chairperson, who is my teacher when I was doing DM cardiology. I thank him, and also my other co-chairperson. My topic will be an approach to young hypertensions, and I will not take much of your time. I'll be approaching, because of the post-lunch session, I know that what are the difficulties you'll be feeling now. So I don't want to be a stress. I want to be a stress reliever than stress infuser for you. Next slide. So my topic will be on epidemiology, how you're going to investigate, and what are the goals set for treat hypertension, and what are the treatment modalities there to treat hypertension, especially focusing on the young individuals. And we know the profile of life, the phases of life priorities, as per from Basha's song, we see the phases of life. The first 8 years for you to play, and then the second 8 years is to read, and third and fourth year becomes detrimental for everyone. After getting married and getting children, automatically BP comes to you. So young individuals are succumbing to the hypertension after getting married, and I think chairperson also agree with this point. Yes, sir. Yes, he used to tell us when we teach us, when we is our cardiology department. So the hypertension burden is phenomenal. You know, just as per 2000 projections, US itself, nearly 1/4 of the global population suffers because of the disease, and it is a leading cause which is modifiable to prevent any form of CV events in individuals. So we have a disease spread across the spectrum of populations, and this can be easily cured or easily treated, brought under control to prevent any CV events, but it is not done so. The prevalence of hypertension young is also increasing. So any individual getting hypertension by 25 or 30 years, automatically, if you don't properly manage the patient, he's going to succumb for any form of stroke or cardiovascular events. It is middle age. It may be age where he'll be working for his home, or where he's working for his children's educations or marriage. At the time, he'll be landing on nephrology domain or a cardiology domain for its treatment, which is happening nowadays.
And guidelines, what are the guidelines that in focusing on? Maybe AHA, ACC or ESC are focusing, many of the populations enrolled in the studies and trial are focusing on the older aspect of the populations. Then the people with younger, 25 years, 30 years having hypertension are enrolled in minimum numbers in their studies. So we don't have much scientific data to support how you are going to investigate, how you are going to manage these young people harboring hypertension disease. And this is the latest guidelines. This was just projected in 2000. They said nearly in the age of 20 to 29, nearly 12% of people are harboring this hypertension. If they keep the goal as a more than 140 systolic and more than 90 diastolic. And when you increase the age, when you go on to the next spectrum of age of 30 to 39, this prevalence is also increasing. But if you go as per the ACC guidelines after the sprint trial, the cutoff level of hypertension diagnosis, the management of hypertension diagnosis has been lowered down to 130. So even any individuals having a BP of more than 130 has to be treated is the ACC guidelines. If you give much weightage for this target, many number of young peoples also fall prey for becoming a hypertensive individuals. And target BP, it should be very, very same as that of a older individuals. Nutshell, hypertension young is happening in 1 in 8 individuals, adults in the age of 20 to 40 in US. We don't have much data from India. In hypertension, what is enigma and caveat? What we face into this low awareness. When you see a BP for young individuals comes to your clinic, if you see BP of 140 and 150, he used to say, clinic BP kodichu. So he will blame you instead of blaming himself. BP machine. So he starts to blame us instead of accepting his illness and rectification. He is not ready to rectify himself. And late diagnosis, many of the individuals goes for a cataract surgery, or many of the individuals goes for a 40 years, 50 years, going for a muscle checkup. They will find LVH in ECG. Echocardiogram shows LVH. For that, they will refer back to lower hypertension. At the time, patient will have ladder pains, any form of hypertensive retinopathy, and so on. And psychological themes. When you say you have a disease in young individuals, awesomely you go for depressions. Any individuals in the 20 years, 30 years, you have BP. Why you have to get BP? What is the reason for me to get a BP? So much of dilemma feelings, the psychological depressions can happen to individuals. That will reduce his goal to reduction of the BP. These deviates some other, and many times smoking, alcohol, many consumption of habits happen in this age. And female when get pregnancy, others becomes problems. Any hypertension is going for a pregnancy, we have to reduce many number of medications. We can't have a good optimal BP control for the individuals. And poor adherence follow. That's very things, because many of the middle-aged people are interested in buying a cell phone or buying a newer car or bike. Older individuals are concerned about health. These sorts of focus on their life differs from the young individuals than the older individuals for the matter. High risk of CV and end-stage events in the middle age if you're not properly addressed. Risk factors, why the young individuals happening getting BP? This process of problem happens in the fetus. So Professor Sesha used to say, focus on fetus for the future. So any abnormality or the young individuals is going to happen is happening at the level of the fetus itself. So any hypertensive female, and the child is the problems of hypertension is even transferred to the children, the capillary or all the vascular organs are being exposed to high level of blood pressure. That individual is at risk of problem. So low birth individuals, pregnancy in the mother who is going to deliver, that offspring is at risk of developing a hypertension at younger age. Genetic things and lifestyle, we know that many of the times we are spending much consumption of sodium and consumption of meat and red meat. It's a very, very high compared to the consumption of green vegetables. And lack of physical activity, indoor games are more familiar than that of outdoor games at all. Obesity, we see much more obesity in school-going children, depression, comorbidities, and secondary hypertension for the matter. So this is the when you are going to label a young patient having a high BP. So there is wide variety of confusions in these three guidelines, ACC and EAC and NIC. So one thing is European Society and NICE accepts that is stage 1, stage 2, stage 3 are same, except the wordings. They are saying it's a grade 1, they are saying stage 1. So more than 140, European as well as NICE is accepting there's more than 140, we should label patient as a hypertensives. But ACC and AHA want to say prepone. They want to reduce the threshold to 130. So stage 1 starts at 130 for ACC and AHA, and stage 1 starts or grade 1 starts more than 140 in European or NICE guidelines, but nothing else. What is it? Last like pre-diabetics. There's a pre-runner of before 140. They are giving a pre-hypertension or high normal levels where lifestyle intervention is needed. Then focusing on medications for that matter individuals. how you are going to investigate any individual of 20 or 30 years comes to your clinic, how you are going to investigate individuals. First, to see for any focus for secondary hypertension. Patients may have a features of thyrotoxicosis. Patients may have features of Cushing's or something else. Patient may taking of treatment for asthma. That may be reason for his hypertension. So search for secondary cause of hypertension and identify target hormone. Because many of the times we miss the diagnosis. We miss the diagnosing hypertension early part of life. So just to take an ECG, just taken a see the fundus of the individual, you can pick up. And urine may show proteinuria, that has to be treated. No need for doing so much of cardiac MRA, something else to direct your hypertension. And initiate appropriate therapy for a better BP control. So don't be lethargic. So give us some sort of lifestyle modification as the individual comes after 3 months or 6 months. Just don't postpone the appropriate medications. Optimize as early as possible, because these individuals, if you don't properly address, may go for a myocardial infarction in the middle age groups. And these are the common renal hypertension. Many of the things happens endocrine domain or renovascular domain. This is the most common cause of secondary hypertension. And drugs, you know, and renal may be vascular component or maybe parenchymal component. And vascular, there may be coagulation of aorta and vascular. Many of the symptoms we see coagulation of aorta is a misdiagnosis. And vasculitis, even if you do ESR, the CBC, the ESR may be elevated. Check for any arthritis symptoms. If you don't send to your rheumatologist domain, there we can prescribe vasculitis, what we commonly see in our day-to-day practice. Endocrinology domain, thyroid and hyper Cushing's and steroid, high level of mineralocortical activity and catecholamines are the common causes. And in young-age adult humans, we have to focus mainly on thyroid as well as renal vascular disease. This is the most common cause for young adults in the age of 20 to 40 getting hypertensions. And how will you see if these individuals form because all the individuals comes to your clinic, we can't go for addressing urinary metanephrines or going for a cortisol suppression. It is impractical to be done in the day-to-day process. When you want to suspect whether this individual forms a category of secondary hypertension, any individual less than 30 years without any comorbid factors. So search for any physical clinical signs for secondary hypertension. In individuals not having appropriate control with 3 medications, including a diuretic, if it's not able to have a good control, check for any secondary causes there. Sudden deterioration of BP, starting a ACE inhibitor or ARB, BP falls down or increase in escalation of the serum creatinine, check for renal stenosis. That may be a reason for the patient. And evidence for end organ damage. Suppose patient have proteinuria, you have to start the patient on ACE inhibitors and check for renal artery domain, whether the patient having parenchymal disease or not. And other causes for hypertension, examine renal artery bruit or Cushing's features, anything is there, you can check for that one. And how you're going to investigate? So first, what I need to investigate, you have to find what is the secondary cause of the hypertension and assess the damage, and you have to appropriate therapy. Patient having hyperkalemia starting ACE inhibitors is going to develop any form of ventricular fibrillation and going to die. So ECG, you can take baseline ECG that can predict LVH criteria. You can check the LVH criteria, LA enlargement, that is surrogate marker. The patient is having long-standing hypertension. Echo, ESC recommends echo for all young hypertensions, but ACC and NICE doesn't recommend. Even if you're not able to, because echo, you can check LVH, even coagulation of aorta can be found out. Serum creatinine levels and the serum electrolytes. Serum electrolytes high sodium and potassium. The patient most probably have renal parenchymal disease. When there is a low sodium, low potassium, patients may have endocrine related issues. You can these sorts of way doing electrolytes. The sodium is high, potassium high. Check for the renal parameters and check along the renal angle. If the sodium is very low, potassium is very low. Check whether the patient's having Cushing's or mineralocortical states. That's so that these are the way where you want to go step by step management instead of going writing a battery of investigation for any individuals. Nothing is going to be good for the patient's angle. And urine for ACPCR, that is albumin creatinine ratio, optic fundi, ESR can be done. These are the things we have to do it to assess secondary hypertension issues. This is simple X-ray can tell that is the aortic knuckle. We know the aortic knuckle will be constriction. If you have see this order for lateral X-ray where you can reverse 3 sign, that can tell about the presence of coagulation of aorta. Because many of the mass check will be done, the X-ray will be reported as normal. If they have any, you're seeing hypertension in young individual, check for any presence of coagulation of aorta is there or not. Other investigations, you can do battery of investigations. So you can do thyroid profile, renovascular hypertension. So if you any find abnormality in the basic investigation, you can go for in the dangle. Patient having high thyroid, you can go for thyroid medications. Whatever you want to assess Graves' disease, you want to do next FNAC, whatever you can do it as want to treat the primary illness of individuals. Renovascular hypertension, as you like, you can do it. Catecholamine and hypertension. We can do battery of investigations that can be done in these all individuals. And what is a risk-based approach? Is any risk-validated tool is there to assess these individuals develop any myocardial infarction in 10 years? Because many of the risks, if your AACV risk score is there, Q-risk score is there, many of the score is there to predict where which individual is going to develop heart disease, any MI, or any form of ACS in the next 10 years. But what is the problem? All the risk scores are amended based on some studies. And that study is not a true representative of the people of having young hypertension. So even if you put risk score in individuals, age is the major criteria. When the age is 60 years, the risk score is high. When the age comes to 30 years, the risk score is not that much high. So it shows when you apply risk score, the score will be very low. So it will not be appropriate to treat medication, optimize the therapy. So applying risk score in the younger individual becomes a problematic, because if you don't treat hypertension, these patients will develop any form of microvascular or macrovascular in the middle-aged problems. So the risk score enrolled, the population, the risk score enrolled is not a true representative of the young hypertension individuals. And other risk factors, because many of the 20 years diabetes not be there. But 60-year individual having a diabetes and hypertension, the sandwich is be very common in the older age than in the younger individual populations. And so CV risk factors are very, only one risk, Q-risk score has included the populations between 25 to 45. That's enrolled. The young population was enrolled on this Q-risk 3 scores. And you can apply this if you wanted to have if you want to apply any risk score for younger individuals. Now, how should we treat younger hypertension? So early detection is very, very paramount importance, and appropriate medication has to be initiated. Now, it should be optimized. Giving medications alone is not sufficient. You must ask the patient, you can go for home monitoring of BP or ambulatory BP to assess the dippers and non-dippers. Based on that, you can give medications to individuals. So lifestyle intervention is very, very important. But many of the times, even advocate weight loss, they may put on, there may be loss of weight that can be translated in terms of BP reduction, but we don't have randomized controlled trial to tell this sort of life intervention has been good for adults for long terms. So we need much more research in the lifestyle modification in control hypertension in the young individuals in the long-term basis. And treatment aspects, as there are so much of confusions. So one thing is very, very great for me. That is, after systolic BP more than 160, what are the guidelines we follow? ACC, EAC, NICE, you have to treat it. So more than 160, no compromise. The problem happens in the early stages. Only when the BP crosses more than 130. More than 130, ACC says, if the patient having any form of ASCVD, any form of vascular events, please treat it. Any risk score more than 10%, you treat the individuals. But ESC says no need to treat, just keep a lifestyle modifications for the individuals. We can wait and watch and ask the individuals to reduce their weight, or so much of lifestyle interventions can be done. So when it comes to 140, that is, if you go by ACC, it's a stage 2. But ESC, NICE is a stage 1. In stage 1 also, the ESC and NICE says don't treat. But if the patient is having hypertension or coexisting with diabetes or any form of microproteinuria or any vascular risk, when the Q-risk score is more than 10, you can treat. So before in a nutshell, more than 140, you have to treat. So if there is no risk individual, you can give a lifestyle modification for a period of a month and reassess the patient. If even the lifestyle is not beneficial for the patient, you please put on the patient on the medications. 140, more than 140, you get to treat it. And how should treat? We don't have much data. This drug is superior in the individuals. This drug is not superior. All the drugs, what we use as first line of antihypertensive management, ACE inhibitor, ARB, CCB, therapies are equally effective. And medications, what you use should be synergistic with the primary treatment. Versus hyperthyroid patients comes to a clinic with tachycardia, don't put the patient on CCB inhibitors. Try to give beta blocker for the individuals. Patient with some sort of heart failure comes to a clinic, don't give patient on CC inhibitors, preferably gives beta blocker. That sort of things you have to ACE inhibitors, like that you can give instead of what the medication is going to use, it will be synergetic for the individuals. Patient with gout, don't give on thiazide group of thyroidics. So you must access all the parameters when you want to treat medications. What the medication you're going to use, that will be synergetic. There's no sex disparity in choosing a medication, but when you use ARB and ACB in childbearing period, you have to warn the individual. If you get become pregnant, there's a possibility of teratogenic effect of these molecules. Then you can choose the drugs, whatever, nifedipine or amlodipine or beta blocker, depending upon the patient profile, you can choose in these individuals. In AHA and EC, they have not recommended any specific treatment, but NICE says any individual less than 55, we have data to support the usage of ACE inhibitor ARB, except black African peoples where they are recommended calcium channel blockers. So less than 55 years, AC inhibitor ARB has good hold. If there is no renal compromise in the individuals. That's the last slide. So this is nutshell. In young hypertension is very, very common. And BP, we track it because these individuals are a tray of prey for any macrovascular or macrovascular complications as they move on to middle age. And we don't have much validated 10 risk score to assess these individuals, whether these individuals get any problem or not. So investigations, do the baseline investigation, don't order all the investigation at the first point of entry, check whether the baseline investigations are normal or not. If there is any abnormality find at baseline investigations, proceed across the angle which it directs. So ECG, echo if you want to detect thyroid and creatinine and microalbumin is more than sufficient. And treatment, give importance for lifestyle changes and assess the cardiovascular risk and heart age as per the risk, whatever risk you have, factor you have, or you have justifications. You can start initiation of BP if the BP is more than 140/90, and you must use a drug which is be friendly for his primary disease, maybe thyroid or maybe renovascular disease for that matter. And AC inhibitor, ARB are good holds, good in young individuals. You can use CCB if it's not under control, optimize. The choose of a drug, the choice of drug is on the physician's domain. You have to speak with the patient. There is holistic approach should be there when you want to initiate any medications in hypertension. Thank you for the patient listening.
It was crisp, Adhiman. I think most of the people nowadays we are seeing young hypertensives less than 40 years, and even less than 20 years also we are also seeing the patients. Most of them are having minimal hypertension, and mostly the big important history they say is stress. And even school students, we have seen people, 12 standard students, 11 standard students with a blood pressure of 140/90. And moreover, obesity is also in the increase. So I think lifestyle modification should start right from school age. We cannot wait till late 20s or 30s. I think, and the treatment for young hypertension should be individualized. There is no, as Mahadevan told, there is no as such RCTs which have a solid data or robust data recommending what drugs to be used in young patients. We have to see the pros and cons of the drugs and the need of the patient. Ultimately, the aim is to keep the blood pressure under control, that is less than 140/90, the newer standards, and try to find out any secondary cause of hypertension. Don't over-diagnose or over-investigate the patient. Just do some basic investigations and keep a check on his blood pressure regularly. And nowadays, a lot of gadgets have come. There is electronic gadgets that monitor the blood pressure of the patients, and maybe we can get use of the modern gadgets and ask these young fellows to keep their blood pressure under good control. Thank you.
Yes, so one question, sir. So, woman of childbearing age, married, sir, which drug will you choose? But not pregnancy, non-pregnant. Is there any guideline for treating women of childbearing age? Because we cannot use ACDR because they can become pregnant anytime between the age 20 to 40.
Yes, sir, you rightly pointed out. Women of childbearing age, if they wanted to conceive, if they are planning of conceive, you should not use AC inhibitor ARB or to discuss with the patient. You can use nifedipine or amlodipine or beta blocker for that matter. You can use even alpha dopa for that if you are willing, with the patient wants to continue.
I am asking even if they are not planning for pregnancy because we do not know when they are planning pregnancy.
Then do a family sterilization. They have to advocate sterilization, then do AC inhibitors.
That is, if they are not, they have no, they have only one child or no child. We cannot start till the second child.
What the point you are telling is validated. It's been there in even ACC guidelines, sir. Even because many of them, the pregnancy is not been noticed by them. That is the reason when your childbearing comes, if there is any indication, start AC inhibitor ARB. Suppose 20 years female with proteinuria, you can't put the patient on nifedipine or whatever beta blocker because whether patient is going to pregnant or not, his kidney is going to get damaged. So at the time you are forced to write AC inhibitor ARB. Whenever you write a prescription, you have to tell the patient the next pregnancy should be planned one. If there is possibilities of you get accidentally pregnant is there, so pregnancy cannot be accident. So if there any accidental pregnancy is there, automatically you have to terminate the pregnancy, or there is a possibility of teratogenic effect on the fetus will be there. It should be explained.
Can you define what is young or what is old? Because many people, it varies from country to country.
My age is 45, so I am young. So when I comes to 55, I am also young. So study says geriatric population is above 65 years. So till 65 years, it can be taken as zinc because but you want to middle-aged and younger age, it becomes a problem. So what what are the review articles take when you go by young hypertension, they are segregating in groups. So less than 55 years, they are saying the 55 years, 30 years. When you analyze hypertension prevalence, from 19 years to 29 years, they're keeping one arm, and 29 years to 39. Like that, they are giving every 10 years. I know why they are choosing even instead of 20, they are keeping 19. I don't know. I could not define. I thought it's a teen, 18, 19. So after teen, they are taking it. It was my assumption, but it did not be written. After 19 years, what happens to the BP level? When you go by, the article was the global prevalence of hypertension that was published in Lancet. So they say 19 to 29, 29 to 39, like that they were segregating what the prevalence, when the decades increases, what happens to the prevalence and all. And many of the things they are taking from registry, and in which was enrolled, and many of the military when you go to hypertension, many of the individuals when registered, medical checkup was done during entry point of military, they were followed period of times. So exact location depends upon, you can tell yourself as I think, sir.
I'm still young.
Young at heart.
But nice guidelines, they are saying less than 55, they are taking as young, sir. Less than 50. Many of the trial RCT nice guidelines, they said many trials conducted less than 50 years, AAC inhibitors, ARBs holds good BP control and beneficial effect is there.
Salt.
See, Meenakshi madam is there. Meenakshi
madam
will
ask in the next. Yes.
It was a well-structured talk, sir.
Thank
Only
you.
my take was majority of the hypertension patients will be landing up with physicians, GPs, or cardiologists and nephrologists. So what we see is only tip of the iceberg, and the rest of the cases are still not underdiagnosed. So the one thing is, any patient coming with hypertension, have a bird eye view. Don't investigate much. Just take a detailed history of the patient. Then you investigate like a detective where your path is leading you. And second thing, education. So educating the patient about home BP monitoring and charting, as well as educating the fellow colleagues as well as the patients about the utility of ABPM. Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, chairpersons and the speaker. We had a nice session. We'll move on to the next session. More or less, the two sessions will be mostly on diabetic related various aspects. Now, for that, first session, I call Dr. Gautam sir to chair the session, and also Dr. V. Sheshadri. Both are very good physicians. You can learn a lot of things from them. And the first speaker will be Dr. Meenakshi Basaj. I think she has got F, no fat friend 4. And the next speaker, our friend Dr. Vijay Kumar, the diabetologist, hospital management of diabetes. And the third one will be virtual. Dr. Ravindranath on sexual dysfunction. Over to the chairperson. And welcome the.
Yes, sir.
Yeah.
Good afternoon. At the outset, I would like to thank the organizers for giving us a wonderful program and inviting us to be the chairperson. And the first topic is the trending one, the dietary fat front of four. And the best speaker is Dr. Meenakshi Bajaj. Already I've listened to her once. So she was always clear and crisp. Her credentials are there. So time constraint, madam, we'll go to the topic.
At the outset, I'm truly grateful to Dr. Chandrasekhar sir and his entire team for the opportunity to be talking to you on Cardio-Metabolic Congress. And the topic chosen here is fat, foe or friend. But before I address this, I thought I'll take up the question. There was a query on which sort of salt should one consume if you're hypertensive or trying to, talk of lifestyle modification. And most often we are spoken of DASH diet, dietary approach to stop hypertension, wherein we reduce the total salt consumption in terms of sodium chloride. But as you mentioned, there are different types of salt. There is kosher salt, bamboo salt, rock salt, puro salt, and a list of them. But if you want to improve hypertension, first thing is reduce the consumption, total consumption of salt. Second is you can choose on a potassium rich salt. So you have certain salts which are available in the market, which have almost 30% of potassium and 70% sodium. So if I'm to talk of the trade names, you have Tata Light, Sapola salt. You have another salt called Puro salt, which is otherwise the which are rich in potassium. There are also certain salts which are completely potassium salts. I think that was available way back called Lona, which had no sodium at all. It had only potassium, but that's very, it has a very metallic taste. It's not very comfortable to choose on that unless you take it for an acute phase about 1 week or so. So that's the answer for the salt part of it. So when we talk of fat, food is not palatable if you don't have fat on the plate in the form of a recipe. It could be a plant-based fat, or it could be an animal-based fat, whatever type of fat. Unless and until you want the food to be palatable, it should contain fat. Second is, we always think only the negative side of fat. Why don't we think it's also important? If you talk to a neurologist, he's the first man to say you bring down your total cholesterol as low as this. He says the brain's important component is cholesterol. So don't go very, very low on cholesterol. So obviously there are two sides of a coin. So similarly, when it comes to fat, we have two sides. We'll be discussing this in the next 20 minutes. So when we talk of fat, we have to understand one is the fatty acid component, that's the glyceride component, and we have the non-glyceride component. The non-glyceride component is the one which is the friend in the part of the fat, which means it contains lignans, resveratrol, phytosterols, tocoinols, tocotrienols. All these components are the ones which improve the health or the metabolic health of an individual. I would say they are immunonutrients, they are antioxidants, anti-inflammatory in nature. They also improve the lipid profile. But always remember, when you consume a food ingredient, you are not consuming only the fat component or only the carbohydrate or only the protein. It comes in a combination with several other micronutrients and fiber. So when we talk of nuts, I think it's the favorite of everybody. Now, everybody is talking of nuts, whether you want to go on a ketogenic diet or you want to blunt your postprandial glycemic response, or you want to replace some amount of saturated fat with mono or poly, you talk of nuts. When we talk of nuts, we talk of one exchange of nuts, which means approximately it provides 85 calories. Any nut, if you take it up to 15 grams of nuts, it will give you almost 3 grams of protein, 7 grams of fat. Now the crunch is there. The 7 grams of fat can come from saturated, mono, poly, or a combination of all the three. Apart from that, you have about 1 gram of fiber. Now, I would like to share some time on this particular slide. If you look at nuts, remember when it comes to walnuts, it looks more like a brain, right? It's nothing great, but that's omega-3 fatty acids. The second thing is we talk of monounsaturated fats, that's the almonds. These almonds are rich in monounsaturated fat, not in omega-3. Secondly, they need to be soaked overnight and then consumed after deskinning them, because it's not only the fat which we are looking at for almonds, it's also zero carb count. Also, the other thing is it is rich in zinc and protein. We need the protein to be bioavailable, more digestible. The zinc has to be more bioavailable for the system in order to improve the immunonutrient function of the almond. So you need to soak it. Now, always when we talk of groundnut and cashew nut, the whole world, at least I would say, I've been major part of my life in South India. So I would say they're very friendly when it comes to groundnuts. Cashew raises our brows, but look at the profile. Profile is not any different. It's almost the same. In fact, cashew nuts are slightly one edge better than groundnuts. Groundnuts, we can just, if I give you a handful of groundnuts or a handful of cashew nuts, which you think you will finish faster? Obviously the groundnuts. You're watching the last over of the cricket match with India and Pakistan. How many bowls of groundnuts will walk in? Nobody can even think of it. But look at the profile. Profile is almost the same. In fact, MUFA is higher in cashew nuts when compared to groundnuts. But does that mean we take empty? No, we don't take empty in quantity. We just replace one idli, one dosa, one chapati, any one of them with one handful of nuts prior to the meal. Follow the food order. So it will do good in terms of fatty acid profile, in terms of satiety, in terms of micronutrients. Coconut. We cannot B, without talking on coconut. Remember the saturated fat acid content. It is as high as 91%. American Heart Association 2017, the presidential advisory talks, the ratio is 82%. But I would say Indian food composition tables talks to us about 91% of saturated fat. There is no ambiguity in saying this, that saturated fat does raise the LDL cholesterol and it does have an influence on morbidity and mortality. So coconuts, they are a source of saturated fat. So restriction is important. It goes without saying. Now, when we talk of this study, which was published in the American Journal of Clinical Nutrition, it talks very clearly that when saturated fat has been replaced with plant-based MUFA. I just mentioned to you, MUFA, we have a source of almonds, we have cashews, we have groundnuts, which are sources of MUFA. So when you replace plant-based MUFA from the saturated TGL and the refined carbohydrate, you see that the risk of dying with all different causes comes down by as high as 16% when you choose on plant-based MUFA. Now, this is what about coconut I was talking to you of. This again, the American Heart Association Presidential Advisory Guideline 2017 very clearly tells the fact you need to lower the saturated fat, especially with PUFA, which will lower the incidence of CVD by 30%. The reason being, they did a study, not only one study, there is actually a systemic review with 7 trials, which 7 trials included comparison of coconut oil with beef and cheese, different sources of saturated fat, wherein they found that whether it was beef, whether it was cheese, or whether it was coconut oil, it did raise the LDL cholesterol. 7 out of the 7, there were 6 which were statistically significant. And this is the guideline which tells us that when there is a raise in the LDL cholesterol, you need to bring down the saturated fat to 5 to 6%. Otherwise, general population, you can go as high as 10%. So many of them come to me and tell me in Kerala why they are choosing on coconut oil and we are not seeing so much of mortality and morbidity. You need to understand in Kerala, there is red rice, there is fish, there is coconut oil, and not to forget there is physical activity. If you just want to choose one component, coconut oil and coconut, and forget the other components, then you're not going to do good to yourself. So go local, go seasonal, go traditional. Now look at these sources. These are all animal-based fats, whether you talk of milk, ghee, butter, cheese, eggs, whatever it is. It ranges its saturated fat from 51% to as high as 91%. And all these sources are sources of saturated fat and cholesterol. It's only the fish or the seafood, which we would say contains the omega-3 fatty acids. Now, these are the different types of fats. I'll not go into the details, but this just gives you a snapshot that these are all processed fats from animal-based fats. Now, look at this. I want to say a single small story. You know, people have been replacing butter with margarine. What was butter? Saturated fat. It has some amount of trans fats also. That is why they said, let us move to something which is more healthier, which is giving us the taste of butter, but actually not butter because it is going to be made from vegetable oils, which is a combination of MUFA and PUFA. But they forgot that it was processed. And in the process of hydrogenation, it was converted into a trans fat. So no better thing to move from butter to margarine. But of late, recently, we have some margarines which have come into the market, which are low in trans fats and are not processed in the form of partial hydrogenation. So now, but remember, butter, when you go to a pav bhaji counter, the tawa is piping hot on which they put a blob of butter, and that's also really at a high temperature. You're making the bun on it, and the bhaji is cooking continuously with butter. So you keep reheating the butter. The butter is already a source of trans fats. Second is reheating increases the trans fatty acids, which increases LDL cholesterol, TGL cholesterol. Apart from that, we have the apolipoprotein, the A and the B, and the dip in the A1 as well as in the HDL cholesterol, all of this happening with trans fats. So reheating all oil, that's why people say, I think even our elders used to say that you cook in an iron kadai, in a steel kadai, not in an iron kadai. A steel kadai, the oil does not get rancid very fast. The smoking temperature is still on the higher side. Otherwise, the smoking temperature also changes. So this is about the trans fats. And yeah, this is the animal fats. I'll give you some simple new information, which will be shocking, but which is a food for thought. We all know a whole egg, which will be about 42 to 50 grams. which is a source of cholesterol, which contains about 183 milligrams of cholesterol. And every day we have a new guideline telling us how we need to keep reducing our LDL cholesterol or our total cholesterol. But more so, we walk in between 200 and 300 milligrams of cholesterol, dietary cholesterol per day, though we know that 85% is synthesized by the liver, only 15% comes from the food, and all the reasons go on. But what is the specialty here? Look at the egg whole, which is 50 grams, has 183 milligrams of cholesterol. Goat chops, that's mutton, has 100 grams, has 88 milligrams of cholesterol. Beef chops, in fact, we hear, at least in the hospital, when we talk to the patients and we get a recall from the patients, especially the gestational diabetic patients, their consumption of beef is very, very high. As well as the onco patients, the beef consumption is super high, but the cholesterol content is low. This gives us a food for thought to understand that what else is the component apart from cholesterol, which is sitting in the red meat or which is sitting in the beef chops. Now look at the right side of the slide, the goat brain. It is the highest source of cholesterol, 1,130 milligrams. In fact, the monkey brain is a delicacy when it comes to Singapore. But I'm not suggesting or advocating to consume that, but I'm just making a mention of it. So remember, cholesterol is not the only thing. We need to look for something else beyond cholesterol when it comes to beef chops or goat chops. And this is another delicacy, emu meat, which has a very, very low cholesterol when compared to egg, but the taste is actually similar, but unfortunately the prices are very, very high. I'm talking of this was available for 400 rupees per kg almost 10 years ago. Now, what about the cholesterol story? The cholesterol story, it is very clearly evident in 2015, 2020 AHA guidelines that don't worry about cholesterol, but people only read the spicy headline. They forget to read the entire guideline. The entire guideline still says if you're having type 2 diabetes with comorbidities or congestive heart failure, or you have dyslipidemia, you definitely need to worry about the total cholesterol apart from the medications you are put on for it. And the FSSAI has laid some guidelines to processed foods as to when a food can be called as low cholesterol or free from cholesterol. So this is the trans fats. Now, there is one more story in this. You know, in understanding and learning about these guidelines recently in the last 1 month, I realized that trans fats initially, there are of two types, industrial trans fat and the trans fat which is present in the milk which you and me consume, the red meat which you and me consume. Now, between these two fats, till 2016, the consensus was the ones which are present naturally in milk and red meat is no harm at all. But the 2017 guidelines very, very clearly says between the two, they both are equal in the damage they do, whether it's the LDL, whether it's the TGL or the apolipoproteins. And look at vanaspati and ice cream. It's shocking. They have equal amount of trans fat. Butter has slightly lesser trans fat when compared to ghee. In fact, about 30 years ago, before I did my BSc in nutrition, we used to fry the puris in ghee till I did my BSc in nutrition. In fact, ghee has a very, very high smoking temperature. It can be used for frying, but we cannot forget it's a source of saturated fat. So these are the trans fat stories. Now, this is some guideline to tell us that there has been an increase in CHD when you increase TFA, and the number of deaths are very high with reference to WHO in terms of industrial trans fats. Trans fats have been banned in the New York City, and they found there was a decline in the hospital admission, heart attacks and strokes. And as I mentioned to you, they are equal in their damage, what they do, whether it's industrial or ruminant fat. Now, this was something interesting. When children consume trans fats, in fact, what India eats has been published by ICMR 2020 based on the NNMB data, wherein they found that ultra-processed foods, which are sources of saturated fat, trans fat, all the bhujia, snacks, namkeens, savories, which you consume, they have penetrated into the rural region to as high as 4%. Obviously, in the urban region, it's as high as 11.6%. And when children consume it, they are at risk of eczema and asthma. And pregnant women consume it, it crosses the placenta. It also has an influence on the length of pregnancy. Apart from that, we also have the Nurses' Health Study talking to us about CHD, type 2D in breast and colon cancer. And recently, US FDA has recently revoked the GRAS status for the partially hydrogenated vegetable oil. In fact, any food product, if you see, it will not directly say trans fats, it will say edible hydrogenated fat. In fact, though it's a scientific gathering, but I would still want to make a mention. Mary biscuits have been part of everybody's family for I don't know how many years. I think it's called a diabetic biscuit or whatever. There was a time when it did not contain, when it did contain trans fats, and now there's a big oval circle saying no trans fats. So any bakery item is a source of trans fats unless and until they make a label mention that it is not a source of trans fat. So heart attack rewind is another guideline which has been, raised and revoked by FSSAI, wherein they said that all industrial processed foods should have trans fats less than 2% in their packages as on 2022. The global guidelines say as on 2023, we do not want trans fats more than 2% in any packaged food. So this is something about reheating of oil, which I was telling you. Any oil, suppose you have fried a vada or a bhaji or a pakoda today, tomorrow when you use that oil, it has to be used only for sauteing, or you're preparing your dosa or something, or a gravy. After 48 hours, you have to discard it. If you're going to refry in that particular oil in which you have fried, you are only consuming trans fats. So what is the best type of oil? All this depends on whether it's unrefined, refined, omega-3, 6, saturated, unsaturated, flavorful, neutral, or smoking point. If I have about 2-3 minutes, I will just go through this. What is the difference between chakenne, cold pressed oil, or you would say unrefined oil, raw oil, virgin oil? Difference between the two is some amount of vitamins and minerals are retained in the chakenne or the unprocessed oil. But when you are refining the oil, you're removing the inorganic phosphorus, you're removing the impurities, you're subjecting it to a particular temperature. And fourth is you're losing vitamins and minerals. But most importantly, you're trying to save on your kidneys, and the temperature, the smoking temperature of that particular oil is on the higher side when it is refined when compared to unrefined oil. So any unrefined oil, people spend a lot of money buying chakenne, a lot of oil. You cannot fry in that chakenne because the smoking temperature is really low. It's really low. So that's the first message. Second message is it does contain impurities. Third is it is a source of inorganic phosphates, which is not renal friendly. Now comes to omega-3, omega-6 is always a confusion. Though the recent ICMR guidelines does tell us we want the omega-3 in the ratio of 1:5 up to 10 when it comes to omega-6. Saturated, unsaturated, I think I'm quite clear about. Neutral oils are those oils which do not have any flavor or color, but they just are neutral when it comes to preparations. All the canola, the safflower, the sunflower, peanut oil, all these are considered as neutral oils. And smoking temperature or smoking point is the point when the oil starts getting rancid. When the temperature goes so low and it starts getting rancid, it starts becoming bitter, burnt, gets converted to fatty acids and triglyceride. That is the point called the smoking point. So the smoking point should be on the higher side if you want to use it for Indian cooking. We want to have the jeeragam and the kadag splutter. We want the frying to be done for several occasions. Whatever reason it may be, you need to choose an oil which is called an all-purpose oil if the smoking temperature is high. Now, what are the oils which are having a high smoking temperature? We have the refined groundnut oil, refined coconut oil, canola, rice bran oil, ghee, and the extra light olive oil, pure olive oil, refined olive oil. All these have a high smoking temperature. Does this mean I can choose on this oil? The next component I need to see whether it's a source of trans fat or saturated fat. So that's the second thing. And apart from that, we have a lot of novel oils like the flaxseed oil, hemp oil, grapeseed oil, pumpkin seed oil. All these oils are available. Avocado oil, walnut oil. Does that mean if they are novel oils, they are the oils which are fit for our Indian cooking? Definitely no. We have only the avocado oil, which is an all-purpose oil, or the grapeseed oil, which is an all-purpose oil. The rest of the oils are not. So what do? What combination do we follow? We need to follow the saturated mono and poly in the ratio 1:1.2:0.8. The best thing is to choose on rice bran oil for your cooking, where the absorption of fat is less by 15%. That is first thing. And second thing is soybean oil. There is an issue when it comes to glycemic friendly. We have found that it is obesogenic. It helps in gaining weight, thereby insulin resistance and not being glycemic friendly. So that's something about soybean oil. Third thing is if you use groundnut oil, remember to use only skimmed milk. There are certain combinations which I'll share with you, which the National Institute of Nutrition has proposed. You can choose on rice bran oil with mustard oil in the north, or rice bran oil with canola oil, or rice bran oil with soybean oil. But as I mentioned to you, soybean oil is not very, very glycemic friendly. For people who are very, very fancy, who have hefty pockets, they can choose an olive oil with safflower, or groundnut with safflower, or groundnut with sesame oil. So these are the novel oils which I was talking to you of. Then you have the novel omega-3 fatty acid, which is known as the krill oil. The best part of this is that it is more bioavailable when compared to the regular EPA and DHA. Next comes the algal oil, which is also a source of omega-3 fatty acid, which is plant-based, and it is used in a lot of infant formulas, food additives, and pharmaceutical. This is basically the guideline which has been proposed by various associations. Simple thing is, you do not cross more, you don't go low, very low, lower than 20% when it comes to fat. Don't cross 35%. Saturated fat, ideally keep it between 7 to 10%. Trans fat, as far as possible, nil or less than 1%. Omega-3, omega-6 ratio, I've already mentioned to you, MUFA should be the highest, but remember, there has to be a blend of oils. Choose one oil for dry and one for vegetable. Say, for example, you're using any oil, gingerly oil. Suppose you're using gingerly oil, quarter liter gingerly oil for gravy and quarter liter any other refined vegetable oil for your dry vegetable. So when it comes to frying, remember, use stainless steel, avoid iron. And when you have black particles in it, unless you remove them, if you don't remove them, they are going to lower the smoking temperature of your oil. So AHA dietary guidelines very clearly tells us that we need to replace the saturated with unsaturated to bring down the CVD by 30%. Choose on liquid plant oils rather than tropical oils like coconut oil, palm kernel oil. Obviously, a big no to butter or lard. And liquid plant oils are rich in unsaturated fatty acids. So choose on tree nut oils and peanuts. Flax seeds, the message here is, do not choose on flaxseed oil. Roast the flaxseed, grind it, refrigerate the small quantity, munch on it along with your meals. They will give you the omega-3. Otherwise, they are going to get rancid. So I would say, choose on being fit. Don't rely only on one nutrient. It has to be a blend of all macronutrients, a blend of all oils. And remember, fatty acid, choice of fatty acid is important, but you still need all the 3 fatty acids. Thank you for your patient listening. Moderation is the key.
Thank you, madam. Just finished in time. So first of all, thanks for that. And I think everyone agrees it's very clear. You cleared many doubts actually. One question from me is, what proportion of fat should be of the macronutrients per day consumption?
Only macronutrient, you're talking only fat.
Only fat. What
Only
proportion
fat?
should be? What are the macronutrients?
Yeah, okay. Out of the macronutrients, we don't go below 20% and we don't cross more than 35%. So 25% is perfectly
25%
good.
will be ideal. Okay. I think you can allow one question from
that was an excellent speech. We all eat food, not macronutrients or nutrients. Okay? And Meenakshi was very clear in explaining both aspects of nutrients as well as food waste. Okay? Fats are important. Don't say it is fat is totally to be avoided. As she said, 25% of your thing. The one point about fats is that, yes, cholesterol, it plays a very important part. If you had listened to Dr. Ajit's speech, you would have said that plaque rich in lipids is a highly vulnerable plaque. Okay? That's the one thing that we have to take in a message. It is basically the fats that count. It is time that we all understand this and also advise suitably our household to change the type of oil we use, to change the type of cooking we do. I think that is the message she has given in an excellent manner. Thank you.
Thank you so much.
Madam, one doubt. Here.
Yes, sir.
Yes. Madam, your comments on pure study. Pure study contradicts like whatever has been told. It says like the oil, the energy from the oil can be as high as 40%. But still, it plays a important role. So
pure study was done much before the American Heart Association Presidential Advisory Guidelines.
I didn't get
The Presidential American Heart Association Guidelines have been released in 2017, published in 2018. I think the pure study was much before that.
So what is the take, madam? So our consumption of oil should be This
It should be
residential and-
between, a single study will not help us, no, sir.
Madam,
It's
that is the
always,
only study we have. Like, I haven't seen any studies at par with a pure study which gives so much of data.
even the NHS study gives us a lot of data, sir.
That's okay, madam. But this sort of data, like which
Sir,
really transforms the way-
90,000 subjects have been studied for 22 years. And that data has been published in American Journal of Clinical Nutrition 2018. I think we have studies, a lot of studies, and more than the studies, these recommendations have been produced by not 1% or 2%, by several societies. So all the societies have been doing a lot of RCTs and systemic reviews to tell us that the fat percentage should not go lesser than 20%, because we have a lot of hormones which are required. I mean, we need fat for a lot of hormones. I don't think I need to tell that to you. So less than 20% we don't go, and less above 35% we don't go. We'll have to moderate it between 20 to 25, say 30, depending on the patient's comorbidities.
Thank you, madam. I think anyone want to see her exhibition, you can go to Omandora. She has got a beautiful way of all types of diet. I think you should go to Omandora.
I had done it in Institute of Dietology, MMC, sir.
Not
here, over there.
I think
I
you
think
should do it.
Professor Anand Moses, I think one day before his retirement, we had inaugurated that exhibit. It's at the Institute of Dietology, Madras Medical College.
Thank you.
Thank you so much, sir. Thank you for the.
Then next talk is an interesting one, in-hospital management of diabetes. It has been ranging through a lot of controversies for the last 10 years. The level at which the control has to be obtained, it was initially studied in ICU units, and then in non-critical care units, and then people who are diabetics, and these are the things that has been always a controversy. All these controversies can be easily explained, and still it is going on. And I think we have none other than Dr. Vijay Kumar, who is an expert in this field. And I have been pleasure of listening to him many times. And I think he doesn't need any introduction, except that let us listen to his talk.
Good afternoon, everybody. Thank you, sir, for a kind introduction. As Mahadevan was telling, I think it's a very difficult time to have a lecture, right? So if anybody wants to sleep, they can. They're welcome to sleep, but only on one condition: they will not snore. You know why? So the next person who's trying to sleep will be disturbed with his snoring. That's the only thing. Anyway, thank Chandru and Dr. Shanmugam sir and everybody in the organizing committee for giving me this opportunity. See, Chandru gave me a task of speaking on in-hospital management in 20 minutes time. I'll try to do that. It's in fact, this is a huge topic actually. In fact, we can do a workshop for half a day on this, how to manage, but I'll try to make it simple and then I'll try to finish within the time. Now, why is it very important is the management of diabetes is because of the vicious cycle that we can have. You could see the vicious cycle that any hyperglycemia through these mechanisms can cause acute illness. You know, for example, hyperglycemia can reduce immune function and decrease wound healing, increased oxidative stress, and all these things put together can got acute illness. And acute illness, if we can see that because of counter-regulation hormones that can be elevated, and that in turn can cause hyperglycemia. This is a vicious cycle. You know, hyperglycemia causes acute illness causes hyperglycemia. And that is the reason we need to, when we try to admit somebody in the hospital, it is basically because of the acute illness. Otherwise, you don't admit everybody into the hospital. And it's very, very important to treat hyperglycemia during that time. Of course, we treat the acute illness as well. Now, if you look into the treatment, it goes very, very simple. Nothing hanky-panky here. In a non-critically ill patient, keep it around fasting around 120, and then keep the postprandial or random blood sugar less than 180. This is very simple. It's quite easy to do that. But how we do it is very important. What are the various situations that we need to look into that? And if you look into the critically ill patients, I think we need to be not very and earlier the days we used to have that, they used to say that keep the blood sugar between 80 to 110 and all. And all these things have been kind of, and the NICE guidelines clearly said that keep the blood glucose in a critically ill patient between 140 to 180. That's enough. Very simple numbers, 120 and 180 and 140 to 180 in critical ill patient. Very simple. Now, if you look into that, the way we need to, whenever talk about in-hospital management of diabetes, just basically three things. One is management of diabetes in the wards. That is most often that we see. And then management of diabetes in perioperative period. And the management of diabetes in ICU. Given the time, probably I'll spend more time on the management of diabetes in the wards. And I'll just touch upon perioperative and ICU. I mean, I don't want to go too many details into the other two, but I'll speak detail about the management of diabetes in the wards. Now, though we say that it is 120 to 120 is a fasting and 180, but what we need to understand is that the striving for euglycemia, the careful attention we paid towards hypoglycemia, very, very important. The one episode of hypoglycemia during the ward will be disturbing the whole glycemic control for the next 48 hours. You know, one thing is that you are worried that I'm giving one more dose of insulin, you may get into one more hypoglycemia. And then I'll tell you, during the course of the time talk, you'll also know why people will go into hypoglycemia, why it is worrisome. I'll let you know that in course of this lecture, you can hear to that. What are the pitfalls that happen in the wards that causes hypoglycemia as well? And that is one thing. And then the other thing is that patient is also, generally patient would like to avoid insulin. And then the one episode of hypoglycemia will make patient also very resistant to take further insulin. So it should, and it's a very bad experience, frankly speaking. Critically ill patients, it's a different experience. And in non-critical ill patients, it's a bad experience. Now, if you look into that, whenever you're trying to reach the goals, sometimes you have to have a different goals as well. Looking into the condition of the patient. Say, for example, a vulnerable patient, the blood glucose goal should be different or slightly less stringent compared to what we are thinking about. Say, like for somebody has got acute myocardial infarction, somebody has got severe infection, hematological malignancy, very important, hematological malignancy. And then those who are elderly, who is vulnerable, cognitive function is bad. And then we can see that hypoglycemia unawareness is another thing. There's a lot, long-standing diabetes, autonomic neuropathy. You can get hypoglycemia unawareness as well. And if you look into that infections, hematological malignancies, very important to note that a lot of youngsters I could see here is that when you are trying to do a glucometer, remember that you should have, if you want to trust the glucometer reading, you need to have at least hemoglobin of 10 and PC of 30. If it is less than that, it will give a false high value. If the hematocrit is very high, like what you see in polycythemia vera or in infants, where PCV is more than 50%, it will show false low values. These are the two things we need to remember when you're trying to monitor diabetes in the wards as well. So we need to give that leverage. Suppose somebody has got a hemoglobin of 6 or 7 or 8, and then less than 10 and less than 30 of PCV. Suppose somebody has got 200, it is only about 160 or 170, it's not 200 exactly. So we need to remember these things. And then whenever trying to monitor it, you should write in the case sheet that hemoglobin how much and PCV is how much. And also remember the renal functions and liver functions also to be noted in the case sheet. So that should be keeps on reminding, because that also tells us what are the oral drugs that we need to avoid, what are the oral drugs that we can introduce, or what is the amount of insulin that we need to give. So all these things will be very, very important to note down in a case sheet, to have the renal functions, the liver functions, and hemoglobin and PCV. The three things if you have, you'll have a great idea about managing diabetes amongst people. Now, if you look into that insulin requirement in general, in a healthy, in a normal active person, you can see that you have basal insulin. You can see that there is a basal insulin all through, and then you got with prandial insulin secretion that happens. And mind you, this will not be reproduced, or there's no need for this to be reproducible in the hospital setting because of various aspects such as stress factors that you have. Now, whenever they're trying to, say, for example, somebody is admitted for surgery or somebody has got admitted for vomiting or something like that, they may be having a fasting. Now look at the type 1 diabetic and a type 2 diabetic. Over the time, if you can see that in a type 2 diabetic where they are not insulin deficient, they are maybe insulin insufficient, or they may be having enough insulin as well. And these people, when they're prolonged fasting, if you can see that the requirement of insulin is going to come down over the time in a few days. Continuous fasting is there. So like in post-operative patient who are putting them on steroid, anything surgery done on the gut, they'll at least 3-4 days, they'll not have any food on them. So whereas if it's a type 1 diabetic patient, whether they eat or not, we need to give insulin. That is no doubt about that. Otherwise, because they're insulin, absolutely no insulin in them. And that's the reason you need to continue to give insulin, even in a smaller doses, so that you don't develop these unfortunate type 1 diabetes will not develop diabetic ketoacidosis. And now, just okay, that is between type 1 and type 2 diabetic. Look at the type 2 diabetic itself. Again, within the type 2 diabetic patients, it differs a lot. You can say each type of patient is different. Some people may still require, in spite of long fasting, they may require a small dose of insulin. Some of them may not require insulin at all. For this, how do you recognize these things is a very, very important thing. One is duration of diabetes. Longer the duration of diabetes, the endogenous insulin is going to be very low. So they may require insulin. Okay, and then what is a prescription that I've been taking at the time of admission? Somebody who has got insulin requiring diabetes, about 3 or 4 oral drugs, and they're taking twice a day insulin. And these people will require insulin even in long starvation sometimes actually. Whereas newly detected diabetic, not much of drugs, just probably only on metformin, they may not require insulin. So it's very, very essential to note what is the situation of the patient, and then we can, to great extent, we can decide whether they will require insulin or not, how much of insulin they require to certain extent. So history taking and noting down these situations are a very, very, very important things that we need to look into to decide or to have some idea to start the treatment about insulin and other things actually. Very, very important. Now, whether we have to use tablets or not, there are some oral drugs that we can give without hesitation. There are some oral drugs which are better avoided, and there are some drugs which have got no use. So for example, you can see that metformin, unless there is a contraindication, says somebody has got renal failure. Sometimes you see in the wards acute renal failure, right? Which is recoverable, which can be recovered back to. It's a chronic renal failure, it's a different. Acute and chronic is different. Acute renal failure, they may get it. So you have to avoid, and then somebody is going for IV contrast, better avoid metformin. And when somebody is going for a major surgery, where it's going to have long-standing surgery for about 5 to 6 hours of surgery, it is still better to avoid metformin. TZDs, absolutely no role in patient diabetes. Sulfonylureas can be given, especially the newer sulfonylureas can be given, provided they are on stable, normal diet. Stable diet pattern is there, then we can use it. Like glycoside or glimepiride can be used actually. And then if you look at the alpha glucose inhibitors, no role. And then exenatide, the GLP-1 analogs, in the hospital admission, it's no role. DPP-4 inhibitors have got a role, definitely, because let me tell you that whenever there is a stress factor, when there is hyperglycemia, the glucagon levels are also elevated, right? Glucagon levels are elevated. So address the glucagon levels, we can think about DPP-4 inhibitors. Is there a role for SGLT inhibitors? Unless it's a stable, not a problem, just admitted for some other reason, but stable, otherwise healthy, you can continue. But don't start SGLT inhibitors in the hospital. Or if the patient is acutely ill, temporarily stop the SGLT inhibitor, and then you can restart after when the patient recovers. And this is how you need to look into the oral drugs. DPP-4 inhibitors have a role even in steroid-induced hyperglycemia as well. They've got a very good role actually. Now, whenever you think about, in general, in the hospital, what we need to think about in the hospital is that always prefer to go insulin. If at all needed, you can add oral drugs. But insulin is the first choice whenever somebody is admitted. How is it the best way of giving insulin is a basal bolus therapy, and there is no second thing. Only then other things like 3 bolus insulin can be given. But if you want to reduce the hyperglycemia to the great extent and without any intraday variation of blood glucose or interday variation of blood glucoses, And then if you want to have a good glycemic control for control of infection, the best one is the basal bolus therapy. Now, we always think that, oh, okay, basal bolus therapy, we need to buy one basal insulin, and we got regular insulin, we buy a vial, but basals is expensive. But imagine if we can reduce the number of days of admission, and if we can reduce the cost of the antibiotics, you're going to reduce the cost, definitely. Just investing into some one basal insulin therapy is going to reduce the cost for the patients in the long run. So please do not hesitate. That's what I would like to say that. Now, usually in the hospital, in outside the hospital, what we usually do is that the starting of insulin dose is of 0.2 units per kg body weight. But when the patient is admitted in the hospital, usually what we do is that we give 0.4 units per kg weight, because they will require more insulin, supposed to require more insulin than what they are in outpatient department. So generally what we can do is that we can, the general rule is to say that 0.4 units per kg body weight. So suppose somebody is about 60 kilos in weight, about 24 units you need to give. In that, we need to give 50%, 12 units as basal insulin, and the other 12 units you can give it as divided doses as bolus insulin. In fact, it's not as simple as that what we say, but at least it's a starting point to do that. We can start about that. And it's also very easy to adjust the basal insulin based upon the fasting blood glucose. So the fasting blood glucose is more than 140, you can always increase by about 3 or 4 units. And if it's coming down less than 80 or 70, we can reduce another 3 to 4 units. Very simple way of looking into that. And bolus insulin, whenever you're trying to do that, you check the sugar before food and proactively give the insulin. I'll tell you very well, proactively. Don't believe in the sliding scales. Never do that. How do you look at the proactive way of looking into insulin dose is very simple. And what is the insulin that is given the previous time? What is the response? What is the blood glucose that has come down? What has been given the previous day? What is the blood glucose levels which are coming down? All these things you need to remember. Once you remember all these things, it is very easy for you to decide about insulin, how to give in a proactive fashion. Don't allow the blood sugar to go up and react to a high blood glucose and bringing down the sugar. Proactively act in advance and don't allow it to go up. That's very important. At the same time, remember, no hypoglycemia. You need to balance between the two. Now, this is a very pictorial presentation. 50% you give it as basal insulin such as glargine or degludec, and the other 50% you can give it to divide into 3 bolus insulins. Now, what are the alert parameters? I'll finish. What are the alert parameters? Is that alert parameters are if there is less than 180, it alerts us. If it is more than 300, again it alerts us. Especially less than 80, you need immediately. Suppose somebody has got 250 or 300 blood glucose, you give about 20 units of insulin. It just drops down to 80. It alerts you that this person is responding very nicely to the dose that you have given. So next time when you think about that, you need to think about we can't give so much of insulin, rather we cannot give so much, because every person differs in response to insulin, not only response to insulin. Any drug, diabetic drug, any hypertensive drug, you can see that definitely it is individualized. So you need to always keep on assessing the patient, how they're responding. Suppose somebody has got a renal failure or hepatic failure, malnutrition is there. Here what we need to do is that we need to reduce the basal insulin to 30%, and rest of it you can give it as a bolus insulin accordingly. Is the sliding scale an option? No. As I said that, you can see that the blood glucose comes down very nicely when you act proactively, not depending on the sliding scale. Suppose you depend on the sliding scale in a reactive way, then you can see that blood glucose control is not going to be very simple about that. Okay. And then very often in hospital, we see that people are on tube feeding, right? Tube feeding on enteral nutrition and as well as parenteral nutrition. Believe it that somebody is on Riles tube feeding or a JJ feeds, basal bolus therapy is the best that we can give. And then when somebody is on, total parenteral nutrition, you don't need to worry. You can add insulin to the nutrition itself. And most often what happens is that whenever somebody is putting on total parenteral nutrition, they are usually starved actually, because only then they'll give that. Or the food intake is very low, then they'll use the total parenteral nutrition. Don't hesitate to add insulin liberally. Start with 15 to 20 units. You can go up to 40 units to be added to the TBN, depending on how the blood sugars are responding. And steroids is another thing. In off late in the last 3 years, we are seeing most of the patients when they're admitted with the corona or anything. Otherwise, even otherwise, steroids are given. And then there's various mechanisms. We can see that the glucose goes up. And then we need to know what is the steroids which we can, whether they are short-acting steroids or intermittent steroids or long-acting steroids. And also you need to divide these two steroids into mineralocorticoid effect and glucocorticoid effects. Lower the glucocorticoid effect and more mineralocorticoid effect, the hyperglycemic potential is lower. Higher the glucocorticoid effect, the hyperglycemic potential is going to be higher. And then, and another thing what you need to say that, see the profile when you give steroids. You give a morning insulin steroid, you see probably a fairly good blood glucose in the afternoon before lunch. Don't hesitate to give insulin. It will go up in the evening, it will go up. So be proactive again. When somebody is on steroids, even if it is 110 or 100, when somebody is on steroid, don't hesitate to give an insulin dose at lunchtime itself. And so that you don't increase the pre-dinner blood glucose, and similar to the midnight blood glucose also is going to be high. Nocturnal hyperglycemia will be there. So be careful. So that don't hesitate. This is the way the blood glucose will go up and whatever steroid that you give. Again, as far as the oral drugs is concerned, no contraindication. Metformin is a good drug that we given. DPP-4 inhibitors got a great role in managing steroid-induced hyperglycemia in the hospital. And this is a very, very important slide. I feel this is that whenever the clinical situations that increase the risk of hypoglycemia and hyperglycemia, that changes in calorie and carb eating. No, especially somebody is admitted, there'll be NBM, nil by mouth. And then suddenly they will go into liquid diet, then go to semi-solid diet, then go to normal diet. They change in the calorie intake, they change the dietary pattern itself, keep changing. So accordingly, you need to think about insulin and other things also. Suppose you don't realize these things, unnecessarily people will be going to hypoglycemia. And then change of clinical status. Most often what they do is that they start the steroids. For example, steroids are given and they try to taper. And we need to keep a watch on that. Otherwise, you'll go into hypoglycemia. And poor coordination, very, very important. Poor coordination of blood glucose testing and administration of insulin with the meals. There's a delay in informing. The nurse delaying informing you will miss a dose of it. You can't give insulin after food. You have to give insulin before food. And apart from that, poor communication. Very, very important. The communication, even the guidelines say that, guidelines say that when this insulin in the instruction only that can be given on the phone to the nurse, nothing else, not even antibiotics, you keep it in writing. So only insulin. But only thing is they also say that somebody gives an insulin, you should ask the nurse to repeat what you have said, ensuring that what you have communicated is correctly gone there. Isn't it? Very important. So that you have to do that. And errors is in writing and transcription is a very, very important thing. So this is about the management of diabetes during the wards. I think I'm up the time. Chandru, I can up the time. I'll stop. Okay. Thank you. Now, whenever there's a surgery, you can see that anesthesia itself is a stress factor, and anybody admitted for admission for surgery itself is a stress factor. And the third thing is there's always a possibility of infection also there. Now, the preoperative assessment of surgery is very, very important. And so that whether they're type 1 diabetic or type 2 diabetic, what is it you can expect when they get admitted? The comorbid conditions has to be taken into consideration. What are the antihypertensives and anti-diabetic drugs that we're taking are very, very important to note that so that you can plan the surgery. And then the most important thing is that request to the anesthetist is that always try to have surgery in the morning. Okay, that is one thing. Anesthetic drugs will increase the sugar, but later the latest anesthetic drugs are fairly good and they don't give. And then if the blood glucoses are normal, because the patient is going to starve, we can see that 5% dextrose or DNS can be given without any hesitation. And monitoring of the glucose is the most important that we can do. It depends on the surgery. If it's a minor surgery, you don't need to do anything much because it's not going to starve. You can continue the usual medicines. If there's no starvation, you can go for surgery. And probably if it is a minor surgery, that's a daycare procedure. There's a minor surgery. And minor surgery, you can see that better admit 1 day in advance. Try to avoid oral drugs in the morning and insulin in the morning. And immediate post-operative, depending on the food intake, we need to restart everything. Major surgery is entirely different, actually. 2 to 3 days in advance, avoid certain molecules, oral drugs, and put them and stabilize them on insulin, both basal bolus. And then you can also give insulin added to the IV fluids post-operatively. Now, the management of nutrition is very, very important to prevent hypoglycemia and also give basal energy requirement. Suppose you don't give basal requirement, that's about 600 calories per day. That is about 5 pints of IV fluids, which contain 5% dextrose. It's about 600 calories. Otherwise, they'll go into ketosis because no energy, they'll go into ketosis. So as far as the ICU patient is concerned, we know that hyperglycemia mortality is very high. Similarly, hypoglycemia also can be very, very high. This is indicated by what is called as nice sugar study, which always clearly said that 90-day mortality of the people after the ICU admission is very high when there is a too tight control of diabetes, where they found 6.8% of these people had blood glucose less than 40, compared to only 0.5 in the conventional group. What do you mean by intensive conventional group? Is that nothing but conventional group is keeping the blood glucose between 140 to 180 and not causing any hypoglycemia. Any amount of severe hypoglycemia during ICU stay can be very detrimental for mortality after getting discharged from the ICU. Now, the best way of giving it is an insulin pump. The reason why we should give insulin via IV is that because the half-life of insulin that you give regular insulin is only 5 minutes. And that is the reason very easy to adjust the insulin dose. And let me remind all of you, my friends, that we're going to have our RSSDA 50th. This is a golden jubilee year for RSSDA, and we're making all arrangements there for you to come. Please join us and visit our website as well, so that you can get all the details about that. Thank you for your patient hearing.
Thank you, sir. It's very informative. It's always special listening to you, sir. I've been doing this for 15 years. Because of time constraint, I need rest. As you rightly said, normally it is yes. Normally. Strike early. Government hospital. Normally we don't increase the dose very soon because of the risk of hypoglycemia. We always have the trouble bringing down the sugar in normal wards itself. And the second question is they store most of the time the room temperatures are in government hospital.
No, actually,
how long they can be stored?
Sir, actually, the bioavailability will not change much when you keep it within the room. So, only thing when it's exposed to the heat in the sun or to the heat like near the
normally
fire or something.
In April, May, we find it very difficult.
No, we don't need to worry, sir. Okay. You can just keep it next to the patient itself. Okay. And then one of the things what we tell them to do is that keep it in between the clothes also. It is insulated well, actually. So that is more than sufficient. Only thing is additional bottle or additional the cartridge that has to be kept in the fridge between 4 to 8 degrees of centigrade. But whatever we are using, we can keep it at the room temperature, nothing like that. And generally what they say is that we need to finish off insulin within 28 days of opening it. That's what they say. That's one. I don't think we will not use it for more than 28 days.
Thank you, sir. Thanks.
Yeah, as rightly you said at the beginning, it's a huge topic and getting it updated to is extremely difficult. But the information I gathered from you has been phenomenal. The first thing I learned was the blood sugar in the inpatient should be maintained at 180. That's one. Second, it is preferable to you depend on insulin than on other drugs to maintain the sugar. And then third thing I learned was the sliding scale. I think it is totally abandoned now. I think none of the hospitals are using. I have not been using it in our hospital at SMF for the last 10 years. The insulin used is, though you highlighted on glargine and degludec, I think the best message you gave us the basal bolus. That's the basal is simple, insulatard is sufficient, economical and easy. Because after some time, what happens is when we switch over to oral drugs, this becomes redundant and still economy has to play a part. And the last thing, what you said was much more important. In critical areas, there's only one answer, IV insulin. Okay, that is the only thing that has stood test of time in critical care. Thank you, sir. Excellent messages from your talk.
Thank you, sir. And for the economical purpose, we can still use NPH insulin as a base insulin. That also can be
Talked
done.
about as an economy.
That we can still use it. Something is better than nothing. So
We use NPH because of
we
the
can use it.
sheer
We can use it.
economy. There's nothing else.
We can use it. No, given the chance, if the patient can afford, probably that insulin, but NPH is still a good one to use. Thank you.
The next talk by Dr. Ravindranath on sexual dysfunction is virtually.
The sexual response cycle, either in the excitement stage or in the plateau stage or in the orgasm or in the resolution stage, that prevents the individual or couple from experiencing the satisfaction from the sexual activity. According to the concepts, Oxford Dictionary defines impotence as powerless, helpless, decrepit, wholly lacking in sexual powers. And the newer terminology, erectile dysfunction, has been formed just to have the man's self-esteem and the quality of life. Coming to the types of sexual dysfunction based on the problems, there are almost 4 base problems. One is the desire disorder, where the patient lack of sexual desire is there and lack of libido. We call it as a lack of libido. The person will not have the feeling of having the sex at all. And second one is the arousal disorder. Here, the patient may have the desire to have the sex, but the inability to become physically aroused during the sexual activity is there. That is arousal disorder. And third thing is the orgasm disorder, where patient will have the desire and patient will be even easily aroused also, but there is a delay or absence of orgasm, the climax. We call it a climax, the ejaculation. And fourth one is the pain disorder, pain during the intercourse. And this condition most commonly occurs in women than in men. So the common problems, if you see, one is the reduced libido, that is inhibited sexual desire. And second thing is the erectile dysfunction. And third one is the ejaculatory failure, where you have retarded and absent ejaculation, premature ejaculation, on retrograde ejaculation. And among all these things, anyone can get any type of combination of the above factors. So coming to the libido, what is libido? Libido, reduced libido can result from the organic or psychological causes. It often has a low level of testosterone and high level of serum prolactin. It may be due to any primary or the secondary changes. And libido problems may be related to hypogonadism, hyperprolactinemia, and depression, fear of sexual failure, certain medications also, and of course, any systemic illnesses. The fear of sexual failure is one of the main factors that we commonly encounter in our practice. The patient may have some sort of tension and worries in the family or the working places, and when he comes home and want to have a sex with a wife, he fails to have the proper erection because of the pre-existing tension in the mind, and not able to have the penetrative sex, and he fails in performing the sexual activity. And after that, what happens? And subsequent days, subsequent occasions, when he involves in the sex, the same fear will come to him, and the penile erection will not occur because of the psychological figure. So this is one of the main fear of sexual failure that is commonly occur in our day-to-day practice. Second thing is the erectile dysfunction. What is ED? This is defined as the inability of the male to attain and maintain the erection of penis sufficient to permit a satisfactory sexual intercourse or the penetration. And if you can see, the normal ED usually develops over the period of months and years in diabetics. It is not related to the duration of diabetes and may also present at any time of the diagnosis. Even at the time of diagnosis also, they may have this erectile dysfunction. The physiology of the normal erection, male erection, it requires intact penile neurological and vascular system. These are the two main components. The paired cavernous nerves originate from the parasympathetic chain at the S2 and S4 levels, and in conjunction with the somatic potential nerves, inside the neurovascular mechanism, responsible for an erection. So the normal erection, if you see, this is a cycle neural mechanism that produces the penile erection. There are various stimulations that trigger the higher centers of the brain. Nervous impulses flow down to the spinal cord to the thoracolumbar ganglia. The penile erections are the result of not only the neuronal mechanism, but also the enhanced blood flow caused by arterial vasodilatation and cavernosal relaxation attributable to the nerve stimulation. So basically a nervous system that is being involved here. Here if you see the parasympathetic nerve fiber that originates, that carries the thoracolumbar outflow was there, and there the stimulation occurs, the penile sectional stimulation occurs, and of course the non-adrenergic and the non-cholinergic stimulation also has got a stimulation of these endothelial cells. So endothelial derived factors secretes nitric oxide because of that non-adrenergic or non-cholinergic neuron stimulation. That causes the release of nitric oxide. Even from the vascular endothelium also, the nitric oxide synthesis is produced, and that produces nitric oxide, which is responsible for the blood flow and the penile erection. And this nitric oxide, along with the guanylyl cyclate, it forms a cyclic GMP, which is responsible for the smooth muscle relaxation and the increased blood flow into the penile musculature, which causes the tumescence. Tumescence is male erection. So what happens to cyclic GMP? After the erection of penis, the cyclic GMP, this is active formation. This active cyclic GMP is converted to inactive form of GMP by means of the PDE5. That is a enzyme that is present there. That will make this CGMP to inactive GMP level, where only we are interfering to block this PDE5 by means of our sildenafil or the tadalafil tablets, inhibitors. So next, this is the nitric oxide cascade underlying the penile erection. In the normal flaccid state, the PDE5 that declares the CGMP levels. In the erect stage, the arginine, O2 and NADPH along with the nitric oxide synthase, formation of citrulline and nitric oxide was there. And this along with the guanylyl cyclase forms the cyclic GMP responsible for the penile vascular smooth muscle relaxation and the increased blood flow. So now this is the physiology of normal erection in the male. Diagrammatically, I just represented here. Here you can see that a cross section of the penile musculature, where you get outer layer is tunica albuginea and the middle layer is subtunical venule space, and inner side we have got a cavernous space. And this penile musculature is supplied by the helicine artery, which is a branch of cavernosal artery. So the blood flow into the penile musculature goes to the cavernous space and gets elongated, and the smooth muscle elongates, and it compresses the subtunical venule space and the against the tunical albuginea, wherein the nerve of a venous outflow from the cavernous space is being blocked, and thereby blood flow into the cavernous space is there, but blood outflow is restricted because of that constriction. You can see from this diagram. So the tactile stimulation of the penile shaft activates the parasympathetic fibers, which travel in the parental lobe and function through the spinal reflex arc from S2 to S4, as I told you before. The dilated corpora compresses the venous outflow channels against the elastic tissue on the tunica albuginea, an action that prevents venous leakage and further increases the intracavernosal pressure to above the systolic pressure. So just before the ejaculation, the ischiocavernosal and the pubocavernosal muscles contract to increase the intracavernosal pressure further, and the response is the ejaculation. Now we can see from the diagram the blood flow into the cavernous space. And after that, what happens? The cavernous space goes on increasing the size, compressing the subtunical venule space, and thereby compressing the even veins also. So penis get enlarged, the cavernous space get enlarged, the venous outflow gets blocked, so that blood stagnates in the penile musculature, and the male get the proper erection. We call it as a tumescence. So this is the physiological mechanism by which the penis enlarges after the stimulation. So the erectile dysfunction, if you see, now the basic thing that we found is that penile artery insufficiency, autonomic neuropathy, reduced neuronal lactic oxide formation, elevated levels of AGE, which act as oxidative free radicals and neutralizes the nitric oxide. An impaired cavernous or smooth muscle relaxation in response to neuronal and endothelial nitric oxide. The ultrastructural changes in the cavernous tissue, all these things are the basic pathogenesis that occur in the erectile dysfunction. Of course, you know, organic cause consists of neurological, vascular, and hormonal components. Apart from that, we got even psychogenic component, and the medications also contribute to the erectile dysfunction, of which we know. I have told you about these neurological factors and even the vascular factors. Main thing, what we want to know is, although the neuronal signals are crucial, the vigor of a man's erection is ultimately determined by vascular events governing the flow of blood into the corpora cavernosa. So, certainly the main substances that are responsible for this event is the intracavernosal chemistry sequence involving the enzyme nitric oxide synthase and nitric oxide, and the second enzyme adenylyl cyclase, which helps generate cyclic guanosine monophosphate needed to maximize the intracavernosal blood flow. This is the basic mechanism that we see in the vascular compartment. Apart from the neurological component and the vascular compartment, hormonal is one of the main factors. Testosterone is a main hormone, mediates a man's libido. As testosterone levels decline, sexual desire decreases. So this hormone is a critical role in stabilizing the levels of intracavernosal nitric oxide synthase, the enzyme responsible for triggering the nitric oxide cascade required to have an erection. I have renovated how the nitric oxide cascade formation was there. And for this nitric oxide synthase is much needed, which is dependent upon the testosterone level. Anything that interferes with the hypothalamic pulsatile luteinizing hormone release or reduces the number of Leydig cells available to respond to Leydig cells will result in the decreased production of testosterone. So this is the basic component how the testosterone level alters in the sexual dysfunction. Of course, the psychological disorders are also there: stress, anxiety, psychological trauma, misconception, depression, psychosis, and poor self-esteem due to obesity, protruding abdomen, hostility, disgust, and humiliation. All these factors are there wherein the patient will have some sort of psychogenic component that produces the sexual dysfunction. Many medications contribute to erectile dysfunction, of which the antihypertensive, antidepressant, tricyclic antidepressant, major tranquilizers, excessive alcohol, brewer's drop, and tobacco smoking. Miscellaneous drugs include the cimetidine, statin, ketoconazole, NSAIDs, and fibrates, and of course metacloprobin. All these things are miscellaneous drugs that may have a minor contribution for the erectile dysfunction. And this is the algorithm where how you are to approach your erectile dysfunction patient, that consists of endocrinologist, physician, sex therapist, urologist, and then health educators. And fourth one is the ejaculatory failure. Ejaculation, what is? Ejaculation before or within 2 minutes after vaginal penetration would be a working definition for ejaculatory failure. So the retarded ejaculation or anejaculation also can be due to psychological, neurological, and medical causes. The adrenergic agents, especially the decongestants, that causes the premature ejaculation, as is the endogenous epinephrine is produced by enzyme. And of course, diabetic neuropathy after the TURP surgery and relationship difficulties may affect the ejaculatory function as well. Now, after knowing all the basic pathophysiology regarding this erectile dysfunction, what are the things that we can just concentrate on it? We need to concentrate on the art of history taking. This is one of the very integrative part that one should have the intelligence to have the art of history taking in a sexual dysfunction patient. Everyone with diabetes should be screened for erectile dysfunction. How you are going to screen the patient? As soon as he enters the room, what you have to do, you have to greet the patient. Privacy is needed, at ease, not judgmental approach. And vagueness must be clarified. What type of erectile dysfunction the patient has got, whether he has got a decreased libido or erectile dysfunction or ejaculatory failure, all these things should be clearly classified and vagueness should be clarified. And choice of terminology is more important. How long has the problem and are they related to the time or place or partner? And dislike of sexual contact or the sexual boredom. Sexual boredom is one of the main factors that we need to concentrate, because any person having a sex with the same person for a longer time will have a sexual boredom. So this occurs not only in men but also in women also. So dislike or sexual contact or sexual boredom is one of the main factors that you should elicit in the history taking. And of course, sudden onset and preservation of spontaneous early morning erections does not necessarily indicate a psychogenic cause. Now coming to the general examination, as that of other general examination, testing of reflexes, genitalia examination, any features of hypogonadism, manual dexterity, protuberant abdomen, external genitalia, testicular volume, and the peripheral vascular disease, all these things to be examined clinically. Of course, all the hormonal levels, basically testosterone, prolactin, LH, and sex hormone binding globulin, free androgens, ECG, and serum lipids, and of course, even the PSA value. All these things are basically mandatory before you start the treatment for erectile dysfunction. Of course, testing nocturnal penile thermosense, the stamp gauge band or the stamp test is necessary. Regiscan device is also there, and papaverine injection stimulation test is there. 3D imaging, penile Doppler, ultrasonogram, and penile brachial index. As with the ankle brachial index, you got even penile brachial index to assess the penile vasculature. Of course, these are all the very advanced investigation where you can do penile arteriography, cavernosography, electromyography, and cavernosometry. All these things are advanced technology. We can go for it. Treatment consists of general measures and specific measures. Specific measures have got a psychosocial sexual therapy, medical treatment, and surgical treatment. Now, the medical treatment available are oral agents, intracavernosal vasoactive injections, intraurethral suppositories news, and vacuum constriction devices, testosterone replacement therapy. Oral medications consist of the phosphodiesterase type 5 inhibitors. We know Preventive, sildenafil, vardenafil, and tadalafil. The one thing, the contraindication should be definitely you have to bear it in mind when you prescribe a PDE4 inhibitors. Significant cardiac events in previous 6 months' time should not be given this PDE5 inhibitors. Of course, not only that, PDR, retinitis pigmentosa, non-arthritic anti-ischemic optic neuropathy, and the patients taking nitrates. One of the major things, patients taking nitrates should not be given these PDE5 inhibitors. And of course, whether all the patients' response to sildenafil is a question. Whether it's not, I think it is almost not all the patients respond to sildenafil therapy. Why this happens? The critical amount of nitric oxide is necessary for the sildenafil to work. Okay, if the sildenafil to work, nitric oxide is needed, but for this, the L-arginine is required for nitric oxide synthesis. So L-arginine deficiency leading to depletion of nitric oxide is the underlying cause for the sildenafil failure. So what we need to, whether we can combine this drug, yes, we have to combine the sildenafil with L-arginine. That will be a better approach to help such patients. And other drugs like tadalafil and vardenafil are there. Tadalafil with a dose of 10 to 20 milligram can be given. And latest studies and many guidelines also support the need for 5 mg of tadalafil daily dose. Patients on chronic erectile dysfunction not able to cope up. Definitely this 5 mg of tadalafil given every day has got some beneficial effect in overcoming the erectile dysfunction. And the other pharmacological therapy, there are apomorphine, yohimmune therapy, trazodone hydrochloride. Of course, you got in alprastatil. Both the criteria, vasculogenic ED or neurogenic ACE, the dose is different. Papaverine and phentolamine combination injection, and the 3P solution, 12 mg of papaverine and 9 microgram of prostaglandin E1 substance and 1 milligram of phentolamine. This can be combined and given out. So these are the intracavernosal injection. We can this injection into the penile separation. Of course, alprastatil has got one side effect of priapism. When the patient develops a priapism, definitely we have to see whether the erection exists more than 60 minutes. When the erection exists more than 60 minutes, we call it as a priapism. And that time, injection of 30 milligram of pseudoephedrine can be given to overcome this priapism. So in the intra-urethral suppository, there's used medicated urethral system for erection. Of course, the vascular constriction device, as I told, shown in the figure, and vacuum pumps are available, wherein you can fix it into the penis and produce vacuum so that the penile musculature gets enlarged because of the inflow of the blood, possibly mechanically. The surgical treatment of ED, there are venous and arterial surgery, penile processes, semi-rigid rod, mechanical rod, malleable devices, and inflatable devices are there. Of course, the other sexual disorders like premature ejaculation is there. This is an inability to control ejaculation sufficiently to permit both partners to enjoy sexual intercourse. The drug of choice is sertraline 50 mg given daily. The retarded or absent ejaculation, the cyperhybrid is the drug of choice for this. retarded or absent ejaculation. The patient will not get the ejaculation at all outside, and they will even retrogradely they will ejaculate. So coming to the female sexual problems, apart from the male sexual problem, even females also they get these kind of sexual problems. One thing that we want to note it here, the 4 stages: excitement, plateau, orgasm, and resolution. If you see the female population, they got sexual dysfunction patient, they got multiple orgasms, arousal to plateau levels without achieving orgasm. Normal patient, they got all these mechanisms. They got multiple orgasms. Whereas male patient, they got only 1 orgasm, but here in female population, they get multiple orgasms. Arousal to plateau level without achieving the orgasm, and brief drop in excitement phase followed by rapid resolution. This is the basic physiology that we see in the female population. So female sexual problems are many. Of which the 4 problems are main important thing that we have to know. Female sexual arousal disorder. Here, inhibition of the sexual response, defined as a persistent or recurrent inability to attain or to maintain until completion of the sexual activity, and adequate lubrication and swelling response of the sexual excitement. And second thing is the female orgasmic disorder, FOD, impairment of the orgasmic component of the female sexual response. A persistent or recurrent delay in or absence of orgasm following a normal sexual excitement phase, as that of the men. Here also they got an orgasmic disorder. Third thing is that dyspareunia on vaginismus, a recurrent or persistent genital pain on dryness with sexual intercourse. For this treatment is cognitive behavior therapy, control of blood sugar, local application like vaginal lubricants and estrogen creams are mandatory. The mechanisms, if you see, the vaginal lubrication is the female equivalent of tumescence. Vaginal dryness or impaired arousal may be related to failure of nitric oxide mediated smooth muscle relaxation, secondary to endothelial dysfunction and non-autonomic neuropathy. Here also, the nitric oxide mediated mechanism is needed for the female sexual act, but they do not respond to PDE5 inhibitors. Investigations of the female sexual function, endocrine investigations, FSH, LH, estradiol, prolactin, diroxin, all should be assessed. Of course, the other investigation like labial thermometry and vaginal plethysmography are the other investigations. The drug of therapy, no definite clinical trial regarding the use of PDE5 inhibitors on female sexual dysfunction. We do not know the basic pathology. Also have got some nitric oxide deficiency that leads to this female dysfunction. Anyway, the PDE5 is not acting in female population. Many studies have proved. But what else? Other thing we can do is that estrogen and replacement therapy may be worthwhile in women almost more than 50 years of age. We can do this estrogen therapy. So discussion, progress in medical care has led to a shift in diabetes care and brought the issue of quality of life to the forefront. Sexuality, however, is an aspect of quality of life that has only recently gained more attention in our clinical practice. Remember, erectile dysfunction is because of endothelial dysfunction. You can say even end organ damage. So ED, a marker of CVD, both share the common pathogenic feature, endothelial dysfunction. And ED may be the first presenting symptom of an unidentified cardiovascular disease. This was proved by this Gazzaruro study at al. You can see they included almost 260 men with more than 50 years of age, no cardiac symptoms. They underwent angiography. Almost among this patient, 133 had IST and 33.8% of the patient had an ED. So this is how this is a hidden symptom that is present before the cardiovascular event. So the take-home message, despite the fact that men with diabetes now have a host of options for addressing ED, preventive education concerning the risk factors that lead to this disorder should be incorporated into diabetes management programs and try to detect erectile dysfunction as early as possible with all means. When the patient comes for the first time you are going to detect diabetes, elicit the history of erectile dysfunction, because the duration of diabetes doesn't matter much with ED. Even at the time of diagnosis, ED may be present. The concluding remarks, sexual act is an art. So train the patient who are ignorant of it. Of course, virtually. Sexual dysfunction is a part of one of the complications of diabetes and a marker of CVD. If you make yourself thorough in diagnosing and treating sexual dysfunction in time, we can avoid we can definitely avoid many diverses. Yes, we can avoid many diverses. Delay in justice is an injustice. Thank you.
That was an excellent thing. The message is very clear. ED is one of the, what I will say, the most difficult, we can say mostly complication of diabetes is erectile dysfunction. Because people are not coming out with, unless it is questioned. The management is, if PDE5 fails, then we are in a difficult situation because the other modalities like penile pump, penile implantation, penile injections have not been as successful as we think. The basic thing is we have to control diabetes at the best. There's no excuse for this. I personally feel if a patient develops an erectile dysfunction, we have failed in the control of diabetes. That is the answer.
Thank you, sir. It's well said, sir. Thank you, chairpersons. Next, we move on to the final session of the Cardiometabolic Congress. May I invite Dr. UV Mohan and Dr. Seduram to chair this session.
Good evening, sir. Generally, the last session will be the most interesting, and this thing, even in one-day match also, the opponent will always be ready to pull down the last wicket. And exciting things happen. Similarly, we have 4 beautiful speakers, excellent speakers, Dr. K. Mohan, Dr. R. Gaurishankar, Dr. R. P. Rajesh, and Dr. N. Kannan. I request all the delegates to please stay in and ask or transfer your questions to the chairperson.
Good evening, friends. I would like to thank Cardiometabolic Congress organizing team for giving me this opportunity to chair this session along with Dr. UV Mohan. The first topic is about ketone bodies. You know, they are produced both physiologically and pathologically. And it gains more significance in patients with diabetes, particularly when they are with hyperglycemia. So with that note, I invite Dr. K. Mohan, physician diabetologist with over 20 years of experience, to take on from here. Over to you, Mohan.
Good evening, everybody. Let me start with thanking the wonderful team of Cardiometabolic Symposia for this opportunity given to us, and for the chairperson for the wonderful introduction. And thanks for all the delegates to be here. I'm going to talk about ketone bodies, its challenges and controversies, more about its challenges. Ketones are normally present in they are not normally present in great quantities, but ideologically or logically, ketosis has been hypothesized as an evolutionary mechanism, because mainly people did not know when, the body never knew when it was going to get the next carbohydrate load. So it is an evolutionary mechanism. Glucose oxidation is more efficient. That is why when you flight and fright came, the glucose takes over. But we need to remember that ketone bodies are very important. This is one of the reasons why the brain, which needs to be there for the flight and fright, has been left alone to utilize glucose, whereas the periphery takes care of the ketones. The heart mainly takes care of the ketones. In addition, ketones produce proteolysis that would be required to support gluconeogenesis. Ketogenesis is therefore a critical part of maintaining the metabolic homeostasis. Emerging evidence from numerous studies suggests that an administration of ketone supplements, it can be oral, it can be IV also. In oral, in the ester form, ketone esters or salt forms can be given. It generates a rapid and sustained nutritional ketosis and metabolic changes that evoke potential therapeutic effects. In contrast to the diabetic ketoacidosis, the therapeutic ketoacidosis, the diabetic ketoacidosis creates a very pathological high amount of ketones of more than 25 nanomoles of ketones, whereas the therapeutic ketosis generally the safe level seems to be between 1 to 7. The therapeutic ketosis generally develops only around 0.1 to 0.2 micromole of ketones. a small touch on the biochemistry. I know it's a very difficult thing, but and very simplified version is this. The adipose tissue releases the free fatty acids, which is taken up by the liver. With the help of HMG-CoA, it splits into acetyl-CoA and then into beta-hydroxybutyrate. Beta-hydroxybutyrate is the form in which it's active in the body. This is taken up into the mitochondria, hepatocytic mitochondria, as well as into the cardiac mitochondria. In between, it comes out. Either it can go for a lipid or a cholesterol synthesis for further usage, or can be exhaled as ketone, acetone. Acetone is the most labile form of ketone, but does not stay in the body. Inside the mitochondria, through the TCA cycle, ATP is formed. But when you talk about glucose, this thing, it forms 21 ATPs, whereas here, though it forms 26 ATPs, there is a loss of around 3 ATPs in the way it is generated. That's why it's not a very robust this thing. And ketones are not oxidizing and can be used for lipid or cholesterol synthesis or eliminated as acetone, as I already said. These are the three rate limiting steps. One, as it goes into the liver, the acetyl-CoA synthesis. Next is the HMG-CoA synthesis and the exogenous this thing. If you look at it that way, the hormone sensitive lipase or the peripheral adipocytes and the HMG-CoA synthesis are inhibited by the insulin and are stimulated by the glucagon during phases of starvation. The acetyl coenzyme carboxylase, which converts the acetyl coenzyme to malonyl coenzyme A and goes into TCA cycle, is stimulated by insulin and inhibited by the glucagon. These are the different places in which ketone bodies work. Mechanism of increasing ketosis as an alternative to the ketogenic diet includes the use of ingestible ketone body precursors, as I told us, either as ester salts or other salts. Applications of ketotic diet has come into the thing mainly for cancers, in NASH, in congestive cardiac failure, and in other neurodegenerative disorders. The controversies, these are the main limiting controversies that we have. Administration of exogenous ketone bodies can create a unique physiological effect because it's an hyperketotic state, and the circulating glucose and insulin concentrations are relatively normal, so the cell uptake becomes aberrant. Ketone bodies themselves have a shorter half-life, and ingestion or infusion of sodium beta hydroxybutyrate salt can also increase the sodium load, thereby the water, other things are aberrated when there's a normal renals. The Atkins-style diet, which is a ketotic diet, the problem is in the long term, it causes a lot of side effects, including constipation, hyperuricemia, hypocalcemia, hypomagnesemia, leads to nephrolithiasis, ketoacidosis, and can cause hyperglycemia also. Ketones and the heart. Although a number of important questions remain, see, once we had the SGLT2 and other thing, what we have seen is that its action on the heart failure has shown us many new discoveries in terms of utility of ketone. There are smaller animal studies which has also shown that, which I'll be alluding to here. Although a number of important questions still remain regarding the use of therapeutic ketosis and mechanism of action in heart failure, current evidence suggests that there's a potential benefit in heart failure. The heart demonstrates metabolic flexibility. Usually the heart is able to utilize ketones 3 times its own body weight. So that's how powerful ketosis is. And it's metabolically flexible. Whenever glucose is available, it can take the thing, but thrives on ketosis because it needs to beat 72 times. So ketone, the glucose, this thing is very fast in utility, and the local glucose can get exhausted. Whereas ketone takes a longer time to be utilized, but is available on a longer term basis. That is why the heart looks at ketone bodies for its the thing. The ketone bodies, lactate and branch chain amino acids are necessary for the thing, and mitochondrial beta oxidation supplies a major ATP substrate for the heart. The SGLT2s, as I already alluded to, have again thrown in a new set of questions because the heart failure reduction through SGLT2 has been alluded to because of the increase in the amount of ketone bodies. See, SGLT2, as we all know, that it takes back the reabsorption has been inhibited, and thereby, because there is a less amount of glucose, the free fatty acid gets the thing, and thereby ketones are produced. As long as the liver is normal, the ketone bodies do this thing. Other smaller animal studies have clearly shown that when you give IV this thing, in spite of fully established inotropic therapy, the heart is temporarily able to have better contractility. So there are questions asked if there should be IV ketone treatment for congestive cardiac failure for betterment of the heart. This novel therapeutic concept might be a promising adjunct. These studies were done in 20 different animal models, etc. Alterations in the glucose metabolism have also shown that several studies have reported increase in peripheral ketone levels in heart failure, which correlates with the rise in natriuretic peptide. As an efficient metabolic substrate, glucose is theoretically well positioned to support the high ATP requirements of the failing heart. However, progressive deficits in glucose oxidation lead to a greater flux through the polyol pathway, a much less efficient process of generation of ATP. As I already told you, though it is much less efficient, it sustains for a longer time, and for the amount of work the heart does, it needs a longer fuel. In hypertrophied heart, reduced contribution of the fatty acid oxidation to ATP generation at low workloads is matched by increase in glycolysis. The metabolic deficits in both fatty acid oxidation and glucose metabolism in heart failure compared to produce an energy-starved heart that is primed to use the ATP-generating fuels. As long as the 17th century, they had shown that when people were starved, the amount of seizure came down. This has been well studied in children. The same fact holds true for adults, but the number of experiments are lesser. In fact, when you put them on a ketogenic diet or a starvation diet, these people had up to 50% reduction in seizures. And it could be done for even 3 months. But the problem is you can't endlessly starve people, and so this is not fixable on a long-term basis. But this gave the idea of food for thought. Underlying anticonvulsant mechanism remained unclear. Although postulated hypotheses include reduced glucose utilization, glycolysis, reprogrammed glutamate transport, indirect impact of ATPs into potassium channel, and alteration of sodium channel isoform expression. All these are again, purely theoretical. In general, at the outset, what all it can do to the neurons is this enhancement of the brain energy metabolism. It is able to cause a better repolarization. They decreases the hyper excitability of the neurons. Modulation of the neurotransmitter release occurs. Modulation of neurotransmitter balance also occurs. Decrease in the inflammatory process, and thereby neuronal protection occurs. The ketogenic diet, ketone esters and beta-hydroxybutyrate administration exert a neuroprotection in Parkinson's disease, ischemic strokes, and Alzheimer's. But major impact is on lactic acidosis and stroke, like the Mila syndrome and mitochondrial encephalomyelopathy. These are two areas where we do not have many treatments for which ketone has been shown to be very, very useful. Neuroprotection is not only due to the oxidative stress reduction or inflammation reduction, but also due to the autophagy accumulation reduction, which causes less amount of neuronal death. Obesity and exercise performance. In the rodent model, it has been clearly shown that when you have IV ketone given, the rat is able to have an increased treadmill time. That is how this has been extrapolated. In rodents, this keto ester diet decreases the calorie intake and plasma cholesterol, stimulates brown adipose tissue. The white adipose tissue is bad, brown is good. So this change has been shown. Recent findings indicate that during exercise in trained athletes, the keto diet, in spite of availability of glucose, where the preserved muscle glycogen content is still there, even when co-ingestion of carbohydrate was given, it is able to increase intramuscular triglycerol oxidation and lactate concentration, which makes the athlete do better. There are also converse saying that the ketogenic diet can cause DNA damage because it impairs the repair. Other conflicting reports also suggest that exposure to high ketone body concentration elicits an oxidative stress. Okay, what is the differences? Those studies which used an acetoacetic acid as the thing, there has been more amount of side effects. Wherever the correlation to beta-hydroxybutyric acid is better, and it decreases the oxidative stress and pro-inflammatory pathways. Taken together, now we have come to a point where we say that the beta-hydroxybutyrate attenuation reduces the oxidative stress. It decreases the ROS pathway and superoxide production, prevents lipid peroxidation, protein oxidation, and increases antioxidant protein levels. NAFLD is one of the thing, the keto diets which have the thing, and weight reduction are two major therapeutic areas for NAFLD treatment. The hepatocytes, the ketogenic flux may be a cytoprotective the thing. While cellular mechanism may not depend on ketogenesis per se, low carbohydrates are clearly shown to be useful in NAFLD. While excess storage of triglycerols in hepatocytes, that is more than 5% of the liver weight, when it does the thing, it decreases the degeneration of the liver function and decreases progression of NAFLD in human with the whenever there is decrease in the whenever there is more than 5% increase in the liver production of the thing, it decreases the NAFLD and insulin resistance. The pathogenic mechanism of NAFLD and NASH are incompletely understood, but include abnormality of hepatocyte metabolism, hepatocyte autophagy, endoplasmic reticulum stress, hepatic immune cell function, adipose tissue inflammation, and systemic inflammatory medias impairments of ketogenesis emerges and NAFLD progression in the molecules, mainly in humans. So in conclusion, the ketones, which are largely were thought of as a secondary this thing, as an overflow pathway capable of accumulating toxic emissions, from that we have come to a place where we are trying to induce ketogenesis, of which beta hydroxybutyrate is more important. Still minus points are there. The amount, we still don't understand the full mechanism of ketogenesis and its protection. The best examples of treatment are used in cancer, followed by in seizures. Again, best examples have been shown with the SGLT2 and injectables, that you can, the ketogenesis which comes is able to protect the heart from a failing heart, from a struggling heart to use the glucose into a thriving heart which does better. While factual, nutritional and pharmacological approach manipulate ketone metabolism, make it attractive therapeutic target. Aggressively posed but prudent experiments remain in both basic and translational research because conflicting reports are still seen. Unmet needs have emerged in the domains of defining the role of leveraging ketone metabolism in heart failure, obesity, and NASH, and type 2 and cancer. These are the places where it has shown the maximum protective elements. So thank you for the patient hearing. Questions at the end, or?
Thank you very much, Mohan, for that very lucid presentation. We will have the Q&A at the end of this session.
We welcome the next speaker, Dr. R. Gauri Shankar, a powerful speaker. We will be talking about obesity paradox. As you are well aware, during this COVID situation, you would have seen a lot of patients bringing down the children also with rapidly increasing weight, like say 10 kg, 15 kg and all. To talk about this obesity paradox, I now invite Dr. R. Gauri Shankar to take on the stage.
So thank you, sir. Thanks for the opportunity. Respected senior colleagues, friends, good evening to all. So I have been asked to talk on this topic, obesity paradox. I would like to thank Chandrasekhar sir and team for giving me this topic. And I heard this topic like obesity paradox. I was just looking like what is there in paradox. All throughout the time we have been thinking like obesity is detrimental. Always it is detrimental. No. So we know like there are various mechanisms like by sympathetic tone, reduced insulin sensitivity, and free fatty acid turnover promotes systemic inflammation. There are so many mechanisms which are associated with obesity, which is associated with increase in CV events. But what is there in paradox? Like I never thought like obesity can be helpful. So research like I just Googled and saw like is there something to say like obesity really helps? So I was discussing with Chandrasekhar sir also, like there are many datas, many datas, like this article which came in Lancet, looked into about, it's a meta-analysis of about 40 articles, looked into about 250,000 people for about 4 years. And what the study showed was in people, they were seeing the mortality of people with respect to obesity. That's what they looked into. They picked up Embed and the PubMed and other showed like the quantified articles. When the meta-analysis was done, it was showing that whether the people die of myocardial infarction or all-cause mortality or mortality because of PCI or CABG, whenever the obesity was increased, it was showing an increased survival. Astonishing, no? Like, how can it happen? Like, there is an U-shaped curve. If you see over here, there is an U-shaped curve which was happening, which is favoring that slightly being obese is good for the people. So the other article, the other article, which is as early as 2013, this JAMA article looked into much more data which was available. So about 100 studies, it looked into 3 lakh deaths and about 30 lakh people who were looked into this article. It's a meta-analysis. They were trying to match obesity with the all-cause mortality. And this article again showed like fantastic data. See the amount of people who are involved in this meta-analysis. It showed that grade 1 obesity was not associated with higher mortality. If the people are overweight, it benefits them. So the paradox, it really helps. So how can it happen? Like then I saw many articles. So I just looked into whether there is a terminology called as reverse epidemiology. This terminology of reverse epidemiology came after people who had an higher creatinine in people who are undergoing dialysis. When the LDL was increased, when the people were having hypertension, they were showing good prognosis, including higher creatinine. So it is just from that they coined this term called as reverse epidemiology. And people in heart failure, MI, COPD, the people from older nursing home, peripheral arterial disease, stroke, post-operative complications, surgical intensive care, patients undergoing non-bariatric surgery, in critically ill, osteoporotic patients. All these patients showed, there are data to show that. I can just tell one article after other article after other. It all showed being obese is beneficial. So something like which we can't understand why it should help the people out. There is a way, like there is an U-shaped curve, like happens in diabetes. So what happens if you treat aggressively the patients? When you try to bring down the HbA1c, the mortality increases. Something like hypertension, when you aggressively treat, the events are not as good. So there exists an U-shaped curve, no? So similarly, there is an U-shaped curve for obesity also. So that's what the data shows. But does being obese really gives advantage? That is the question. So what we need to understand from these articles is, so all this meta-analysis came from article which got published right from 1980s to 1990s. So the huge database. What we try to understand from this is, when it means by lower BMI, what does it mean? If the BMI is less than 20 for an individual, what does it mean? He has decreased muscle mass. So when there is a decreased muscle mass, what happens to that individual? His exercise capacity comes down. It means that his mobility comes down. So he's more prone for illness. It is as simple as that. We try to make these people to gain weight, no? So that is what is happening. So when people have a lower BMI, they were predisposed to higher events. So we can justify that. So BMI doesn't actually reflect the adiposity. When I served in army, there was a Jawan who came. There was an officer who came. His BMI was about 26 or 27, but there was not even a pinch of fat in him. You would have seen people like that. So does BMI of 26, 27, does it really mean that he is obese? It is not so. Especially the specificity of BMI, whenever it is around 25, when the BMI, the specificity to show that the patient has got a adiposity nature is just about 65%. As the people become over obese, the specificity improves. Obviously, they are becoming over obese and shows that there is more amount of fat present in them. But when it is lesser, around 25, it doesn't predict the adequate adiposity in the individuals. Obese and morbidly obese individuals, just because they are obese, they will go to the doctor, they will take treatment, they will record their blood pressure. So they will get adequate treatment than non-obese people. So all studies showed a single point weight measurement. So when the patient dies, obviously he will lose weight, but you will not take them into consideration, isn't it? So they will show as mortality. Obviously, because of the loss of weight, their BMI will come down to less than 1918. So it is just playing with the numbers. The patient gets emaciated and dies. So it shows that a single point measurement will not help. But most of the studies showed only a single point measurement. So it doesn't predict the exact pattern. So you have to see a sequence of weight. So that was not happening with there was an excessive bias because in 1980s and 90s, we were always thinking that whenever we become obese or when the individual becomes obese, it was associated with a higher mortality. So even if people do the study and try to publish it, it was not getting published. So nobody is willing to publish a negative data. So there was excessive bias also, which was happening. So does thin, it really help? So one side obesity is not helping. Does being thin, does it really help? We will just go to this INDIAB study from India and see the average, the people who are diagnosed with the diabetes, their average BMI was as small as 22 and their waist circumference is less than 76. So being thin also, it doesn't help because people who are diagnosed with the diabetes, they were thin. Their BMI is normal. It is less than 22, 23. For Western Caucasians, we say like BMI is overweight, it is 25. For us, it is 23. But all these people who are newly diagnosed are having a BMI of about less than 23. 22 was the average BMI. The waist circumference also, if you see that it is less than 80, what we see. So what does it mean? On one end, we are looking at the statistical data. On the other end, we are not able to correlate with being thin and all. So where it goes is matters. So what do we mean by where it goes? This is an article which got published in Lancet. So leave alone all these paradoxes. We will just come to the carry home point. Two very important articles which needs to be read by all the colleagues over here. Causes, consequences, and treatment of metabolically unhealthy fatty distribution. This got published in Lancet. In this article, what they try to do is very, very simple. They looked into one article, which is again like it is called as a Dubingen Diabetes Family Study Group. What they tried to do in this study is they recruited about 1,000 people and they tried to see what is the insulin sensitivity pattern in those patients. Then with an MRI, they tried to compartmentalize where the fat is. So you can see that the fat may sit in the subcutaneous tissue, the fat may sit in the thighs also, the fat may sit in the visceral area also. Then they looked into carotid intimal media thickness. So they looked into all these three compartments, and what they have shown is, especially just look into the middle part of the diagram. So we have two set of people who are metabolically obese, people who are metabolically non-obese. And there is another set which is given in the lower range, where the carotid intimal medial thickness is low and the carotid intimal medial thickness is high. Especially if you see in the middle part, what happens is we can see the people who are metabolically obese and metabolically healthy and metabolically non-healthy when they have a carotid intimal medial thickness low and high. So when these changes happens, the visceral obesity changes. Okay, the amount of fat that is secreted around the organs, the visceral obesity, it changes. But if you see the subcutaneous tissue, it doesn't change. You see these graphs, you see these things, it doesn't change between these two subgroups of people. So it doesn't change at all. But what is much, much more important is, you see the third part of it, how much amount of subcutaneous fat mass is in the thighs or leg. So we know the association between visceral obesity. But what do we learn in this article is how much amount of fat gets deposited in the back, thighs, legs is much more important. When we gain weight, if the adipose tissues are getting enlarged in the leg, fat and thighs, it is okay. That is what this article helps us to understand. So whenever we gain weight, it is not the subcutaneous fat that is going to be important. It is okay for us. It is the visceral obesity which is very, very important. But when the visceral obesity, even before the visceral obesity happens, whether the expansion happens at the level of thighs and back is very, very important. If it happens, then it is fine. So people who have this fat over here, over thighs, over legs, are much more low risk than the people who have their fat tissues around the visceral tissue. So this article, like we have seen the this apple shaped and pear shaped for years together, we have been discussing about this. So the amount of, it is okay to be obese. It is okay to be obese. But what matters is, where does the fat go? If the fat stays instead of in the visceral adipose tissue, if it stays in the leg and thighs, it is beneficial to the people. So how can we decide this? We can't decide that. It is either genetically prone. Lots of genome-wide association studies are there to prove this. We cannot decide that. Or some therapeutics like TSGTs might help, because that moves the fat from the visceral tissues to the subcutaneous tissue. So that is one thing we learn at the end of this study. So it is okay to be obese, provided the fat goes into the bottom part. That is one point. The second is it is okay if one doesn't lose weight also. So what do we mean by that? So how can we say that don't lose weight? So we will just take into this second article. Please go back and read this article. Whatever I say may not be, you cannot appreciate the real meaning of it unless you read this article. Still, I will try to explain this article in a minute's time. Very, very fantastic article. We always say people, like I do exercise, but I'm not losing weight. Why people don't lose weight if they do exercise? We say 7,200 calories you spend for losing half kg. But where does the 7,200 calorie if you exercise, like you do 7,200 for 10 days? Do you lose half kg every time? It doesn't happen, especially for people with the BMI 25, 26. Even if they do exercise, it doesn't happen at all. So why does this fat loss doesn't happen? This article tries to explain that. So we will just briefly go through this. There are three terminologies, try and understand. One is the basal energy expenditure, the energy that happens at the basic rate. So whether it is immune system, cardiorespiratory system, renal system, brain, liver, skeletal muscle, whatever is there, that is basal energy expenditure. Whatever the animals that they do for activity, reproduction, growth, because they have to reproduce, they have to grow, they have to get thermoregulated, they have lots of activities. This is called as activity energy expenditure. So what happens in human beings when they evolved? The basal energy expenditure was increased, rather the activity energy expenditure was getting decreased, because our immune system, our heart, our muscles, our tissues, they require more amount of energy than the activity that we do. So that is called as activity energy expenditure. So three terminologies are there. One is total energy expenditure that happens with the body. The second terminology is the basal energy expenditure. The third terminology is the activity energy expenditure. So with these three terminologies, there are three models of energy expenditure which happens. So the first model is called as addictive model. Addictive model is what? Over and above your basal energy expenditure, you try to spend some weight. So today you go to swim for 1 hour, you spend about 600 calories. So when you do that, the activity energy expenditure, just focus over here, the activity energy expenditure is increased. So when you try to correlate the total energy expenditure with the basal energy expenditure, it shows a linear graph. So try and understand, you have a basal energy expenditure, the total energy expenditure is increased. So just in the second part of the diagram, it is linear, okay? But there is no difference between the basal energy expenditure and activity energy expenditure, because basal energy expenditure stays over there. The activity energy expenditure is the extra swimming that you do. So there is no correlation between these two things. So it leaves a horizontal chart. There is a second model of performance model energy expenditure, where when you try to match, so in performance model energy expenditure, what happens is a guy typically goes to the mess, eats 10 parotta, 4 dosa, ellam chapduvan, but weight ஏற மாட்டோம், because his basal energy expenditure is higher. So if you see in this model, the basal energy expenditure is also elevated, but he continues to do work. So the activity energy expenditure also increases. So when you try to compare activity energy expenditure, total energy expenditure with basal energy expenditure, it is linear. The activity energy expenditure with basal energy expenditure, it is again linear. But what is much more important, which you need to know, is the compensation model. So as an animal, as our forefathers, we were spending more amount of basal energy expenditure, but as we evolved, the basal energy expenditure tried to conserve. Okay, so the basal energy expenditure tried to conserve. So if you see in this chart, the basal energy expenditure is coming down. So when you try to plot this activity, total energy expenditure with the basal energy expenditure, it is showing a horizontal line. When you try to compare it to activity energy expenditure with basal energy expenditure, instead of being linear, it shows a negative marking. So can we prove this concept? So if we can prove that it is non-linear, it is negative. Just 1 minute, sir. We are done with. So exactly that is what this article tries to do by doing radioisotopes in the form of giving hydrogen and oxygen. Radioisotope hydrogen and radioisotope oxygen was given. So based on the difference of the radioactive hydrogen oxygen which gets eliminated, they were able to show that the difference, that the correlation between activity energy expenditure and the basal energy expenditure is not linear. It is negative, which shows that the basal energy expenditure of the individual comes down. So what does it mean? If you are spending 100 calories, it doesn't mean that you spend 100 calories, you spend just 70 calories. So we try to overeat for that, try to compensate for that, but it doesn't happen. That is the reason why people don't lose weight in spite of doing exercise. So this is the model of expenditures. So please go back and read this. You will understand more about this. So that ends the fifth point. It is okay even if one doesn't lose weight. Okay. So the two paradoxes where it goes is important. It has to stay in the thigh. It doesn't depend on two people can try to be the same weight, but the fat has to go into the thighs. It is okay even if they don't lose weight, because exercise is very important, but they should not hesitate to do the exercise. But even if the weight reduction doesn't happen, it is okay, but still they continue to do exercise. Thank you for the attention.
Indeed, it was a very powerful speech. All this time, even yesterday, all the speakers were telling about calorie restriction, reduce the weight. But as the speakers told, being obese itself is beneficial. We'll come to the doubts at the end of the last session.
The next topic is LDL paradox. I think we have enough studies to say reduction in LDL is paramount for cardiovascular health, for as heart protection study, as heart care, and so on. But now and then we have certain studies which makes a big ripple. So I think Rajesh will be talking on LDL paradox. Over to Rajesh.
So respected chairpersons, senior clinicians, and my dear friends, a very good evening to all of you. Before I could start, I want to profusely thank Professor Chandrasekhar sir for giving this wonderful opportunity. And also a very special thanks that you shared certain articles so that it was easy for me to prepare for the talk. So over the next few minutes, I'm going to discuss with you about the LDL paradox. What is it? We all know about cholesterol hypothesis. When cholesterol gets increased, when LDL gets increased, the occurrence of cardiovascular disease increases and the mortality due to cardiovascular disease increases. This we all know. And again, when we take measures to reduce total cholesterol or LDL cholesterol, the occurrence incidence of cardiovascular disease reduces. That also we know. That is what is called cholesterol hypothesis. And that's the reason why we reduce LDL, we target LDL. And we all know that when we bring the LDL just by 38 milligrams per deciliter, we can achieve somewhere around 20 to 25% reduction in the cardiovascular event. So simply, when a person is having LDL around 170 milligrams per deciliter, just bring it down to less than 100, then what happens is that the CVD risk reduces by 40 to 50%. Or in instance, if it is around 100, you bring it to close to somewhere around 60, around 20 to 25% reduction is achieved. So this is what we all know. But again, where we should go, that is again a confusion, because lower the better. We have so much of evidence. Initially it was 100, going to less than 100 was beneficial, then going to less than 70 was beneficial, then 30, then 50, then 30. Then now there are studies to show that even if you bring it less than 30, somewhere around 25 or 15, there also you get still benefit. So we don't know lower cutoff value beyond which benefit will not be there. So that is the confusion. But that is not what I'm going to talk about. I'm just going to enlighten you about the flip side of a coin. So when we bring LDL to very low levels, is it absolutely safe? Or when a person is at a very high HDL level, is he really at risk? So that is the other side of the coin. We're just going to look into it. So there are several data to show that when somebody has very low LDL, the risk of cancer increases. A lot of data are there. I'm just going to project one data here. This data is from Denmark, Copenhagen. There are two sets of cohorts. And what you can see is that in these two sets of cohorts, good number of patients. One cohort, there were more than 10,000 patients. In the other cohort, close to 60,000 patients. And they were all followed up for a considerable period of time. And you know what happened? At the end of the thing, on analysis, you can see that compared with people who had their LDL more than 158 milligrams per deciliter, people who had their LDL less than 87, they had a 43% increase in cancer. So this was the data. And again, in the second cohort of more than of close to 60,000 patients, what you can see is that compared with keeping an LDL of more than 135, when somebody brings down their LDL to less than 80, then the cancer risk increases by 31%. And if you take out patients who are taking statins, then this risk increases by 58%. So many studies have shown that. And again, what it has shown is that 50% reduction in LDL increases the cancer risk by somewhere around 10%. That means from 140, you try to bring it to 70, data tell you that there is a 10% increase in cancer risk over a longer period of time. So what are the reasons? We don't know what are the exact mechanisms behind it. It only tells you that lipoproteins are involved in protective mechanisms against cancer. So when lipoprotein levels go down, then that mechanism is not going to work. The cancer is going to increase. In fact, there are plenty of data. I just forgot the name of the scientist who did this study. He's from Denmark. So he has done a lot of trials and he has done a lot of analysis on breaking this cholesterol hypothesis. So this particular person has done a review of a lot of studies where he has seen more than 140,000 patients who are all followed up for a period of more than 10 to 30 years of follow-up. And what he has found is that people who had very low LDL had increased cancer risk. So this is one thing. And is that over? See, again, plenty of cancers. I'm not going into the detail. Again, this is another thing. We all know that when LDL reduces, the risk of ischemic stroke reduces, but again, the risk of hemorrhagic stroke increases. A lot of data are there. I'm just going to project a few data here. Two sets of data. One is from the ERIC trial and one is from the CHS trial. And these patients are all followed up for a considerable period of time. Just look into the period of follow-up. 263,489 person years of follow-up. Such a huge follow-up period. And what you can see is that we all know that African American ethnicity and hypertension are all risk factors for hemorrhagic stroke. But what has been found is that low LDL was an independent risk factor for an hemorrhagic stroke in this particular trial. And again, but there are so many trials which have shown that very low LDLs are associated with the hemorrhagic stroke, but we don't have previously we were not having a sex stratified data to look into whether females are also having the same risk. So to fill up that lacune, you have a trial here. This is from the US, and you can see the women's health study. Somewhere around close to 28,000 female patients, female health professionals were all followed up. They were all over the age of 45 years. They were all followed for a period of 19 years, more than 19 years. And what you can see is that compared with people who kept their LDL between 100 to 130, people who had their LDL to less than 70, you can see there is a huge increase in the occurrence of hemorrhagic stroke. The total hemorrhagic stroke, the intracranial hemorrhage, as well as the subarachnoid hemorrhage, all these things were high in people who had their LDL less than 70 when compared with the reference group where the people had their LDL between 100 to 130. Yeah, of course, here you can see some kind of a U-shaped curve where in the extreme, so you can see if the cholesterol, if the LDL cholesterol is more than 160, there also there is an increase. But look into that, the difference between the group having 100 to 130 and more than 160 is not statistically significant. But here, this is a huge gap. And you can see this data is statistically significant, which clearly tells you that keeping a very low LDL can increase the risk of hemorrhagic stroke. And again, if you look into this data, these people who had their LDL less than 70, they had 2.17-fold increase in having a hemorrhagic stroke when compared with people who had their LDL between 100 and 130. And again, this is another data which I'm going to project. Again, you can see two different sets of data. And the thing is that you can see it very clearly here, compared with people who had their LDL more than 140, people who had their LDL just less than 100, they had a 55% increased occurrence of hemorrhagic stroke. And again, the second line, I'm not able to use this pointer here. Here you can see compared with people who had an LDL of more than 140, if they bring down their LDL to less than 70, then there is a 78% increase in the occurrence of hemorrhagic stroke. So all these are data to show. Now, what is the reason behind that low LDL causing ischemic stroke? So there are obvious reasons. We all know that when there is a low cholesterol, what happens? It will lead to arterial medial smooth muscle layer necrosis. We call them angionecrosis. So once angionecrosis sets in, what happens? The endothelium will be impaired and microaneurysm sets in. And once microaneurysm is there, then there is tendency to bleed. So this is one thing. And again, there are trials which has done in rats, which has shown that if you feed the rat with a high fat diet and increase the cholesterol level, then compared to the controlled rats, these rats did not develop angionecrosis and no microaneurysms and no ICH bleed, intracranial bleed was not there. So now there are studies to show, enough evidences to show that very low LDL can increase the risk of intracranial bleed. But looking into other side, high LDL and increased survival rate. I'm just going to show few data here, just two data I'm just going to show. One is from the NAN study. You can see follow-up period was somewhere around 7.8 years and a good number of people, 19,000 people were followed up. And what you can see is that whatever is the baseline, whatever is the comorbid condition, whatever is the age, whether they're smoking, whether they're not smoking, whether they have diabetes or not, whether they have CVD or not, what you can see is that people who had their LDL less than 70, all these groups, all these people had increased, their mortality got increased. And here it will be very clear if I can show you, after adjusting for all the variables, you can clearly see the mortality rate here. People who had their LDL less than 70, you can see there's an increase in mortality. And another thing also you can see, people who had their LDL level more than 160, you can see their survival rate is as good as somebody who's maintaining between 100 to 130. But I'm just going to, this is the last data I'm just going to project you. This is a very good data, huge data. And you can see there were 19 relevant studies were taken, 20 cohorts. Look into the number of the patients. 63,57,729 patients. All these patients were, if you can look into that, there were 18 cohorts which looked into the total mortality. And in 8 of those people, in 8 of those cohorts, what you can see is that people who had highest LDL lived as long as those with normal LDL level. And in another 9 cohorts, people who had the highest LDL, they lived even more longer than people who had the normal LDL level. So this is what has happened in this particular analysis. And again, they also looked into the cardiovascular mortality. There you had some kind of a mixed picture. In few cohorts, you can see high LDL was associated with CV mortality. And in few cohorts, it was inversely related. And in few cohorts, you had a U-shaped curve. That is, with high LDL, you had increased mortality. And again, on the other side, with very low LDL, again, there was increased mortality. So somewhat, some kind of a mixed picture was there. Now the question is that if high HDL could cause CV mortality, then what happens is that people who had normal LDL or people who had very low LDL, they should have had increased survival rate. Because in most of the countries, the most common cause for death is cardiovascular mortality, but that did not happen. I can show you, and I can show you in evidence. There's plenty of studies that have shown that people with a high LDL, they lived longer or at least equal to that of people who had normal normal LDL levels. So here itself, this concept of cholesterol hypothesis is being shattered. I can show you evidence here. This is a data which is taken from the WHO Global Health Observatory data. You can see mortality in 181 countries. Here you can see people who had highest cholesterol, there the mortality is actually very, very low. And this is in male data. Again, in females also, you can see in 181 countries, WHO data, people who had high cholesterol level, they had the least mortality. The survival rate was actually more. So looking into reasons, what could be the reasons? One is, a lot of data have suggested that people who had low LDL, they are more prone to infection-related deaths. The reason is that lipoproteins can prevent any bacterial, viral, or parasitic infections, and they form an integral part of our innate immunity. They can bind and neutralize LPS, which is found in the gram-negative bacteria. They can also bind and neutralize lipotecoic acid, which is found in gram-positive bacteria. So what can they do is that by binding with all these things, they can prevent the infection, or when an infection is there, they can lessen the severity of the infection. So these are the things. And again, when there is infection, LDL can get oxidized, and the oxidized LDL in turn plays an anti-infective role, and it protects the endotoxin-induced tissue damage. For all these things to happen, you should have a normal LDL level. When the LDL level is too low, this protective mechanism will not be into play. And again, I can show you so many studies where LDL has proven its anti-infective properties. And again, now the question is, if that is so, why people having high LDL having high mortality? So this is where we need to understand stress plays an important factor here. There are a lot of evidences to show that when there is a chronic stress, there is an elevation in both total cholesterol level as well as LDL level. And stress can directly increase the CVD risk, irrespective of whatever is the baseline cholesterol level. Stress can directly increase the CV risk. This is what we need to understand. I'm not going into the detail for a lack of time. And again, another important thing, in familial hypercholesterolemia, where people have a high HDL, the mortality rate can be high. I'm just winding up, just half a minute. So, but what we need to understand is that these people also have hypercoagulable state, and that could be another reason for increased mortality. We can have it in the discussion. To summarize, what we need to understand is that, yes, there is cholesterol hypothesis, but other side of the coin is also there. Lipid paradox is also there. It has been proven. It has been already, so many trials are there. So what is it is that people with very low LDL levels are not absolutely safe. We have seen data that there are increased occurrence of cancer is there in these patients, increased occurrence of intracranial bleed is there in these patients. And we also have evidence to show that people who have high HDL, they also live better. In fact, in some of the studies, the survival rate is actually even more than people who had normal cholesterol levels. So with this, I stop. Over to the chairperson.
Thank you, Rajesh, for the very elaborate presentation talking about the LDL paradox. We'll move on to the next speaker.
The last batsman of today is none other than Dr. N. Kannan. He will be talking about diabetic diarrhea. Often we see our patient asking too many questions. Some patient will also have some 20 to 25 questions. Treating these patients itself will cause diarrhea for ourselves. Today, it's a very, very important topic, diabetic diarrhea. Dr. Kannan is Joint Secretary of IMA GTVT branch, life member in RSSBA, member Diabetic Association of India Southern Chapter, member in Indian Food Society, member in Endocrine Society, participated in all national and international conferences in the field of diabetes and cardiac diseases, conducted many roundtable discussions, and is member of diabetes clubs. Over to Dr. N. Kannan. Dear delegates, kindly note down your doubts. You can unmute your microphone and then you can ask, or otherwise you can jot it down the questions to be asked to the speakers and kindly pass it on to the chair after the end of this session.
Good evening, friends. Thank you, respected chair, for the wonderful kind words. And my heartful thanks to Professor Chandrasekhar and two days, we have been talking on lot of things on the diabetes updates. We have been talking on the diagnosis technology, and also we have been talking on the new molecules, and also we have been talking on the lot upgrades and this one new emergencies in the management of diabetes. And we are talking about the snack technology and all. It's a great pride and honor to render my presentation before my mentors, Shanmuga sir, then my teachers and my friends and colleagues here. Say, in a routine clinic setup, if you see a diabetic patient, we were wondering to reduce the burden of glycemic control, and ultimately we are able to control both the complications, both micro and microscopic complications. And off late, this one of the important things is the gastrointestinal manifestation of the diabetes is often neglected, and therefore it has been mentioned in all the textbook acts, exclusion of the diagnosis. Professor Chandrasekhar, while giving me this topic, I was always wondering. So I don't know what the things we want to talk about, because diarrhea means we know what the infective pathology and some other pathology regarding that. But regarding the chronic diarrhea and diabetes, there are a lot of things to be understand. I was going through all the article. I was able to get the article by one of the mentor, Professor Sachan Joshi from Mumbai. He was entering two articles. One article from Science Direct from Elsevier, and another article from the Diabetes Care 2020. So after going to the article only, I'll be able to see that's a huge, vast subject here in this segment to want to read more and more, because this segment covers the whole entire central nervous system, including the peripheral nervous system also. So my topic will be on the chronic diarrhea in diabetes with the acronym of DD as diabetes diarrhea. Very, very fascinating. See, in our routine clinic setup, our goal to prevent the complication, both macroscopic complications, microscopic complications, we are most focusing on the microbial complication. And also we have to provide the good quality of life and also good quality of quantity of outcomes and all. How it can be commanded, how it can be offered, and how it can be given. Because if we want to prevent all the complications, then we want to target all the system, including right from the vascular phenotype, metabolic phenotype, myocardial phenotype, and also we have to focus on preventing one of the most important thing is gastrointestinal manifestation of the complication of the diabetes mellitus, including both type 1 and type 2 diabetes mellitus. Because diabetes, there is one of the clear manifestation of both the diabetes forms in type 1 as well as the type 2 diabetes mellitus. Very fascinating introduction, because this is nothing but the interlink between, but it is pathophysiological link between the brain-gut axis. The key player is ultimately hypothalamus and is mediated by autonomic nervous system, both sympathetic as well as the parasympathetic nervous system. It contains both the afferent as well as the afferent. And more and more dysregulation on the gastrointestinal tract, right from the esophagus to the anus. This is the main introduction of this topic, because this is one mediated by the hypothalamo-pancreatic gut axis. The simple form is brain-gut axis. What is meant by diabetic diarrhea? In simple definition, it is the hyperglycemic induced neuropathy of the entire nervous system, enteric nervous system. What is the enteric nervous system? It is the whole nervous system involving right from our esophagus, that is from our saliva to the anus. Very fascinating history is there with the enteric nervous system. Almost 100 millions of neurons have been involved in the enteric nervous system to regulate the bowel habits. Is equivalent to the whole spinal cord, because whole spinal cord contains 100 millions of neurons. Like this enteric nervous system also has almost 100 millions of neurons. This neuron loss, this neuronal dysregulation by means of hyperglycemic induced neuropathy in the various form of oxidative stress, especially form of polyiol pathway, tyrosine pathway, which is induced by the all mechanism, including the RAS, this one, and the ROS activation as well as the age activation. These are the main culprits behind this diabetic diarrhea as well as the diabetic gastroenteropathy. If you see the quality of life, first of all, in all the diabetic patients, we were accessing, we were treating, and we were wondering of the quality of life. The quality of life will be distorted by means of this main predominant neuropathical involvement, especially the neuropathy of the GI disorders and the peripheral neuropathy, because most of the peripheral neuropathy have the acute painful neuropathy and don't have enough sleep, and patients go for distress and erectile dysfunction. Because these are the main areas in our routine OPD. We will see a lot of patients regarding GI disorders, peripheral neuropathy, and erectile dysfunction that we want to implicate, and we want to correct the patient, and accordingly we want to treat the patient and give the good quantity and quality of life also. The important facts of this diabetes diarrhea is the prevalence of GI disorder is almost 70%, which involves both type 1 and type 2 diabetes. It's predominantly more in females than in the males. The level of control, because in fasting sugar, it may be one sort of manifestation, in the prandial state, one sort of manifestation, because the problem of control is mainly mediated by the neuroreflexes, especially by the autonomic nervous system, by the sympathetic. The sympathetic and parasympathetic plexus, I will tell you later. What is the pathophysiological link between this nervous system, I'll tell you later. One of the most important thing is psychological comorbidities, including the depression and anxiety, because most of the diabetic patient will have any form of sympathetic form, will have depression and anxiety, and diabetes. This is one of the commonest manifestations among the both type 1 and type 2 diabetes mellitus, which will lead to the irritable bowel syndrome and also to dysregulation of the whole GI tract. The onset of depression multiplies the GI tract manifestation by 3 to 4 times. Once if you treat the patient with the resolution of the depression, almost the 2% of the chance of regression or resolution of the symptom will be dissolved, and GI symptoms have a major impact on the quality of life. And also the gastroparesis, because this involves both gastroparesis as well as the gastric motility disorder, and will impact the burden on the huge impact on the routine expenditure and annual income. The occurrence of the gastrointestinal adverse reaction with metformin, we know metformin is one of the king of the dysglycemic agents. We have been using metformin almost for 5 decades. This is another molecule we have to consider in our routine clinical practice, because metformin is very good drug, but it a lot of controversies regarding all the other things, because from respiratory failure, cardiac failure, and GI manifestations, and all these molecules should be considered. And therefore, this molecule is a newly diagnosed. In newly diagnosed DM was associated with a 40% reduction in the adherence, because once the patient going for the drug-induced diarrhea, the patient will not take the medication properly. Ultimately, the adherence will be distorted. There will be poor complaints, and also the glycemic level also will be dysregulated. There will land up in a lot of complications. So diabetic diarrhea being the most debilitating of the GI effects of the diabetes, so we have to keep it in mind. And all the textbooks clearly explain that this is the area, but it is not diagnosed properly. It is not evaluated properly. It is underutilized. See, in most of the conferences, this topic is not utilized properly, because we are talking a lot of artificial intelligence. We are talking about the machine learning. We are talking about the CGMS and all, but we are not talking about this important, routinely seeing OPD impact, so-called as chronic diarrhea and diabetes. And therefore, we have to keep in mind, in a routine clinical practice, if a patient gets the problem of diabetes, diarrhea, any patient with diarrhea, with diabetes, we have to keep in mind whether it's going for any autonomic neuropathy, because we know that this GS symptom will not have any morbidity and mortality, but with autonomic neuropathy, with the cardiac involvement, cardiac autonomic neuropathy, at any time the patient go for sudden cardiac arrest or sudden cardiac death, because cardiac autonomic neuropathy, one of the commonest manifestations of the diabetes, type 2 diabetes of the age of more than 8 or 10 years of duration. Very interesting facts. See, right from all the segments, from the upper GI, middle GI, and lower GI, both these type 1 and type 2 diabetes have different manifestations. They have the reflex form of esophagitis, they have dysphagia, both type 1 and type 2 diabetes mellitus patient will have. They have nausea and vomiting, they have some bloating and distension diarrhea, and they have early satiety problem and diarrhea, constipation, and fecal incontinence, because these are all mediated by the whole system of the enteric nervous system, both by parasympathetic and sympathetic form of autonomic nerves. And this makes an important thing, because the myenteric plexus and submucosal plexus of the intestine have been involved in the gastrointestinal tract, which is very important, because this carries both the afferent and efferent impulses. So if you see the other, if you want to define the definition of the chronic diarrhea, see, once again you come to the OPD setup. If a patient coming, doctor, I'm having diarrhea, I'm taking medication for the diabetes. So what you will do? First, we want access. So I was referring a lot of articles, but only one article I able to find in from Science Diarrhea, that diabetes bowel questionnaire have been clearly implicated. That is, loose or watery stools occurring more than 25% of the times have been mentioned as the diarrhea, that is diabetes and diarrhea. These have to keep in mind. This is very important. This is called the definition of the diabetes diarrhea. This is questionnaire. See, every diabetic patient, if they're taking metformin or any GLP-1 or any AGs or any form of disorders, if they're having diarrhea, means we want to rule what are the kind of diarrhea they have, what is the percentage of diarrhea they have, in how many times they are doing this diarrhea problem, and we want to put the questionnaire and we want to evaluate and diagnose the problem accordingly, because the quantity and quality of life is very, very important for our type 2 diabetic patient. So the clinical presentation will be like painless watery diarrhea, is chronic more than 6 weeks, the long-standing diabetes, poor glycemic control, is involvement of both autonomic and peripheral neuropathy, is non-bloody, is more in females, and episode of diarrhea interspersed with the normalcy as well as the constipation. Very, very interesting features are both are nocturnal diarrhea and fecal incontinence, because these involve both the components. And DD is a diagnosis of the exclusion. So most of the diabetic patient, if they're coming with the diarrhea, we want to exclude the diagnosis that is having any autonomic involvement of diabetic diarrhea. Very, very interesting pathophysiology, because this whole diabetic diarrhea has been implicated by means of the enteric nervous system. The afferent nervous system was maintained by the myenteric and submucosal nerve plexus, and the efferent from the central nervous system, which carries both sympathetic as well as the parasympathetic. The main cells that have been involved in the GI tract are these interstitial cells of Gajal and enteric glial cells. And these cells are dysregulated. There will be neuronal loss, because they have the receptor of neuropeptides and other hormones and all to produce, because the peristaltic movement, the absorption, the immunoregulation, the secretion, it's all maintained by these both the cells, especially the Gajal cells and glial cells and the smooth submucosal cells. These cells are dysregulated by means of autonomic neuropathy or any form of peripheral neuropathy. So if you see the understanding pathophysiology, we know about the neuropathy contains both autonomic as well as the focalized enteric neuropathy, and there is changes in the motility disorder. And there most of the cells involved are Gajal cells, enteric cells of glial cells, smooth muscle cells, and there is ionic transport. See, the sodium, hydrogen, calcium will be dysregulated, because the this one, the myenteric mitochondria needs more cytoplasm. There will be dysregulation between the nitrogen and hydrogen, and there will be dysregulation between the cytoplasm and this one is calcium also, and therefore there will be accumulation of the fluid. This fluid load will predominant for the osmotic diarrhea. That is epithelial damage and colonic stem cells. See, the colonic stem cell is very, very important among the larger bowels, because they regulate the thing properly and they regenerate the thing properly, because colonic stem cell is very, very important among the GI tract. So anti-diabetic drugs are very, very important. There are a lot of drugs out there. There are many 4 drugs. Metformin we have exenatide, then we have alpha-glucosidase inhibitors. The other molecules also going for the anti-diabetic drugs involved diabetic diarrhea. Dietary factors, because this non-artificial sweetness they are taking by the diabetic patient like inositol or sorbitol or mannitol, they also go for the diabetes-related diarrhea. Celiac disease is one of the important things we have to keep in mind, because most of the type 1 diabetic patients will have autoimmunity, and they're predominant for the HLA, that is human leukocyte antigen abnormalities. They will go for celiac disease, diabetes, diarrhea. And pancreatic exocrine insufficiency, very, very important, because diabetes itself will cause pancreatitis, and pancreas is predominant for both the gland, because pancreas contains endocrine as well as the endocrine as the exocrine gland. The exocrine gland will have acini. This acini dysregulation will have the impact on the indigestion of all 3 enzymes. These 3 enzymes will have the abnormalities of producing the dysmotility as well as the gut microbiota regulation, and they will go for diarrhea. This is very, very important, but is available in both type 1 as well as the type 2 diabetes. Small intestinal bowel growth involvement, that is, most of the diabetic patients, the type 1 and type 2 diabetic patient, they have the delay in transit. This delay in transit will have the impact on the abnormal bacterial growth, and will land up in small intestinal bowel growth also. So these are leading reason for DD, reduction in the neuronal numbers of ilion myenteric plexus. And very, very important thing, there are 2 phases. First phase is stunned by the stunning of neuronal activity, and the second phase by the apoptosis. The first phase will be clearly by the early insulin therapy and hyperglycemic management. Once the patient gone for the abnormal dysregulation in the mitochondria in the intestine, the apoptosis will lead up. This apoptosis will not be irreversible, and therefore it is very, very difficult to treat. So in the early stage itself, we want to implicate and we want to treat the patient accordingly by means of proper initiation of insulin. So increased neuronal smooth muscle coupling, the fasting state, increased frequency, increased bursts of motility and generating activity, less of nitric oxide, because nitric oxide plays an important role, because this is secreted by the sympathetic activity. This inhibition of sympathetic activity will have the low secretion of NO, that is nitrous oxide synthesis. This will go for the localized dysmotility disorder and more for the osmotic diarrhea. And muscles from colon also exhibit the altered contraction and relaxation. So there are other histopathological findings also. I don't want to detail in this. So the drug-induced are metformin, GLE, I already told about. We are AGS also. So these are the various pathophysical mechanism have been involved in the metformin complicated with the chronic diarrhea. I don't want to detail in this because we don't have enough time here. And there is structural and similarity between the 5-HT receptors, may similar to serotonin release, because metformin may have the more the impact on the diabetes related diarrhea, and we have to keep in mind because metformin at any stage, even at the 8th year, 9th year also they go for diarrhea, and we have to keep in mind, we have to treat the patient accordingly. This is the rule of the metformin half rule. 50 to 70% of patient metformin are intolerant to some extent. 50% of the above have the more pronounced intolerance, requiring most to be more made by 1/2, and 50% the more cannot tolerate metformin at all in our clinical practice. So this is the only drug we have to keep in mind and what to treat the patient for the type 2 diabetic patient. So these are different, these are the various differential diagnoses. I already alluded about this. I don't want to go detail about this. It's very, very important. These are the investigation, detailed personal examination is very, very important. These are the management. There are various management. So it is available now. You can have the capture refer to that. So let us sum up now. Diabetes mellitus is a highly prevalent disease in India, with many associated GS symptoms. The clinical approach to diabetic patient with diarrhea involves a detailed review of medication, including dietary habits, followed by testing to exclude organic pathology of the pancreas, small bowel, colon, endocrine system. Diarrhea is typically a chronic, painless, voluminous, and watery diarrhea, most found in long-standing insulin-dependent diabetic patient with poor glycemic control and concurrent neuropathy. Is the diagnosis of exclusion. It's very, very important. We have to keep in mind. Main goal of treatment is glycemic control with the goal of reversing underlying mechanisms that lead to symptoms. Loperamide, other things and all, we have to treat the diabetes diarrhea. And more than that, the stress also plays an important role in the type 1 and type 2 diabetic patient, and we want to avoid that. So thank for the opportunity given to me. Thank you very much.
That was indeed an excellent talk on diabetic diarrhea. Since we are running short of time, I ask the delegates just any doubts to the speakers, kindly unmute your mute and then ask to the speaker directly. 5 minutes for a Q&A. Jaykumar.
The supplementary diet I already told about this, because most of the diabetic patients, they will take the non-sweeteners form of to control the diabetes. They will take any form of non-sweeteners, not artificial sweeteners. These artificial sweeteners will have inositol, mannitol, and sorbitol, and this may involve in the improper dysregulation of the gut microbiota, and therefore we have to keep in mind, and we want to avoid the patient that matter. Other than that, all the diet should be always balanced. The carbohydrates should be balanced, the protein should be balanced, the fiber should be balanced. Accordingly, we want to tell the patients. Younger subjects, there are no any specific supplementary diet modification, but elderly patient, most of the elderly patient will have some form of neuropathy in any form, and therefore we have to tell the patient to avoid all junk foods and all high rich fiber foods also will go for diarrhea, and we have to balance the diet accordingly, and we want to treat the patient accordingly. So because depends upon the patient age only, we want to treat this, treat and give the food plan accordingly to prevent the diabetes diarrhea.
Yes, sir. I was focusing towards.
Add a few things. There are a few things you should remember. One of them is dysbiosis in many of the diabetic patients, including with our drugs. So dysbiosis needs to be looked at. Now we are looking at microbiome, including antibiotics. Not only antibiotics, even your own diabetic microbiome. So gut microbiome could be a thing. In fact, we are looking at reimplanting food, reimplanting things like that. It's going in a different way. That is one. Frequent small feed is a very important part of diabetic treatment to disabilitate diarrhea. You know, they get overloaded. For them, that is very easy because the peristalsis become slower at first, then one diarrhea sets in, it gets the thing. So frequent small feeds so that the assimilation is good. That is one the thing. In such patients, roughage usage should become minimal because fat and roughage causes more diarrhea. So you should look at it. So easily digestible, frequent small feeds should be the way you supplement for these people.
Okay. Thank you.
Sure. Thank you, sir. Thank you, chairpersons, and thank you, speaker. I think we quickly move on to the valedictory function. Like it won't take not more than It will not be more than 15 minutes. We'll leave you in another 10 to 15 minutes. May I now invite Leela ma'am, Organizing Secretary, Dr. K. Shanmugam, Dr. Prabhu sir, Dr. Gaurishankar sir, Dr. Wasim, Rudra on stage, please. I think we all know that like it's a humongous task like of getting particularly during the COVID period to get the faculties. So we wholeheartedly we thank all our faculties who are readily consented to give spare their valuable times, and heartfully we thank all the speakers and chairpersons. And almost 169 papers, postgraduates have presented their papers. So the judges, almost we conducted in 11 sessions, 11 or 12 sessions. Like so, all the panels, like we had around 12 to 13 papers, and it was judged by a couple of judges from the entire state. Like many people, they joined virtually also. So we extend our heartfelt thanks to all the judges who took part in this conference and made it as a huge success. So as a token of gesture, like so there are so many papers which have been presented. Like so we would like to select almost many people, many postgraduates, they have done a very wonderful job. And some of the people, to our surprise, scored 10 out of 10 also in oral presentation. It was a surprise. There is one guy who scored 10 out of 10. So that is the amount of involvement they had. And in fact, like we had participation from AIMS, Rishikesh, Uttar Pradesh, from Mahi, Manipal, and Karnataka, and Kerala, and of course, throughout the state, scattered participation from postgraduates. We take this opportunity to appreciate their efforts and congratulate all the postgraduates who have presented. So it's time to give some way the recognition for the postgraduates. Almost all the postgraduates have done well, but some of the postgraduates, they deserve special mentioning. So may I invite Dr. Shyam Mohan from Kilpack Medical College. I request Leela ma'am to hand over the certificate to her for his best oral presentation. Next, may I request Dr. Arjun Jayachandran from Stanley Medical College. Important. Next, I request Dr. John Samuel Wiesman from Karpaga Vinayaga Institute of Medical Sciences and Research Center. I request Krishna TV on stage. I request Dr. Gaurishankar to adorn the medal for the selected postgraduates. May I invite Jose Maria on stage, please, from Stanley Medical College. Next, we move on to the best poster presentation. Can I invite Dr. Sharan from Venkateshwara Medical College and Hospital Research Institute? I request Dr. Prabhu sir to adorn the medal for the medallions. Dr. Sharan is here. Dr. K.M. Vignesh. He is from Rajarajeshwari Medical College and Hospital. Dr. Mridubhashini Swarup. Dr. G. Ramakrishnan from Stanley Medical College. Dr. Hagamat Shafiq from Madras Medical College. We thank all the and congratulate all the postgraduates who have given their best and got their medal. And it's also time to reciprocate our heartfelt thanks. Like it's not a one-man job. People may say that it's a one-man job, but it's entirely absolutely a team effort. So we do have a lot of people who are behind the show, like who have been working tirelessly, effortlessly, almost for more than 2 or 3 days. Some of the guys who are here, they have not even slept for almost 36, 48 hours. So they are given their the best of their effort, and it's time to recognize Mr. Sundar on stage, please. I request Dr. Shanmugam sir to hand over the memento to him. Dr. Sahana on stage. Dr. Tarini on stage, please. Dr. Srihari on stage. Dr. Nitesh Adit on stage, please. So it's also another team of group of people who have given their best, and they try to contact the faculties and the postgraduates, and they coordinated with the entire team of people. May I now invite Dr. Mohan to give away the mementos to Mr. Vignesh. Dr. Gopinath. Dr. Gopinath, come. Miss Shravani, come. Miss Bhargavi. Miss Roshini. Thank you, Dr. Mohan. May I request Dr. Balaji to hand over the mementos to Yashwani. Yashwani, yeah, come. Yashwani is there. Srilaka. Yashwani. Janvi. Karpagavalli. Thank you, Bala. I request Dr. Yui Mohan to hand over the memento to Saravanan. Good. Saravanan, yeah. Next to Sunil Gavaskar. Sunil. Rudra, who is missing? Karthik. Karthik on stage, please. Sambit. Yeah, okay. Who is left, ma? Yeah. Karpagavalli. Yeah. Srileka. Thank you, Dr. Mohan. I request Dr. Sedram, please come and give away the mementos to Anita. Anita, yeah, come. Oh, yeah. Sambit. Dr. Guru Satyan. Zubairia. Momento matire. Parani. I request Dr. Thank you, Sedu. I request Dr. Leela ma'am to hand over the mementos to the people who are compared from Stanley Medical College, Dr. Kavya, அது வேறம்மா வேற வேற அந்த இது வேற அது 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 அது. காவியா கம். Dr. Malavika, come. This conference would not have been possible without the support of the pharma companies. And as a token of gratitude and a goodwill gesture, there are almost 23 companies have participated and contributed their academic grant to conduct this conference. As a token of gesture, I just read out the name so that the representatives can come and collect the mementos from Dr. Prabhu. Sand Labs. Anyone from Sand Labs? Yeah. O2 Fitness. Anyone from O2 Fitness? Synergen Pharma. Lipon. HBC.
He wants you to give to some.
Novartis. HBC. Yeah. Jagdish. Merck. From Aristo, I request Dr. Wasim to hand over the mementos to Aristo people. Yeah. Aries. USP. 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 Anyone from Boston? Novo Nordisk? Anyone from Novo Nordisk? Sun Pharma? Microlabs? Yeah, Mani is there. I request Dr. Gauri Shankar to hand over the memento to Mani. Microlabs. Corona Remedies? Primus? Anyone from IPCA? IPCA. Primus. Anyone from IPCA lab? Microlabs, Carcion. Microlabs, Carcion. From Mankind Pharma. AstraZeneca. Redmax, anyone from Redmax? Yeah. Anyone from IDFC? We also extend our thanks to the people who have done that, the hoteliers and the catering part of it, and the people who have helped us in constructing those stalls. I request Dr. Shanmugan sir to give a concluding remark. Madam, நீங்க பேசுறீங்களா?
Good evening, everyone. I think after the 2 days of hectic academic feast, we have come to the end of this show, Cardiometabolic Conference. I think the first credit should be the delegates. Just without delegates, we cannot have the show. Therefore, I congratulate all the students, especially the students, and also the physicians, and some of the other branches of medicine also have joined the conference. The benefits goes to ultimately to the patient, that we should realize. It is not for our own sake. Knowledge should be spread, and if it is good now, it should be accepted by everyone. For that, I think Dr. Chandrasekhar has worked out a lot of scientific materials and put together so that now it will benefit both the practicing physician as well as the postgraduates. For year after year, he will be doing similar proceedings like this, so that everyone will get benefit and the healthcare of the country totally will improve. What we have seen in our days as students, there is no conference, there is no discussion, there is no ultrasound, there is no CT scan. We had only plain X-ray, stethoscope, inspection, palpation, percussion, auscultation. That's all we had. Therefore, now you got lot of things to learn. In those days, we learned only few things. But each topic now you have to learn a lot. But you cannot learn without attending this type of conferences also. You can go to the e-medicine, that is different, but nothing like your personal experience sharing with the teachers also. For this, I will request all the students to attend very many conferences so that now you will get experience from other people also. I should also thank Mr. Rudra for arranging all his people behind that. Now, this technical team, I think we came on Friday night. The whole thing was entirely different. Now what you are seeing is entirely different. Therefore, there are many people working behind this type of conferences. We have to give a big applause for them. That is very, very important. And the International Society Renal Research, I should thank personally to all the people who have contributed to this for the organization also. Thanks to all of you.
Thank you everyone for these inspiration words and marvelous timings we spent in last couple of days. I greet my gratitude once again to all of you and I apologize sincerely on behalf of the organizing team at any point where we would have failed to meet the expectation. There was minor technical glitches of audio video, so I do apologize for that as well. But overall, we have received a very good feedbacks from our beloved audience, participants, and everyone. And I owe this success of this conference to the man who has single-handedly brought scientific content and single-handedly worked for this. In fact, he has worked mentally, psychologically, emotionally, sentimentally, more than even all of us, even more than my entire team of BioLeagues ISCRS also. So I don't think it is needed to name him, but we all know his contribution for this conference. I wish everyone a great evening, and I will also request everyone to give a applause and a clap for Dr. S. Chandrasekhar. We have been organizing, we have till date, our experience of organizing conferences goes in triple digit. And every year we have 70 plus or 80 plus conferences we do, and we do this type of activities in almost more than 25 countries, regularly operating, and we have a operation structure also. But still then I would honestly accept we have learned a lot of things from sir. And the things of perfection in his routines of working has also made and also led my colleagues getting a privilege to learn as well also, and we all are doing that. Moreover, I also owe the success of this conference once again to entire team of Stravani, Gopinath, Vignesh. I would request everyone, if you all would have loved them, please applause for my team as well. I also wish my hearty gratitude to all the contributors and participants of this conference. I wish my gratitude again to the contributors in field of scientific aspects in form of content, to all the honorable speakers, and also express my gratitude to who have contributed in terms of arrangements, the logistics and the operation part, to all the industrial partners, those who have involved with us. I request everyone for a applause for them as well. Last but not the least, we expect we would have tried our level best to meet your expectation, and hope these 2 days were valuable. And we'll try to deliver this type of fantastic and fabulous and marvelous conferences and scientific events and scientific meetings in upcoming days. Thank you very much.
There is one medal is pending. The guy who got 10 out of 10 is Dr. Anburajan. So we have Gauri, I feel our medal. Or medal, yeah. Certificate. He is from Stanley Medical College. Empty store. Let them write the name. Thank you. Thank you. So we conclude this, and I wish you all a happy evening. We'll meet again. Thank you. Yeah. Thank you. Oh, no. Sorry, group photo only.
Hey, Rajesh, sorry. Rajesh, வாங்க ராஜேஷ். நீங்க இல்லாமயா? நீங்க வாங்க. ராஜேஷ் கௌரி இல்லாம
ஹோட்டல் இல்லனா எப்படி அப்போ?
அவளை கீழ வந்துடுவா.
கௌரி என்ன கௌரி மறைச்சாரு. கௌரி மறைச்சாரு.
Thank you.
Thank you.